bacimo pitanja i mislio sam, ako hoćeš, da kad ja budem držao tebi dam da prikrviš život.
Poštovane koleginice i kolege, dragi gosti, dobrodošli na prvi koronarni summit. Imam veliku čast i zadovoljstvo da vas sve toplo pozdravim u ime Udruženja kardiovaskularnih hirurga Srbije i u moje lično ime. Tema današnjeg sastanka je koronarna bolest. O značaju koronarne bolesti ne treba trošiti mnogo reči. To je vodeći uzrok morbiditeta i mortaliteta širom sveta, pa i u našoj zemlji. Rasprava, odnosno poređenje raznih modaliteta lečenja koronarne bolesti je predmet debate i diskusije na svim sastancima koji se bave ovom tematikom. Današnji sastanak organizujemo sa Udruženjem kardiologa Srbije, zato što sve dobre, velike, značajne stvari se organizuju zajednički. Pre nego što najavimo naše drage kolege iz regiona, naše poštovane kolege iz inostranstva, ja ću zamoliti profesorku Anastaziju Milosavljević da se obrati skupu u ime Udruženja kardiologa Srbije. Profesorka.
Hvala, profesore. U ime Udruženja kardiologa Srbije pozdravljam organizatore pre svega i sve ovde prisutne kolege i koleginice. Pozdravljam i one koji su nas uvek pomagali, a to su farmaceutske kompanije, bez čije podrške ne bi mogli da realizujemo naše aktivnosti. Da podsjetim, ciljevi Udruženja kardiologa Srbije su među ostalima poboljšati obrazovanje, usavršavanje i trening kardiologa i drugih profila, medicinskih radnika koji se bave kardiovaskularnim bolestima, organizovati samostalno ili u zajednici sa drugim udruženjima ili organizacijama kongrese, stručne skupove, seminare i druge oblike stručnog obrazovanja. Kongres kardio i vaskularnih hirurga je događaj i promocija zdravstva cele Srbije. Član našeg udruženja treba da bude jači ako mi kao organizacija stojimo iza njega i podržavamo njegove ideje i potrebe. U medicini su pojedinci bitni, ali je bez timskog rada nemoguće postići rezultate. Naš zadatak je da učestvujemo u procesu, cilj nam je da zajedno budemo još bolji. I mi, kardiolozi, i vi, hirurzi, ste deo svetske statistike, po tome vidimo da ste odlični. Kardiohirurzi su primjer kako jedna mala zemlja sa nevelikim brojem kardiohirurga postiže svetske uspehe. I to je, kao što ste videli, objavljeno nedavno u Atlas studiji početkom ove godine. Cilj ovakvih skupova je razmena mišljenja, ali i promocija kardiologije i kardiohirurgije. Udruženje kardiologa Srbije će i u buduće podržavati ovakve aktivnosti. Ovakvi događaji budu primjer svima koji žele da unaprede svoje odnose i znanje i na stručnom i na naučnom polju. U nadi da ćemo i u skoroj budućnosti imati mogućnost saradnje i ličnih susreta na ovakvim ili sličnim kongresima, želim vam uspešan rad i hvala lepo što ste me pozvali.
Hvala, profesorka, na ovako divnom obraćanju. Sada ću zamoliti doktora Milana Milojevića, jednog od bitnih ljudi i organizatora ovog sastanka i našeg dragog kolegu koji je zaslužan za dolazak ovakvih eksperata iz polja kardiovaskularne medicine i hirurgije, doktora Milana Milojevića, da pozdravi skup.
Želeo bih zaista svima da se zahvalim što ste došli danas ovde i da se zahvalim Srpskom udruženju za kardiovaskularnu hirurgiju za priliku da učestvujem u organizaciji ovako bitnog skupa. Sada ću se obratiti na engleskom našim dragim gostima iz inostranstva, tako da se izvinjam zbog toga. Dear guests, speakers from abroad, I really would like to thank you for being here today. It's very great pleasure and privilege to have you here in Belgrade. Just for the broader audience, I want to introduce you each of you. We have today the Professor Friedhelm Beyersdorf from the Freiburg in Germany. He's our current president of European Association for Cardiothoracic Surgery. Next to him is sitting Professor Miguel Sousa-Uva from Lisbon, from Portugal. He is the past president of the European Association of Cardiothoracic Surgery. We have also here Professor Sigrid Sandner from University Medical Center in Vienna, and she's the chief of coronary surgery over there, and she's one of the co-program director at the STS Coronary Conference, which is the biggest event in this field that we have currently in the world. And last but not the least, we have a Professor Anders Jeffson. He's coming from the Gothenburg, from the Sweden. He's the past chair of the Committee for Clinical Practice Guidelines at the European Association for Cardiothoracic Surgery, task force members in many other guidelines, but I think that his biggest role is in the leading fantastic Sweden Heart Registry at one of the PI over there, and he's contributed with so much data in this field that it's fantastic to have him today in Belgrade and to share our knowledge with his hard opinions in this field. So I would like to thank you all for being here today. I look forward to fruitful discussion, and that's everything that I have to say at this moment. Thank you very much.
Hvala Milane. Ja ne bih mogao da završim ovu uvodnu reč da se ne zahvalim svim sponzorima koji su omogućili da se ova zamisao ostvari. S tim u vezi bih pozvao predstavnicu kompanije Makler, generalnog sponzora našeg skupa, da vas sada pozdravi.
Poštovane dame i gospodo, uvaženi profesori, dobar dan i dobrodošli na prvi koronarni samit. Velika mi je čast i zadovoljstvo što mogu u ime firme Makler i u svoje ime da vam poželim uspešan samit i da zahvalim organizatorima na ovoj prilici da vam se predstavimo. 30 sekundi je zaista malo da vam predstavimo 30 godina koliko je Makler prisutan na tržištu i u vašim zdravstvenim ustanovama. Ostvarujući izuzetno uspešnu saradnju u laboratorijskoj dijagnostici, hirurgiji, ortopediji, transfuzionoj medicini, a od skoro na naše veliko zadovoljstvo i u oblastima kardiohirurgije i interventne kardiologije, o čemu je ovaj samit i posvećen. Nadam se da će godine pred nama pokazati da smo dostojni saradnici i partneri. Hvala vam.
Još jednom bih vam se zahvalio što ste danas sa nama, što ste došli u ovolikom broju. Ja zaista osjećam veliku radost kada vidim i naše prijatelje iz regiona. Ja moram posebno da ih pozdravim, to su naši prijatelji, profesor Mate Petričević, šef kardiohirurgije iz KBC-a Split. Znate, profesor Saša Radević, profesor Srđan Pavićević i profesor Mugoša iz Kliničko-bolničkog centra Crne Gore, Podgorice. I sa nama će biti i doktor Šokarovski Marijan iz državne kardiohirurgije iz Skoplja, iz Severne Makedonije. Posebno mi je velika čast i zadovoljstvo i želim posebno da pozdravim profesoru Mariju Zdravković, direktora KBC Bežanijska Kosa, što je danas sa nama. Hvala Marija što ste došli. I moram da kažem da ovako značajan veliki sastanak ne bi bilo moguće organizovati bez podrške jednog od najznačajnijih ljudi koji su toliko doprineli u razvoju kardiovaskularne medicine. To je, zahvaljujem se na pristupu, profesoru doktoru Milovanu Bojiću. Naravno, tu su i gosti iz Republike Srpske, profesorka Tamara Preradović. Profesorka Tamara, hvala što ste izdvojili vaše vreme da budete danas sa nama. Želim vam danas uspešan i lep dan. Ja ću sada na engleskom pozvati profesora Beyersdorfa da otvori naš skup. I will kindly ask Professor Beyersdorf, the president of European Society of Cardiothoracic Surgery, to address the audience and to open this meeting. Professor Beyersdorf, please.
Well, thank you very much. First of all, also in the name, of course, of the European Association for Cardiothoracic Surgery, it's our privilege to be here and to be invited by you and by Milan. I know Milan already for many years, and I have to tell you that you can all be proud to have him. He's a fantastic guy. He's absolutely great. He acts almost could not live anymore without him because he has so many functions in the European Association and he has such a deep knowledge and is overall also a very pleasant person. That's not always a combination which you see every time. So that I'm very thankful, first of all, as I said, to be invited. Milan, thank you very much, but also Professor Mićović, thank you very much for the invitation to the summit. As you have written in your invitation, it's the inaugural summit from the Serbian Society for Cardiovascular and Thoracic Surgery, and you choose as a first summit the coronary artery disease, which in my view is perfect. Why is it perfect? Because in the 60s, when cardiac surgery emerged from zero, cardiac surgery was the specialty who treated for the first time diseases that could not be treated before. Okay, so we started with congenital cardiac surgery. All the babies were dying because there was simply no treatment for it. And then in the 60s, we started doing coronary artery bypass grafting. And this was a great step forward to all the patients who were suffering from coronary artery disease. And then, of course, a decade or 2 decades later, alternative techniques were coming up, and this was also very good and for the benefit of the patients, namely PCI. And I know we do have the first cardiologist who has introduced PCI in Serbia. So this was really also very beneficial and positive and great. Now, over the years, we noticed, of course, that there are different mechanisms behind the revascularization by coronary artery bypass grafting and by PCI. As you can see from this nice picture there, coronary artery bypass grafting is directing new blood to the distal part of the coronary vessel. Perfect. PCI is treating the high-grade stenosis. In addition, there are also differences in the recovery rate, for example, of the patients, and so on and so on. So therefore, it's important to have a look at which patient might benefit from which kind of treatment. And that's exactly what you are doing now for the entire day, that you devoted the topic for this meeting to coronary artery disease. And all the specialists know that there are many discussions about the indication for this or for the treatment. And therefore, I'm very happy that you invited all kinds of specialists to have a fruitful discussion, and hopefully tonight at the dinner we all can say that we know much more, that we have solved several problems, and that we can go on in the future. Thank you very much.
Now I would like to invite Professor Ostojić and Professor Beyersdorf and all the panelists from the first session to take their seats, and we should start with the meeting. Thank you very much.
Good morning to everybody. I have to say I'm Miodrag Ostojić, cardiologist from Belgrade, associated with the Institute for Cardiovascular Diseases Dedinje and the Clinic of Cardiology of University Clinical Center in Banja Luka. It is a great privilege and honor to be part of the first coronary summit, and I can say that coronary artery disease was in my focus all my life. And I'm especially happy that it is in coordination with our Society of Cardiologists, thanks to Anastazija, Society of Cardio Surgery, and I'm grateful to Professor Mićović, and also to Milan, Milojević, who is one of my collaborator. We work together in Dedinje and try to conduct some research work. As far as coronary artery disease is concerned, this is killer number one, and I'm happy to say that collaboration between the cardiologists and cardiosurgeons started very intensively in 2010. I was the member of the Task Force 13, which prepared first guidelines for myocardial revascularization jointly, European Society of Cardiology and the European Cardiothoracic Surgery Society. So all meetings like this see is continuation and of this hard work. I'm happy that I'm moderating this meeting with Professor Beyersdorf, who is a very, very important name in world cardiology and cardiosurgery. We had a short discussion, and except that we are all interested for coronary artery disease, we share our appreciation, for example, for stress echocardiography, which was introducing these cardiologists. So with this short thanking to having me here, I would like to announce the first speaker, very, very famous Professor Miguel Sousa-Uva, who was meeting regularly in European Heart House during journal meetings, during guidelines meetings. And this is a really great privilege, Professor Sousa, to have you here. Thank you very much.
Ladies and gentlemen, good morning. First of all, let me say how honored and happy and proud to be here again in Belgrade. I'd like to thank the invitation. It's really an honor to be here. Milan, thank you. You're a friend, you know. Professor Mićović, thank you again for your invitation. It was a pleasure to visit your institute, and I'm really grateful for the huge work that you've been doing. I know that coronary artery disease, as Friedhelm stressed, in Serbia particularly, is still number one killer. And so I think it's really appropriate to bring the discussion of your first Congress on this topic. So I was asked to talk about PCI and CABG. What are the hard facts in 2022? I think this is it. And this, where are the slides? Oh, here. Good. So I have no disclosures. Well, everyone knows that PCI saves lives in myocardial infarction with ST elevation. PCI improves symptoms on top of optimal medical therapy, but PCI has not shown till now that it improves survival in patients with stable coronary artery disease compared with medical therapy. What I'm here to defend, this view, is that in stable multivessel coronary artery disease, and this will be the topic, CABG reduces MACE rates and prolonged survival in stabilized multivessel coronary artery disease. I start with a very large registry, more than almost 190,000 patients from the joint registry of the STS, the surgical, and the American College of Cardiology Foundation. So they merged the two databases, and they managed to follow these patients for a mean follow-up of 4.6 years, if I'm correct. And they used very sophisticated adjustment techniques, propensity score techniques, to adjust, because this is observational data. And what they showed, it was at 1 year there was no significant difference in survival, but at the follow-up you see that the absolute risk reduction of 4.4% in patients whom the final decision of the physicians was the selection of the method of revascularization. And note that 78% of these PCIs were performed with drug-eluting stents. And the curves keep diverging, meaning that the benefit in survival increases with time. A second piece of evidence comes from the Friedhelm trial that included 1,800 patients with diabetes. and that were followed a little bit more than 4 years. At the end of follow-up, the main endpoint, which was a combined endpoint of death, MI, and stroke, also benefits surgical revascularization, with a difference of 9% in risk reduction, and even in mortality reached statistical significance. And this has been achieved with a mix of first and second generation stents. In 2018, Stuart had, and you see here, a second author, Milan Milojević, published in The Lancet this seminal paper, an individual patient meta-analysis, pooled meta-analysis of 11 trials, more than 11,000 patients. The problem is with previous trials that they had not been powered enough to demonstrate any particular impact on mortality. So we have to keep combined endpoints. And this for the first time demonstrated and looked to see if we combine the data, had any influence in favoring one of the two revascularization modalities. And what did these authors find? Well, at the end of the follow-up, it was around 4 years follow-up, there was a significant difference. You see the p-value there that shows a significant improvement in survival. A 20% relative reduction in mortality. You are all aware of the Syntax trial, and these investigators also could contact all the participating centers, and in order to get follow-up, extended follow-up up to 10 years of these patients, and regarding patients with 3-vessel or left main coronary artery disease, and you see that the follow-up was 94% complete, and very important to note. Although at 10 years there was no significant difference found for the whole group, in the 3-vessel disease subgroup, there was a 28% proportion rate of mortality in the PCI group versus 21 after surgical revascularization. Then the hypothesis came out that we were doing too many stents, too many PCIs, and many of them were not useful. So the concept of physiologically driven revascularization was born, and this was the basis for the FAME3 trial, which was selecting patients for PCI just for those with an FFR below 0.8. And the hypothesis was that it was non-inferior to surgical modern techniques using the latest generation stent, the Medtronic Resolute, using the zoterolimab, which is state of the art. And the results showed at 1 year, it's still short follow-up. It was published in 2022, and there will be a session later about this trial, more in detail. But basically, non-inferiority was not met. Then let's go to the left main arena. The Excel trial results at 5 years were published in the New England Journal of Medicine. The conclusion at the 3 years, it was meant to be a non-inferiority trial. However, the authors skipped that objective at the 5 years, was presented as a superiority trial, and in that case, no significant difference was the conclusion of this trial. However, you can note here that there is a huge difference in the first 30 days, and when we look deeper into the details, this difference between the techniques with a much higher rate of events in the surgical group was due to a tailor-made definition of peri-procedural myocardial infarction, and we can come later to this. But then, from then on, and particularly from the first year, 12 months, to the end of the follow-up, the curves keep diverging, and although this did not reach significance, it's due to this difference and to a totally new type of defining peri-procedural myocardial infarction. More or less at the same time, the Noble trial comparing patients treated with PCI versus CABG with left main was published. This was a non-industry sponsored trial, in Nordic countries and the United Kingdom. And you can see here that there was no difference in mortality. However, in MACE, which included repeat revascularization in opposition with the ACCEL trial, showed a significant benefit with a p-value of 0.0002. And finally, to close the left main, there was EACTS took the initiative because of the 2018 guidelines could have been influenced by the controversial results of ACCEL, to gather a group together with ESC and commissioned an independent group to do a patient-level meta-analysis of the trials that are cited here, Syntax, Pre-Combat, ACCEL, and Noble, to see if ACCEL results showing a higher mortality rate with PCI could be confirmed or not. It did not confirm. So there is no significant difference in this pool meta-analysis in mortality. However, please note that spontaneous myocardial infarction, which should be one of the targets of our interventions, because myocardial infarctions can cause death and disabling and worsening left ventricular function, arrhythmias, etc. There is a significant benefit with patients that are revascularized with CABG and a hazard ratio of 2.3. Finally, in stabilized non-STEMI patients, also a pooled analysis of 3 randomized trials, Syntax, BEST, and Pre-Combat, showed, for stabilized, clinical stabilized patients with non-STEMI, which are the majority, because many non-STEMIs are just a rise in troponins. So I must stress that the majority of non-STEMI patients should be taken and should be treated and revascularized as stable coronary artery disease patients. And this shows in here. You see that the combined endpoint of death, MI, stroke benefits the surgical revascularization, and even death in patients in the subgroup of multivessel disease, which are we are concentrated on. It's also significantly favoring the surgical revascularization strategy. And why? Why is this so? Well, it is this slide one of the most important, because more than 80% of myocardial infarctions are due not to significant stenosis, but to non-significant plaques. And where PCI treats these significant ones, particularly if you apply FFR, the CABG collateralizes all vessels and protects against future events in non-significant atherosclerotic plaques. And just to finish, a question mark here is because we are focusing very much in guidelines nowadays. And I've been involved in guidelines for many years at ESC, and I've been chairman of the guidelines committee at EACTS. Are we adhering? So this is a New York cath lab database gathering from, I think, more than 16,000 patients. And the conclusions are not very optimistic. In more than 64% of the cases, the interventional cardiologist was the only source of final recommendation. And see here that the patients who had an indication by the guidelines, the American Heart Association guidelines for CABG, 53% got CABG, but 34% got PCI. And why is this important? This is from Israel database, around 1,000 patients, a survey from the National Revascularization Patients with Complex Coronary Artery Disease. And the final conclusion, his heart team guidelines discordant is associated with increased mortality. See here, when there was discordance with the guidelines, the mortality, not MACE, mortality was significantly higher with a hazard rate of 2 compared with those where the decision was following the guidelines. And you see that in patients, a significant amount of patients with high Syntax score were referred. Of course, they could be high risk for surgery. And I must just focus on the fact that all randomized trials only included patients that were suitable for PCI and CABG, meaning they were low-risk patients. We're not talking about high-risk patients for CABG here. That's why heart team discussion is so important, to select the right treatment modality for each patient. And this is my final slide. why do we have such a huge discrepancy? And this is from the Organization of Economic Cooperation and Development, OECD. And you see in different patients, what is the ratio of PCI versus cabbage? It goes here in Mexico, 0.67, to Spain, where the ratio of PCI over cabbage is almost 9. So something must be wrong, or something is different in each environment where we are working. So, in summary, the evidence for the superiority of cabbage over PCI in stable, operable, multivessel coronary artery disease, including left main, is consistent. It's not new. The more diffuse and severe the lesions, and even more if the patient is a diabetic patient, the more the evidence points to cabbage as the optimal strategy for multivessel coronary artery disease in standard risk patients. While PCI treats only flow-limiting lesions, cabbage confers long-term protection against future myocardial infections from non-significant atherosclerotic plaques. And finally, PCI over cabbage ratio vary widely, and heart team decision-making is a class 1C recommendation in the guidelines, but is still far from widely adopted worldwide. Thank you very much.
Well, Miguel, thank you very much for this, for the demonstration of all the data. And I heard from Milan and from you that we are not having discussion after each topic, because I think it will be better if we just listen to all the presentations and then we have it at the very end. So therefore, it's my pleasure to call Professor Svetlana Apostolović, and she will give us some insight into the famous ischemia trial, which has also generated much discussion. So please.
Your colleague, Professor Beyersdorf, organizer, told me to talk on Serbian, but my slides on English. Okay. Moje ime je Svetlana Apostolović, interventni sam kardiolog i trenutno vodim koronarnu jedinicu klinike za kardiologiju Kliničkog centra Niš. I posle 5 godina od objavljivanja rezultata ishemija studije, vidite stalna debata oko toga kako tumačiti te rezultate. Studija je komparirala optimalnu medicinsku terapiju, odnosno medikalnu terapiju i revaskularizaciju kod pacijenata sa hroničnom koronarnom bolešću. Stalno se pitamo da li je nama ova studija bila potrebna. Mislim, odgovor je jasan, da, bila je potrebna. Da li nam je promenila svakodnevnu kliničku praksu? Za sve one koji se pridržavaju savremenih guidelines u lečenju svojih pacijenata sa stabilnom koronarnom bolešću, nije mnogo uticala na promenu primene, odnosno nije mnogo uticala na strategiju lečenja. Pre objavljivanja rezultata ishemija studije bilo je negde 8 sličnih studija koje su komparirale optimalnu medikalnu terapiju sa revaskularizacijom, međutim značajno su se razlikovale u odnosu na dizajn ishemija studije. Pre svega zbog toga što su sve te studije uključivale pacijente gde je inkluzivni kriterijum su se bazirali na težini angiografskog nalaza, znači kolika je bila stenoza. Ovo je prva studija kod koje su se uključivali pacijenti sa ishemijom koja je umerenog do teškog stepena, gde praktično u samim inkluzivnim kriterijumima lekar nije znao kakav je angiografski nalaz. Izvođeni su neinvazivni testovi detekcije ishemije i svi oni koji su imali zadovoljenje kriterijuma moderate to severe ishemija bili su uključeni u grupu opet koja je podvrgnuta slepom, odnosno centralizovanom čitanju kompjuterizovane tomografije, odnosno kompjuterizovane koronarografije. Isključeni su pacijenti koji su imali left main stenozu i oni koji su bili bez promena na koronarnim arterijama i nakon toga su randomizovani u 2 grupe. Znači grupa koja je išla inicijalno samo optimalna medikamentna terapija i druga grupa koja je pored optimalne medikamentne terapije išla na kateterizaciju i ukoliko je bila pogodno na revaskularizaciju miokarda. bazirano na ekskluzivnim kriterijumima, rezultati ove studije se ne mogu primeniti na one koji imaju bolest glavnog stabla, akutni koronarni sindrom unutar 2 meseca, oni koji su naravno visoko simptomatski pacijenti, zatim oni koji imaju ekcionu frakciju nižu od 35%, isključivani su pacijenti koji imaju glomerulnu filtraciju ispod 30 ml u minuti. Znači, jedna grupa je išla i lečena je konzervativno, pri čemu ta optimalna medikamentna terapija, znači tokom kontrola je praćena, ukoliko je postojao failure optimalne medikamentne terapije i je pacijent imao bolove u grudima koji su bili učestali ili imao neki događaj, ti pacijenti su slati na koronarografiju, odnosno revaskularizaciju. S druge strane, inicijalna invazivna strategija, optimalna medikamentna terapija kao baza, a zatim kardijalna kateterizacija. Anatomija koja je bila pogodna za revaskularizaciju, heart team je odlučivao da li će biti PC ili bypass, pri čemu određeni procenat nije bio pogodan za revaskularizaciju i praktično ispadao iz studije. Na kompjuterizovanoj koronarografiji vidite da je negde oko 77% imalo multivessel disease. Znači, nije se radilo o tako lakim pacijentima. Ako pogledate pacijente koji su bili na konzervativnoj terapiji, tokom vremena, negde skoro 14% je praktično prešlo u grupu gde je došlo do revaskularizacije, odnosno koronarografije, i to svega 4% zbog failera optimalne medikamentne terapije, dok je 8% bilo neadherentno na tu optimalnu medikamentnu terapiju. Prva procedura revaskularizacije u grupi invazivne urađena je u 80% pacijenata, od ostalih 20%, 2/3 znači imalo je nesignifikantnu bolest i nije bilo za revaskularizaciju, a 1/3 je imala takvu ekstenzivnu bolest da nije bila uopšte pogodna za revaskularizaciju. I ako pogledate, PC je urađen u 74%, bypass u 26%. Primarni ishod, znači praćenje nakon 6 meseci i nakon 4 godina, vidite da nije bilo razlike u kardiovaskularnoj smrti, ukupnom infarktu miokarda, hospitalizaciji zbog nestabilne angine, srčanoj slabosti ili restituciji zbog kardijalnog aresta u grupi koja je bila na optimalnoj medikamentnoj u odnosu na grupu koja je odmah išla inicijalno na revaskularizaciju. Ako pogledamo ukupan broj infarkta miokarda, on se nije razlikovao među ove dve grupe, ali ako sada to raščlanimo, vidjet ćemo da grupa koja je bila inicijalno invazivno rešavana je imala značajno manji broj spontanih infarkta miokarda nakon 4 godine, odnosno 5, u odnosu na konzervativnu grupu. Ali opet po cenu toga da je grupa koja je bila invazivno inicijalno rešena imala veći broj periproceduralnih infarkta miokarda. Nije bilo razlike, ako pojedinačno gledamo, u hospitalizaciji zbog nestabilne angine, kao što sam rekla, restitucije, odnosno hospitalizaciji zbog srčane slabosti. I u Barseloni vrlo značajno jedno predavanje, opet je ishemija bila, da kažem, u centru razgovora. I šta smo mi naučili iz ove studije? Kao prvo, kod pacijenata sa stabilnom koronarnom bolešću, koji imaju umerenu do tešku ishemiju, koja je detektovana, znači neinvazivno, odnosno neinvazivnim testovima, sa očuvanom ekcionom frakcijom, rutinska invazivna strategija, komparirana sa inicijalnom konzervativnom strategijom, nije pokazala redukciju mortaliteta. Ali je činjenica da je ovo prva studija koja nam je pokazala da spontani infarkt miokarda tokom godina je bio značajno manji kod osoba koji su bili podvrgnuti revaskularizaciji, ali po cenu veće procenta periproceduralnih infarkta miokarda. Pacijenti koji imaju stabilnu koronarnu bolest, ali umerenu i tešku ishemiju, imaju takođe značajno popravljanje kontrole angine i kvaliteta života u grupi koja je bila na inicijalnoj invazivnoj strategiji. Ono što nam ishemija govori jeste da je prva stvar raditi na faktorima rizika, modifikaciji stila života i na taj način modifikaciji napredovanja uopšte ateroskleroskog procesa i da je optimalna medikamentna terapija cornerstone pacijenata koji imaju stabilnu koronarnu bolest. Ali kod onih gde optimalna medikamentna terapija treba, odnosno ne pokazuje adekvatnu stabilizaciju simptoma, ali i ishemije, treba razmišljati o revaskularizaciji. Interesantno je da pacijenti sa ishemijom na testu su u stvari naši pacijenti, a minimalnim simptomima, koji možemo da kažemo iz svakodnevne prakse, liče na pacijente u ishemija studiji. I treba nekako naći neku meru između svega ovoga, da ništa nije hitno, naročito kod ovih pacijenata ako je test pozitivan. Isto tako da treba da nađemo pravi trenutak kada treba budemo agresivni interventni kardiolozi i opet ponavljam, pre kateterizacije najvažnije optimalna medikamentna terapija. Ako primenimo na svakodnevnu kliničku praksu, vidjet ćemo da nam ishemija praktično obuhvata one pacijente iza koje nismo mnogo sigurni u svakodnevnoj praksi da li bi bili dobri za revaskularizaciju ili da li ti pacijenti, ili možda mi ne bi ušli u proces revaskularizacije, a ovde je praktično randomizacija odredila njihovo mesto. I još jednom ponavljam, ishemija je prva studija koja je pokazala da perkutalna intervencija prevenira infarkt miokarda kod stabilne populacije pacijenata. I bez obzira što se stalno priča o rezultatima ove studije, bez obzira što imamo, da kažemo, mogućnost izbora, naravno da je pristup individualan i da ćemo se uvek pitati da nismo pogrešili. Hvala.
Thank you very much, Professor Apostolović, for this beautiful overview. I would like, I made a mistake that I didn't present our panel with very distinctive experts. And I can say Professor Marija Zdravković from University Clinical Medicine Center Bežanijska Kosa is here. Then we have one change because of a tight schedule of Professor Tamara Kovačević Preradović. She is the Chief of Cardiology in University Clinical Center in Banja Luka. She is my chief, actually, in Banja Luka when I'm there. And then we have Professor Nebojša Tasić, Chief of Scientific Board in Cardiovascular Institute Dedinje. All those were cardiologists, and we have finally Mate Petričević, Chief of Cardiosurgery in Split, Croatia. And that's maybe why the ratio between PCI and cabbage is 4:1 or 3:1. You see the panel number, 2 cardiosurgeons and 4 cardiologists, I'm cardiologists too. So after correcting this first mistake, I would like to call Dr. Boris Džudović to present results of the FAME-3 trial.
Poštovane koleginice i kolege, dragi prijatelji, na početku samo da vam prenesem reči izvinjenja docenta Romanovića koji nije mogao da dođe da vam održi ovo predavanje, tako da ću to učiniti ja. I predstavit ću vam rezultate FAME-3 studije koja je objavljena početkom ove godine. Ja sam dr. Boris Džudović, interventni kardiolog u klinici za urgentnu internu medicinu VMA. Kao što ste mogli da čujete, neke prethodne studije koje su objavljene pre možda više od 10 godina, već su pokazale da postoji određeni benefit kod lečenja pomoću kardiovaskularne hiruške revaskularizacije u odnosu na perkutanu koronarnu intervenciju kod pacijenata sa trosudovnom bolešću. Međutim, u to vreme dosta su korišćeni stentovi koji su tada bili aktuelni, dakle bare metal stentovi ili prva generacija drug-eluting stenta. Takođe, vi znate da je kasnije objavljena i FAME-1 studija koja je pokazala da se procena lezije pomoću FFR-a smatra kao benefit u odnosu na angiografsku procenu, a tada nije korišćen FFR. Tako da je s tim razlogom nastala ova FAME-3 studija koja je postavila hipotezu da FFR-om vođena PCI kod ovih pacijenata sa trosudovnom bolešću, koja ne uključuje, naravno, glavno stablo i te se koriste noviji stentovi, novije generacije, nije inferiorna u odnosu na Kebić. Naravno, tokom jednogodišnjeg MACE-a. Ova studija je multicentrična, randomizovana studija koja je uključila 48 centara širom sveta i vidite da je taj primarni ishod MACE tokom godinu dana bio kompozitni endpoint koji je uključivao ukupnu smrt, infarkt miokarda, moždani udar ili ponovna revaskularizacija. Čekamo rezultate ovih sekundarnih endpointa na 3 i 5 godina i to će biti takođe interesantno. Ovo je definicija infarkta miokarda kao proceduralni ili kao spontani. Dakle, za proceduralni infarkt miokarda uzeta je ona definicija infarkta miokarda tip 5. Dakle, to je porast troponina iznad 99. percentila, odnosno 10 puta iznad gornje referentne vrednosti i jedan od ovih kriterijuma, da li je to EKG kriterijum, novi patološki kuz zubac ili blok leve grane, odnosno angiografska vizualizacija okluzije grafta ili koronarnog krvnog suda ili vizualizacija, imaging vizualizacija regionalnog ispada motiliteta, odnosno viabilnog miokarda. Kad je u pitanju spontani infarkt miokarda, dakle, tu je takođe porast troponina glavni kriterijum, plus jedan od kriterijuma bilo da je to tipični simptom ishemije, EKG promene ili opet vizualizacija, dakle, regionalnog ispada kontraktilnosti ili gubitka motiliteta. Ovo su glavni uključujući i isključujući kriterijumi. Dakle, u ovu studiju ušli su pacijenti koji su imali trosudovnu koronarnu bolest, koja ne uključuje glavno stablo, a lezije su najmanje 50% i sve ove lezije su procenjivane na osnovu, nisu sve procenjivane, nego je Heart Team određivao da li su ovi pacijenti pogodni za obe vrste lečenja, dakle i za PCI i za Kebić. I nakon toga je usledila randomizacija 1:1, a glavni isključujući kriterijumi su kardiogeni šok, skorašnji stemi tokom 5 dana ili ekcijona frakcija ispod 30%. Ovo su glavni proceduralni zahtevi, vidite kako su neki mandatorni, a neki su samo na nivou preporuke. U ovoj grupi gde je PCI, dakle svi pacijenti su morali da budu adekvatno medikamentno pripremljeni, FFR-om su procenjivane lezije, dakle to je FFR-om vođena PCI, bilo da se adenozin daje intrakoronarno ili intravenski. Sve vrednosti FFR-a ispod ili jednako 0,8 su smatrane značajne i tu je plasiran stent, zoterolimu stent. Na nivou preporuka je da se nakon intervencije učini FFR i svi pacijenti su morali biti najmanje 6 meseci na dvojnoj antitrombocitnoj terapiji. Ovde vidite u ovoj Kebić grupi da je mnogo toga malo mandatornoga više na nivou preporuka. Naprimer, FFR nije bio mandatoran, dakle, mogao je da se koristi. Možda je to jedna od limitacija studije. Svi pacijenti savjetovano je da budu na aspirinu i na visokim dozama statina. On ili off-pump hirurgija je bila prihvatljiva, lima kroz svih pacijenata i preporuka da se učini kompletna arterijska revaskularizacija. Dakle, izračunato je da je 1500 pacijenata dovoljno za očekivanu snagu studije, čak i manje, jer su pomerane te margine za hazard ratio, ali je se ostalo pri inicijalnoj proceni od 1500. Vidite, 757 je randomizovan u PCI grupu, 743 u Kebić grupu. Svi oni su ušli u intention to treat analizu. Naravno, uvek dođe do nekog ispadanja, ali obzirom da je napravljen taj višak pacijenata od onog minimalno potrebnog, nije uticalo na snagu studije. Ovo su osnovne karakteristike ovih pacijenata. Vidite da nema razlike između ove dve grupe, ali ono na šta vam skrećem pažnju, što jeste možda isto jedna vrsta limita, jeste da je većina bilo muškaraca bele rase. Znači, to je karakteristika ove studije. Dakle, ovo ostalo možete da vidite iz tabele, da tu zastupljenost faktora rizika i kliničkih nekih karakteristika osnovnih nije postojala razlika. Ovo su proceduralne karakteristike, dakle, neke najvažnije sam vam izdvojio. Procenat lezije koja je u PCI grupi procenjivana na osnovu FFR je 82%. Nisu procenjivane one koje su bile okluzije ili koje su bile subtotalne lezije, dakle nije bilo potrebe za tim. Vidite, oko 24% je imalo FFR preko 0,8. Ovo želim da vam izdvojim, dakle, broj stentova koji je korišćen prosečno 3,7. Ako se sećate, slično nešto u FAME 1 studiji, a u poređenju sa nekim drugim studijama, kao što ćete vidjeti kasnije, sintaks studiji značajno manje, jer sintaks studiji nije korišćen FFR. Totalna dužina stenta 80 mm. Intravaskularni imaging je korišćen u svega 12% slučajeva. To može da bude limitacija, mada se autori ograđuju od toga, bez obzira što su neke studije pokazale da češće korišćen intravaskularni imaging ipak stvara benefit u odnosu na nekorišćenje, ali vidjet ćete posle da možda ta stent tromboza nije bila uopšte tako veća u odnosu na te studije. FFR nakon intervencije je urađen kod 60% pacijenata. Da vidimo Cabbage grupu, pošto FFR nije bio mandatoran, negde oko 10% slučajeva je korišćen za procenu lezije. Multipli arterijski graftovi u 1/4 slučajeva, ali ima naravno u skoro svim slučajevima i off-pump hirurgija negde isto blizu 1/4 pacijenata. Ovo je glavni slajd što se tiče rezultata. Dakle, vidite ove dve linije koje se jasno razdvajaju, hazard ratio, koji pokazuje da je ovaj MACE bio za oko 50% češći u odnosu na Cabbage, odnosno studija zapravo prema hipotezi koju je postavila, pokazala je da FFR-om vođena PCI nije neinferiorna u odnosu na Cabbage. Sad moramo da vidimo malo neke pojedinačne elemente tog MACE-a i kada pogledate zapravo nije nigde postignuto statistički značajnost, iako postoji trend porasta u PCI grupi. Ono što jeste značajno jesu zapravo neke komplikacije koje su doduše i očekivane neke od njih, kao što je recimo bark krvarenje tipa 3 do 5, značajno češće u Cabbage grupi, akutna bubežna slabost, aritmije, ne samo atrijalna fibrilacija i naravno zbog svega toga i rehospitalizacija. Dakle, sve su značajno bile češće u Cabbage grupi. I onda se ipak tu zapitamo pa koji su to pacijenti koji zapravo imaju stvarni benefit. Ovde u ovom grafikonu je uokviren syntax score koji je prosečno u ovoj studiji bio 26, dakle to je neki intermedijarni nivo i jedino je tu postignuta značajnost. Međutim, ako pogledate ovaj grafikon ovde, sve što ne seče ovu liniju je zapravo značajno. Ja bi tu, pored syntax score-a koji je preko 22, dakle kompleksnije lezije imali su apsolutni benefit od kardiohiruške revaskularizacije, odnosno PCI. Ali ja bih tu dodao još nešto, znači ima i više značajnosti, ali iz čisto mnemotehničkih razloga izdvojio sam da su to muškarci, mlađi muškarci, mlađi od 65 godina, dijabetičari. Dakle, oni su sa kompleksnim lezijama, dakle, oni su najbolje prolazili na kardiohirurgiji. Evo, ovo je još jedan prikaz kako se u odnosu na syntax score menjao ishod. Dakle, samo kod manje kompleksnih lezija manji je MACE, odnosno bolje su prolazili pacijenti koji su imali PCI. Dakle, ali u kompleksnijim lezijama preko 22 te krive se značajno izdvajaju u korist Cabbage grupe. Ovo je poređenje, dakle, FAME 3 studije i veoma slične syntax studije prema tom jednogodišnjem ishodu, kompozitnom ishodu, s tim što podsjećam vas da u syntax studiji nije korišćen FFR. Vidite, nije bilo razlike, vrlo su slični bili pacijenti, čak je i taj prosječni syntax score možda nešto viši bio u syntax studiji, ali i dalje spada u onaj intermedijarni nivo. Ali ono što je interesantno i što možda pokazuje koliko se stvari promenilo za ovih 10 i više godina, dakle, vidite u obe grupe, i PCI i Cabbage grupi, u syntax studiji su bile, MACE je bio značajno učestaliji nego u FAME3 grupi. Može tu da se diskutuje, ali već to govori zapravo o promeni možda i tehnike, i materijala, i tehnologije zapravo rada tokom svih ovih godina. Ovo su neke samo od limitacija koje sam već i pomenuo. Dakle, jednogodišnje praćenje je možda relativno kratak period i čekamo one rezultate nakon 3 i nakon 5 godina. FFR-om procenjivane lezije, hemodinamske značajnost lezije nije rađena u Cabbage grupi, nije bila mandatorna. Ne znam da li bi to nešto promenilo, ali ako se sećate FAME2 studije, prvo su obe grupe su bile poređene, pa su onda obe grupe su bile procenjivane sa FFR-om, pa onda poređene. Intravaskularni imaging je korišćen u svega 12% slučajeva, to sam vam već pomenuo da se ograđuju, da je to značajno, ali ipak u današnje vreme značajno više se koristi kod kompleksnih lezija, ne samo kod left main. I ono što, recimo, nije tako nevažno, ne znam da li je namerno ili slučajno izašlo iz analize, ali kvalitet života i kroz onaj KCCQ upitnik i cost-benefit nije analiziran. Ako se sećate u FAME1 studiji je i to uzeto u obzir i tu su rezultati vrlo interesantni. I da rezimiram, dakle, studija je pokazala da kod pacijenata sa trosudovnom koronarnom bolešću bez left maina, FFR vođen na PCI sa trenutnom generacijom drage luting stentova nije neinferiorna u odnosu na Cabbage. Međutim, MACE u ovoj FAME3 studiji je u obe grupe manji nego u studiji, syntax studiji koja je bila pre nešto više od 10 godina. FFR-om vođena PCI je još uvijek preporuka kod pacijenata koji imaju nizak syntax score, dakle koji imaju manje kompleksne lezije i obrnuto, dakle oni koji imaju više kompleksne lezije prema syntax score-u, a ja bih dodao tu i ono što već smo videli, mlađi muškarci sa dijabetesom, imaju benefit od Cabbage-a u odnosu na PCI. Ja samo na kraju želim da pokažem da su se neki naši centri koji su učestvovali u ovoj FAME3 studiji posebno istakli kao top regruteri, posebno, evo vidite, klinički centar u Kragujevcu i klinički centar u Beogradu i oni su doprineli da ova studija bude objavljena u New England Journal of Medicine. Hvala.
Well, thank you very much for giving the results of this FAME3 trial, and now we have heard that there are obviously different patient population in the ischemia trial and the FAME3 trial, and therefore it's only logical that the next talk given by Dr. Dragana Šarenac will look into the question which patient might look like an ischemia patient and which patient might look like a FAME3 patient, almost the same question what we have right now for patients with mitral valvular regurgitation. There are also different studies and one has to see which patient fits into which category, so please.
Poštovane kolege, zaista mi je čast i zadovoljstvo i privilegija da budem ovde među vama i nisam verovala da ću reći, izvinjavam se, ja sam klinički kardiolog. Tako da to za dalje imate u vidu. Ono što smo do sada čuli, možemo možda da rezimiramo sada, vidjet ćete par u stvari slučajeva naših iz prakse, odluke našeg heart tima za srce. Šta je zajedničko za oba dve ove, znači FAME studije i za ischemija studiju, jeste da optimalna medikamentna terapija sama ili u kombinaciji sa angiografski vođenom PCI ima sličan procenat miokardnog infarkta i mortaliteta, za razliku od FFR-om vođene procedure koja ima bolje kardiovaskularne ishode i koja se preporučuje kod bolesnika sa hroničnim koronarnim sindromom, znači kod stabilne angine. Ovdje vidite grafički prikaz preklapanja također, gde FAME-2 studija tokom 5-godišnjeg praćenja pokazala je smanjenje infarkta miokarda kod FFR-om vođene procedure i krive se razilaze nakon 2. godine. Isto se događa i u ishemiji. Nakon 2. godine, vidjeli ste i sada, iako nema statističke značajnosti, ove krive se nakon 2 godine razilaze u korist invazivnog pristupa, a na račun smanjenja spontanog infarkta miokarda. I preporuke za revaskularizaciju se razlikuju. Evropski guidelinesi stavljaju, znači, u klasu 1 indikaciju revaskularizaciju kada je količina ishemičnog miokarda procenjena bilo kojim funkcionalnim testom preko 10%, za razliku od američkih guidelinesa za pravo čudo koje su krenule korak unazad, odnosno kod stabilne angine i stabilnog bolesnika 2B su klasa indikacije. Naravno, sve se ovo odnosi na bolesnike bez značajnog bolesti glavnog stabla i bez značajne simptomatologije. Ono što sada ću da vam izložim je par naših bolesnika. Ovdje vidite bolesnika 68. godište koji ima anginu na veći napor, pozitivan stres eho test i izražen hereditet. Njemu je na sistemu leve koronarne arterije, ali sad ovo ne mogu da ubrzam, vidjet ćete, urađena FFR na lezije gde ima prilično dobro ramificiranu CX, tako da su velike i OM1 i OM3, vidjet ćete LAD. Znači FFR nije značajna, procedura vođena FFR-om, preko 0,8 je cut-off, iako lezije mogu imponovati angiografski značajne. I upravo to kaže FAME-2, odlična negativna prediktivna vrednost ako je cut-off preko 0,8, bez obzira kako imponuju lezije angiografski. Ovo je kao jedan izazov, da kažemo, meta-analiza objavljena grupe doktora, sada na SSC, inače u Heart Journalu, grupa američkih doktora sa ozbiljnih univerziteta, ja ih nisam ovdje pobrojala, koja je uključila 7 trialova na preko 5000 bolesnika i šta su došli do zaključka? Da je FFR-om vođena revaskularizacija bila udružena samo sa manjim brojem implantacije stentova, a da nije bilo značajnog smanjenja rizika od dugoročnih neželjenih događaja. Za razliku od toga imamo real world studiju, također tokom ovog meseca objavljenu, na preko 10.000 bolesnika, gde se jasno vidi korist plava kriva, razilaženje, znači FFR-om vođene procedure u korist, znači smanjenja infarkta miokarda i smrtnosti. Ovaj naš pacijent je 52. godište, ima očuvanu komoru, NSTEMI je imao, ima ozbiljan i polivaskularni bolesnik, ima ovu abdominalnu aortu koju ne želi da operiše u ovom momentu, iako je tako velika, i on je dobio FFR-om vođenu proceduru, stentinanu RCA i po sistemu leve koronarne arterije, ako vidjet ćete kako izgleda i ova LAD, nisu značajne lezije. Znači, FFR, bez obzira na dužinu ove lezije, kako izgleda, pokazao je da lezije nisu značajne, indikovano je dalje praćenje, lečenje lekovima, obzirom da je njegova predikcija dobra. Sljedeća bolesnica je dobila, samo da ako možemo da uključimo i ovaj ako može da se uključi klip. Dobila je, znači, FFR-om vođenu proceduru, neće da se uključi, i pre i post PCI. Jel možete da uključite možda ovaj? Pa dobro. U svakom slučaju, vrlo su značajne lezije na sistemu LAD i RCA, gde je procedura vođena FFR-om i pre i post PCI procedure. I ovde se vidi, znači vidite i FAME2 i ishemija podgrupa revaskularizovanih bolesnika, ovo se odnosi na nefatalni infarkt miokarda, profitira revaskularizacijom. Zanimljivo je post-PCI FFR da ima dobar prognostički značaj, da je indirektno proporcionalan MACE-u, što znači što su veće vrednosti post-PCI FFR-a, to su bolje predikcije, manji su kardiovaskularni događaji. U ovoj studiji vidite da je cut-off prognostički dobar za LAD lezije 0,83, dok je za non-LAD lezije 0,88. I posljednji prikaz našeg veoma teškog bolesnika, 60. godište, koji ima malu količinu ishemije na testu opterećenja, međutim operisan adenokarcinom sa operisanim metastazama u jetri. Njegov koronarografski nalaz izgleda ovako, to je teška višesudovna bolest sa 3 okludirane arterije po sistemu leve koronarne arterije i njemu je indikovan nastavak medikamentne terapije. Zato što ishemija studija, sad sve što smo videli kaže da ovaj čovjek ima goru prognozu zato što ima tešku polivaskularnu bolest, ali njegova se prognoza neće izmeniti ukoliko bude invazivna strategija primenjena tokom 4-godišnjeg praćenja. Ovde moramo da kažemo, istaknemo, ne zato što je kardiohiruški kongres, već zato zaista što je i ishemija studija imala dosta visok procenat hard eventa, bez obzira na primenjenu optimalnu medikamentnu terapiju, iako veliki procenat ljudi nije se ni pridržavao guideline directed terapije. Šta je ono što je važno za kliničke kardiologe, odnosno za nas kod našeg hroničnog bolesnika? Pa da imamo mogućnost izbora i da ne moramo da jurimo u invazivnu proceduru pošto poto. Sada možemo biti relaksirani, da lečimo našeg pacijenta lekovima, znači da ne jurimo, da ga pratimo, jer znamo da on neće imati lošiju prognozu. Ali u svakom slučaju, ukoliko se pogorša, možemo i treba da ga revaskularizujemo. Hvala vam na pažnju.
Hvala Dragani Šarenac na izuzetnom prikazu i dilemama. Prosto upadu u oči thank you very much to Dragana Šarenac for extraordinary case presentations. It's catching eyes, those lesions which would get stents everywhere that had so good FFR. It is almost unbelievable. I think every interventional cardiologist would stent it. But excellent presentation, and we'll have discussion after all presentations. Now it's my honor to announce Professor David Gleiner from Ottawa, Canada, who will have his presentation filmed.
Mr. Chairman, dear colleague, first of all, I would like to thank the association for the privilege of the floor, specifically Slobodan and Milan for this very kind invitation. I've been asked to talk about the fractional flow reserve and the insight of the impact trial. I have nothing to disclose. Already in 1984 in the New England Journal of Medicine, the president of the American Association, Dr. White, was stating that there is a clear need of improved analytical method for the physiologic assessment of coronary angiogram. Why is that? It's mainly because we often misjudge the severity or the non-severity of a lesion by looking at a three-dimensional lesion into a two-dimensional view. In this example, it's very clear to understand that on the left side, we will definitely underestimate the severity of the lesion, while on the other side, on the right side, depending on which view you have of the lesion, you can definitely also underestimate or overestimate the lesion. Moreover, the angiogram does not give you any insight whether the flow is favorable versus unfavorable, or the flow is located versus very diffuse, such as in the right side. The fractional flow reserve is the ratio between the distal pressure and the aortic pressure after and before a clear stenosis. And all the studies around the fractional flow reserve come from this milestone paper from 1996 from the group from Pels and others. They correlate 3 different non-invasive tests, exercise test, thallium test, and the stress echocardiogram, and the fractional flow reserve showing that below a threshold of 0.75, the vast majority of these 3 tests were positive. So if you have a narrowing of 70% and pressure in the aorta of 100%, the drop of pressure is 30, you have a fractional flow reserve of 0.7. The beauty of the FFR is that it will take into account the presence of collateral. For example, if you have a big collateral, then the pressure after the stenosis is only 85, therefore FFR is negative. But more very interestingly for a surgeon is that if there is a scar or a very small runoff, the FFR will also be negative, such as in this example with an FFR of 0.85. So what can we say about the FFR looking at the cardiology world results is that FFR is highly accurate, FFR is lesion specific, FFR has a defined cutoff value. When we look at the DIFFER trial, not standing an FFR negative lesion is safe, and all the FAME trials have shown that treating FFR positive lesion induces outcome. So the problem is that all this is cardiology stenting world. What is it in depth in the bypass surgery world? Well, I think that it's also very interesting and very important to take care of this FFR, because when we look at the FFR trial, in the FAME trial, sorry, the lesion estimated by eyeballing between 50 and 70%, only 65% of these lesions are inducing 65% of these lesions are not inducing a significant physiologic altercation of the flow. So every time you bypass a lesion at 65%, you will have significant competition flow. And we've studied that if you evaluate the drop of pressure in an artery versus in a vein, there is a very significant difference. Veins are not resistive, meaning that if you have 100% millimeters of mercury in the aorta, you will have 100 millimeters of mercury at the end of the vein, and so no competition flow. It's a short graft, non-resistive, no resistance to blood flow. While if you use a mammary, if you have 100 millimeters of mercury in the left subclavian, at the end of the mammary on the LAD or on the circumflex, you will have a significant drop of pressure due to the muscular physiologic component of the artery, and therefore you can have significant competition flow. So if you put this into the context showing that there is a correlation between the flow in the left mammary and the degree of stenosis, if you have a 70% lesion stenosis and you have a negative FFR of 0.89, if you put a vein on the 70% eyeballing lesion, but there is no drop of pressure, you have no competition flow. Why? Because at the end of the vein you have 99 millimeters of mercury, so 99 wins against 89, no competition flow. While you use a mammary, there is a significant drop of pressure, and then the 92 will lose and you will have a high competition flow. So the real question around FFR is, does FFR improve graft patency and does FFR improve clinical outcome? Let's first look at the FFR improved patency. This is the milestone paper from Botman and colleague 2007, where they already find a clear cutoff between 0.8 and 0.7, where the drop of the increase of graft occlusion is clearly shown on the graph. After this, Onda and colleague have looked at the FFR in the left mammary to LAD, and they also find that above 75 there is a clear significant drop of flow compared to below 0.75, and it's the same thing with the rate of systolic reverse flow showing very high competition flow. The higher the FFR is, the more competition flow you will have. So for these reasons, we decided to do the IMPACT trial, which is a prospective angiographic FFR trial. So what we did is we wanted to plan the surgical grafting with full arterial grafting, 2 mammaries in a Y-graft configuration, and correlate the pre-op FFR in this 3-vessel disease and the 6-month post-op angio in order to better understand what would be a clear cutoff to have patent arterial grafting. So this study is only focusing on arterial grafting and comparing the pre-op FFR in all 3-vessel disease versus the 6-month angiographic patency and functionality of the graft. And so we found a clear cutoff of 0.78. As you can see, most of the dots on the left side are functional, while on the right side they are not functional, and the cutoff is 0.70. So when we look at the occluded graph below 0.78 versus above 78, when we look above 78, what is also very interesting is that if you do sequential grafting, you will have much less occlusion than if you do non-sequential grafting. So the first also interesting finding is that sequential grafting helps in terms of decreasing graft occlusion. Now also very interestingly, when we look at the sequential grafting and no sequential grafting, what we found is that if you do not use the sequential grafting technique, but you graft the PDA versus the circumflex, the worst target is always the right coronary artery, specifically the PDA. So to make it simple, and it's very theoretically logical, the longer the graft is, the longer the arterial graft is, the higher the drop of pressure. And it's logical to find that if you go on the inferior wall of the heart, you will have more competition flow leading to more occlusion. So for these reasons, we find a cutoff of 0.78 for the left side of the heart and 0.71 for the right side of the heart when you use arterial grafting. Once again, here I'm not talking about venous grafting, but only arterial. Now, the conclusion was that FFR, but not angiographic stenosis severity, was a predictor for arterial anastomosis patency. And once again, the FFR cutoff is 0.78 for the left side and 0.71. Now, does FFR improve clinical outcome? There's 2 major trials, prospective randomized. First is the Fargo trial, which is angiographic guided versus FFR guided CABG. Endpoint is patency at 6 months and secondary endpoint is MACE. Unfortunately, 75% of the graft were vein, and the result was that there was no difference in patency or MACE. Unfortunately, this trial carries a lot of bias. First of all, it's underpowered. Secondly, 25% of the patients were lost at angiographic follow-up. Third, the study stopped at 58% of the planned enrollment. And fourth, 12% had a clear operative protocol violation. Therefore, it's very difficult to draw any conclusion from this trial due to this significant bias related to the second trial is the Graffiti trial, which is also angiographic guided versus FFR guided CABG. The primary endpoint is patency at 1 year. Secondary endpoint is MACE at 1 year. Unfortunately, here again, 50% of the graft were vein, and they could not find any difference in patency or MACE. Once again, just like the Fargo trial, there is significant bias in this trial. First of all, only 83% of the planned enrollment was performed. 37 were lost at angiographic follow-up at 1 year. And very interestingly and very sadly, 40% of protocol violation in the FFR group were such as 29% of the deferred vessel had an FFR of below 0.8, meaning a significant FFR, and 11% of the bypass vessel had an FFR of above 0.8. And so you can clearly understand that these are very significant bias and it's impossible. So I think that the conclusion that we can say on the FFR and bypass surgery is that today FFR should not be used to decide whether or not we should graft a moderate lesion. However, if you have to take care of a very young patient and you have a 60% lesion on the circumflex or on the RCA, I think that the FFR is very useful in this specific population, young population, because it will allow you to know whether or not you should use an arterial graft. If the FFR on the circumflex is below 0.78, you can use an arterial graft with good results. And if the FFR is below 0.71 on the RCA, you can use an arterial graft with excellent results. I thank you for your attention.
Well, Professor Glenot, that was really very interesting, first of all, to see the results and the data, but I think it was also great that he mentioned all the shortages and the bias in his own study. And the conclusion is very unusual that when you do a study, at the conclusion you say that you should not do it because there are so much bias in there. I think that's fantastic because it only shows that obviously something is there, and we probably have to do, you know, more detailed study in order to look into that. I think we will have a very nice discussion at the end. Is he only with a film or is he online? So we cannot ask him then? No, okay. Well, now the last presentation will be about FFR-guided PCI, and the talk will be given by Dr. Ivan Ilić.
Can I have my slides, please? First, I would like to thank the Serbian Society of Cardiovascular Surgeons for kind invitation to present in this meeting. And I will have a difficult task to defend PCI procedure versus surgical revascularization. These are my potential conflict of interests. And I would start with the patient. This is male, 70 years old, previous inferior ST elevation MI, treated with tenecteplase, that was presented to us with risk factors and modestly decreased LV ejection fraction. And what you can see on these angiograms, there is a practically triple vessel disease. You have a mid-RCA stenosis and proximal circumflex, and you have a bifurcational stenosis at the mid-LAD. And we did some calculations in this patient, and his syntax score for each lesion is like this, and together it adds up to 14, syntax 1. And after calculating syntax 2, we didn't get much clever anymore, because this patient could go easily to surgery or PCI with a relatively acceptable mortality for 4 years. And if we do a surgical risk score, there's a relatively low risk of mortality on CABG. And what we did, we didn't do anything of those. We decided to perform FFR and invasive physiology with CFR measurements, and it turns out that this stenosis is not significant, this one also, and the LAD stenosis was not significant. Then we decided to treat this patient with drugs only. And this is the landmark trial that put us into a physiology mode in PCI, where we changed our perspective from just looking at the angio into measuring the significance of stenosis. I don't have my slides on the screens in the front. But okay, I'll change like this. And this is a landmark trial that enrolled almost more than 1,000 patients, stable coronary artery disease. There are some patients that suffered myocardial infarction previously, but stabilized initially. And this trial tells us that if you do FFR, there's a benefit for your patients regarding MACE, which means death, non-fatal MI, or repeated revascularizations. And from this on, then we started using FFR very much in the cath lab. But after 5 years, it turns out that whether you do angiography or FFR, it doesn't make any difference. But what we have to know, and what I'd like to point out, is that you have to do a quality FFR measurement, which means you know, everyone does FFR in our cath lab, for example, but I don't think that everyone really performs the procedure adequately as it should be done. It's kind of maybe irritating to tell someone you need to zero pressures, you need to use appropriate guiding catheters, you should do equalization properly, but in fact, in order to get proper measurement of lesion significance and severity of stenosis, you need to do a quality FFR measurement. And what we're aiming, since we have a physiology and angiography, we aim to make a complete revascularization, because if we do not do that, then we have an increased death rate and the MACE rate after 5 years. This study shows that if you have residual syntax score after you do revascularization by PCI, then your patient will suffer a MACE rate of almost 59%. And the death rate for that kind of patients will be almost 30%. So we devised some algorithm, what is complete revascularization. We have anatomical one that treats every lesion that is anatomically or visually significant. We have a functional revascularization, which treats every physiologically significant lesion. But we also devised another thing, which is reasonably incomplete revascularization, which means that you will not address every significant lesion, but you will treat every physiologically significant lesion, the one that could cause ischemia in your patient. And this is an important fact, that we're treating patients, we're not treating lesions, and we're not treating stenosis. In the end, your patients need to feel better after the procedure you do. And this is the slide that tells about comparing surgery and PCI in patients with multivessel disease. There's no doubt if your patient has multivessel disease, surgery might be a better option for him. If he has a diabetes, it's the same. But if your patient has an isolated left main disease, this may be a target for PCI. If your patient has lower syntax score, then it could be a target for PCI. And I will afterwards discuss some issues that we have in interpreting FFR procedures. If your patient has a serial stenosis, there's no use putting a pressure sensor in between the stenosis. Why? Because arterial pressure for distal stenosis is a distal pressure of your proximal stenosis, which is not a real pressure that drives blood through that stenosis. What we have is your change in pressure is affected by two physics constants. The one that it treats diameter stenosis and lesion length, and the other one that addresses separation of flow. If you have a large branch on the side and you addressing in FFR of a smaller branch, then it's very important if you have a stenosis in the side branch. So methods to evaluate serial stenosis using invasive physiology, you can perform a manual pullback, which is something that we do relatively often. Also, you can do FFR in both branches, the one that has no stenosis, and also to do FFR in a lesion in the artery that have serial stenosis. And now we've devised resting indices that can be used if you have serial stenosis. And there are algorithms that tell you which of the lesions is more significant before you treat any of them. In the end, if you have to treat one of the lesions, and then you can address the significance of another one. Also in left main disease, downstream stenosis in LAD and the circumflex could influence your FFR measurements. And this is an animal study that shows if you have stenosis in the branch that you're not addressing, your FFR measurement in the left main will be much affected. If you have severe stenosis or complete occlusion of the side branch, then your FFR in the left main might significantly change. in this group of patients, this group of animals, if you have a lesion of left main that has FFR greater than 0.8, if epicardial stenosis downstream is significant, then you probably in 1/5 of a patients would erroneously evaluate left main lesion. So when you're evaluating left main stenosis, you have to be beware of proximal lesions. If the FFR is around borderline 0.8, you need to use additional tools. Use imaging, use morphology to evaluate stenosis. And you have to do a both branches pull back if you want to evaluate the ostia of the side branch. Since knowing atherosclerosis of a distal left main, for example, it's rarely isolated from the ostial lesions of the circ and the LAD. Severe aortic stenosis is another entity that causes problem in FFR evaluation. In severe stenosis of aorta, you have hypertrophy of the myocardium and you have increased pressures in distal circulation due to physiological mechanisms, which means that your coronary flow reserve will be decreased. Your fractional flow reserve will be increased because your PD is greater, and resting indices will not be affected by having severe aortic stenosis. If you treat this patient, then your coronary flow will go up, coronary flow reserve will go up, and your FFR will go down. Your distal pressure will decrease, and the stenosis that seemed insignificant will become significant. This is the study that was done in 30 TAVI patients. When you do TAVI, your FFR value will significantly change, while the resting indices will remain the same. In order to address that, you need to think a hybrid procedure. Do TAVI or aortic valve replacement, and then afterwards address coronary artery disease, if it's not critical. And this is an algorithm that was presented for TAVI patients by Aleksandrić and his associates very recently. If you have a patient that have severe aortic stenosis, you may do IFR, which is resting index of coronary stenosis significance. If those values are low, then you treat these lesions before your TAVI procedures. If the resting indices are around 83 to 93, then you can safely perform TAVI and then further address coronary artery disease. And something else that is very important when we do FFR, we know that we address every lesion on the way, like continuous wave Doppler in echocardiography, for example. And if you have a focal disease, it's relatively easy. You do resting indices pull back, and then you can see that your lesion is significant or not. But if you have multiple lesions, then you will not be probably able to address properly lesion significance. So the group from Collet devised an index that is called pullback pressure gradient index, which can tell you if your lesion is focal or diffuse. In knowing that, then you know that if you treat focal lesion, then you may help your patients. But if you treat diffuse disease, you will probably have your patients with angina after PCI. So if your PPG index is high, then you have a focal disease and it's safely to treat the lesion. On the other hand, if your PPG index is low, your patient is having a diffuse disease and he would probably not benefit from revascularization. And in the end, what I think we have to do is have an individualized approach to every patient. We need to use tools to support PCI, meaning imaging and invasive coronary physiology. You need to watch for game changers, which is diabetes, left main disease, and very high syntax score. In order for us to compete with surgeons, if we can at all, because they're grafting the artery and they're treating morphology and physiology all in one, we need to combine physiology use, which means FFR, and morphology, which is imaging, OCT, and IVUS, to better address the lesions and to perform better revascularization procedure. Thank you for your time.
Well, thank you very much for all of these presentations, and now we start the discussion. And if I just may ask Miguel, because it's a general question. You have shown to us that there is a tremendous difference in the strategy of revascularization using bypass grafting and PCI, and you showed us a slide where one could see that most of the myocardial infarctions are being generated by low-grade stenosis. And maybe before we go on and discuss more between CABG and PCI, could you elaborate upon the different mechanisms of revascularization by CABG, low-flow, low-grade, high-grade stenosis versus PCI, only high-grade stenosis?
Yeah, thank you. Thank you, Friedhelm. Yes, this is a key question, and there is a great amount of matter that we still don't know, and we must confess and be humble about I think we know the tip of the iceberg, but there are more unknowns than knowns. Having said this, I have the feeling, as I get older, and I
never get older.
Never. That we are in a space of changing. I'm changing my mind. I'm less and less convinced that ischemia is the main target. I think it's the anatomy that is the point. And by saying this, and here we have been influenced by a study by Assoc, which was an observational study with 10,000 patients, saying that above 10% of ischemia, you should revascularize because it has an impact. But this study has huge drawbacks, is observational, etc., etc. On the other hand, I think that the diffuseness of the disease, as we have seen, is that's what is important, even if it's not significant. I'm not talking for symptoms. Of course, PCI is excellent for symptoms in addition to optimal medical treatment, because if the patient is reduced quality of life, you do a PCI, is great, okay? But another issue is MACE, myocardial infarction. And what is the cause of death in coronary disease? It's myocardial infarction and other events like strokes, etc. So in that space, medical therapy is the emperor. And we have to say that CABG has the advantage, there are studies showing that the unstable plaques, even if they are 20%, 30%, can destabilize, can rupture, and be the cause of severe acute myocardial infarction without collateralization. Patients with coronary disease that develop slowly, they have the time to establish collateral disease, and those don't die. We are treating those because they have lots of stenosis and we are putting stents or graft. But the patients who are dangerous are those young patients who come to the cath lab with acute ST elevation coronary syndromes, and the PCI saves their lives. On the other hand, we are talking about stable coronary artery disease, total different animal. And in those cases, we have to focus. What is our objective? Is it improving quality of life, symptoms, or is it improving prevention of myocardial infarction and eventual death because of those myocardial infarction? And in those cases, I think we have to keep in mind that it's a common multidisciplinary decision, an individualized decision, depending on the risk of the patient for surgery, on his wishes, on life expectancy, more than age, because age cutoffs doesn't mean nothing, as we know for TAVI versus SAVA discussions. The same applies for PCI versus CABG. So depending on all of that, I think that's the importance of a multidisciplinary decision making for the choice of revascularization. Thank you.
Thank you very much.
I would just like to tell you that I am a believer in coronary artery bypass surgery. My father has bypass surgery at the age of 60 and died at 93. But I have a patient who had a POBA at the age of 42, and he has to be 100 years in 1 month. So it is individual. So let me remind that in BARI 2 study, patients who were in registry, PCI had excellent result, And mortality was smaller than in cabbage arm. When it was adjusted, it was the same. So it is important to pick up the right patients. And that's why the heart team is important. That's why the experience and expertise of each individual center is very important. It's not the surgery same in Dedinje, where it's a top surgery, or in some centers somewhere else, or in Houston, Texas, or Mayo Clinic. So that is very important that you have individual statistics. When you go and look some clinics in London, you have individual surgeon can pick up what is mortality rate for him for bypass, for aortic valve, mitral valve repair. And that is something that we have to take into account, not just to translate assert from present match cohorts, which has many shortcomings. You know, I was present at SCAI meeting when president of SCAI said ASSERT registry was a registry where cardiosurgeons refused to operate, and then was done PCI, and that's why PCI was more than cardiosurgery. You cannot read that in the manuscript, but when you go and listen live lectures like here, then you hear something behind the stage, which is not so easily heard. But anyway, your talk was outstanding. I shoot some slides because I didn't collect all of them. I have a lot of them, but not very nice slide that you showed. Okay, is there any other comment from the panel?
You would like to make a comment, and then you come.
I have talked to Professor Beyersdorf. First, congratulations to Professor Mićović, bringing back cardiosurgery in a great style in Serbia, and that is very nice. Professor Beyersdorf, I am a German student. I learned in Leipzig and then at Charité cardiomagnetic resonance. We have talked a little bit during these very nice presentations. I would just ask you, we talk here about ideal patient, but what is going on when we have patient with some question about viability, and how frequently do you use cardiomagnetic resonance in your praxis of cardiosurgeon to estimate whether to do the patient or not? Thank you.
Well, I will answer very shortly, and then we will give the question to the presenters. So, actually, the current practice right now is that we try to discuss the patients individually in a heart team. And you hear already what I'm saying. I say we try, which means we do only 10% or even less. All the other patients are being decided upon only by eyeballing the coronary angiography, and we just learned FFR and everything is much better. And only a very small percentage of the patients are coming into the heart team conference where you can discuss this and that and so on. So therefore, at least in Germany, we are lacking far behind what is written in the guidelines. And this also creates, of course, many discussions, which in my view could be avoided by really sitting together. I heard from Milan and from you that you're doing this every day here in this clinic, which is fantastic, because my absolute conviction is, as Miguel also said, it's an individual process. The technique of revascularization is completely different. And you have advantages and disadvantages to both treatments. The big advantage for PCI is that peri-procedural speaking, you have only a little bit of a drop, only a little bit. They go home next morning or whatever. Whereas after surgery, you do have a little bit peri-procedural drop. And now, and this is the new thing, we are working like crazy on getting this peri-procedural drop treated or prevented. Because if this could be prevented, this would be a huge advantage to surgery, because the technique itself, I'm only talking about the technique, is better with the bypass grafting because you're getting the low-grade, high-grade, middle-grade stenosis. But our early post-operative period needs some improvement. So today we do need heart team approach, we should discuss about the patients, especially because we now know that even PCI is not always superior to optimal medical therapy, and this is counterintuitive, I have to say. I mean, when I see a high-grade stenosis, I say, well, I'm in danger, you know, I have to do something. But obviously, this is not right. Please.
Okay, it's working. I would like just to make one very interesting comment and then maybe ask an interesting question to our surgeons. Actually, I worked 20 years in invasive cardiology. Currently, I am in the position of a director of the Center for Preventive Cardiology in the Cardiovascular Institute Dedinje. This is my personal choice, and I want to actually reply to Professor Ostojić. I am not a believer either in PCR or CABG. I will explain you why. We are talking about the MACEs, how to prevent myocardial infarction, MACEs. But you know, we are missing maybe the most important issue and point, and this is, we are not following the patient after both procedures, PCI and CABG, properly. We are not looking to the risk factors, his ways of life. So we are not actually, when we are speaking about the heart team, Dragana Šarenac is here as a clinical doctor. So I think it's obligatory, if we want to prevent MACE, to establish a very, very precise follow-up of those patients. Not just optimize medical therapy, but optimize non-pharmacological therapy if we want to achieve the main goal. I think we are missing there. Why? I really did a lot of PCIs and other procedures in the last 20 years. We are all about the stenosis, all about ischemia. But endothelial dysfunction is the key issue, because everything starts from there and finishes there. And so I will stop here. I would like to ask your opinion about that, because I think we heard a lot of numbers. Even the invasive cardiologists and both surgeons, we are talking about the procedures, and we are doing those procedures in an excellent manner. But I think we should change the whole approach in order to be much better, more efficient to the patient, because I think this is the most important issue. Thank you.
I cannot agree more with you. I can agree 100% with you. The problem is much more difficult to implement, because it's health policies, national health policies. It starts with prevention, the way you eat, the way you exercise, the way you stop smoking and lose weight and exercise, etc. As you said, endothelium is the key. And it's easier to do a CABG or PCI than to have a plan for the whole life of the patient. It needs money, support from the authorities. People in my country, 10 million people, 1.5 million don't have primary physicians. They have nobody. So what's the result? They go to the emergency department with myocardial infarction. So it's a huge problem.
So please one comment.
Now it works. Now it works. Okay, thank you very much. I'm really privileged to be a part of this inaugural, coronary summit. I would like to first of all thank you, of course, Professor Mićović and the whole institute, not just for being here today, but for brilliant cooperation with my institution, Clinical Center in Banja Luka. Thank you from the bottom of my heart. Well, I would just add to the previous comment, which is actually when you talked about these small lesions, let's say 20-30%, and the concept of stable or unstable patient, or stable or unstable coronary plaque, which we do not know. And even when we do a lot of tests, we are at the school of Professor Ostojić, and we really perform a lot of stress tests. But the key point I dare to say is actually to keep in mind all the risk factors and all the actually very modern medical therapy, which we should probably use much more in everyday clinical practice in order to some sort of convert those unstable patients, so-called, to more stable. But we actually do not know. And even in a heart team, if we do not have a different specialties, not just surgeons, not just interventionalists, not just general cardiologists, but in order to compose all these factors and all the mechanisms that we have to influence, not just technique of PCI or CABG, but all these pathophysiological mechanisms, we won't be sure what we do. And the result would not be afterwards, after 6 months or 1 year, not because we did PCI and we should have done CABG or vice versa, but we did not control our patients in a proper way in order to make them so-called stable, or those plaques to make them a little bit more stable. Just about the concept of stable or unstable plaque or patient. Thank you.
Just one brief comment, if you... just one brief comment. First of all, thank you, Slobodan, and thank you, Milan, for inviting me here. I work as a cardiac surgeon, chief of department at the University Hospital Center, Split, the second largest center in Republic of Croatia. So everything matters. When it comes to outcomes, everything matters. And what Professor Ostojić said, it's always the question about the center that does some kind of procedures. So everything that we concluded right now stands for the centers where we work, but we need to spread our message to the small volume centers. When we talk about coronary artery surgery, we are not balanced in terms of the standard of care. So if we, what Professor Beyersdorf mentioned, we need a fast tracking system. I used to work in Australia, Melbourne, Slobodan was there as well, and before that I had experience from the States. So the fast tracking optimizes outcomes. We need to improve our perioperative care. We need to stick to guidelines in coronary artery revascularization strategies to achieve the best possible results. So for every single center in this entire region, we need to have HRT meetings at least once a week, and we need to have mortality morbidity seminars. So we need to learn from our mistakes. So if patient dies, we need to analyze why did that happen. So what can we do to improve that? Do we have good perioperative care? Do we pay attention to the pre-op medications? Do we pay attention to patient blood management? Because every single detail matters in type of surgery where you expect less than 2% of mortality rate. So I would say, in general, I completely agree with all of you, but we need to spread that message to each and every center in this region, and the more important for the particular small centers.
Milan Milojević.
Yeah. I have one comment. First of all, thank you, Professor Tasić, for your excellent comments. I'm often giving talk about the importance of secondary prevention measures after cardiac surgery, and always emphasizing how much I'm disappointed with the results of the current landmark clinical trials. So we discussed the Excel, we discussed the Noble, we discussed the Syntax trial, but the rate of the guideline-directed medical therapies over there range from 30 to 80%. So that means 1 in the 5 patients is not treated well. So we were not able to study what is the real difference between the PCI and the CABG, those patients who are the optimally medically treated. And that's something important that we need to obtain in the near future. And I'm happy because that reminds us all to go to the basics, to go to the medical schools, that we change the terminology, and it's not a stable coronary artery disease anymore. It's a chronic coronary syndrome, which reminds us that this is the chronic process. So we are, once when the patient undergo CABG and PCI, the story is not end, it's continuing. So it reminds us that this is chronic disease, that we should carefully follow all patients, and we should provide them the best possible care. Thank you.
Yeah, Milan, in Europe, we call that chronic ischemic heart disease. Americans call that stable ischemic heart disease. So we have a right terminology in Europe, but they call that different.
Yeah. So yeah, ESC has adopted a new terminology for stable.
And we say myocardial revascularization, and they say coronary artery revascularization.
Yep.
In Task Force 13, we said You are not putting bypass on vasa vasorum of coronary artery, which means coronary artery. So the terminology somehow I think is much better in Europe than in the United States.
They need to think about the payment. I think that their terminology has a lot of relationship with the payers. So, yes.
But Milan, your argument is very well taken. Very often the patient is operated upon and then it's finished. So he goes home, he is healthy, everything is perfect, that's it. But Professor Anders Jepsen has made some studies about this, and maybe Anders, you want to just add what you have found in Sweden.
First of all, I want to make a comment on the discussion about heart teams. We have daily heart teams at our center, but the problem is that the cardiologists are not presenting every patient. I think every patient is worth a discussion. We should avoid ad hoc PCI in patients with multivessel disease. We should discuss those patients and give, for the benefit of the patients. I think that is important. That is something we have to tell the administrators of the hospital, that this could be a very expensive solution by doing ad hoc PCI instead of CABG in some of these patients. I also completely agree with the lifetime management of these patients. We know from all studies that surgical patients are less well taken care of after the operation than they are than PCI patients. And finally, about your questions, Friedhelm, it's quite clear from observational data, we have data from like 35,000 patients in the Swedish registries, that all CABG patients should be treated with antiplatelet therapy. They should be treated with statins. That is probably the most important drug, and they should be lifelong. They should also probably be treated with ACE inhibitors independently if they are having had a myocardial infarction or reduced EF. So I think there's a lot to do here for all of us to keep the patients on optimal therapy. And I think one of the problems, at least in my country, is that the cardiologists, they know this, but they see a CABG patient only once afterward. After that, they are referred to the general practitioners, and they don't know, and it's very, very difficult to reach them, at least in my country. But on the other hand, we should be, as surgeons or cardiologists, we should be sure that they have the right medication when they leave the hospital. Because they will not get it when they are coming to general practitioners. So at least we have to have checklists and so on, so that we are treating them right when they leave. Thank you very much.
Professor Miodrag Perić, former chief of cardiac surgery at Edinje, he has a patient who is now more than 20 years alive after heart transplant that he did.
Which is not the subject of this meeting anyway. If there is any time left, I would like just a couple of comments. First of all, I would like to address the lecture from David Glinar. Years ago, Tatulis showed that if you would like to put an arterial graft on the left side system, the FFR should be below 0.76. Everybody was amazed by that. You know, what was going on now? Why 0.76, not 0.8? And then he says, even more, if you want to put it to the right system, this FFR should be 0.65. And Glinar said 0.71. It's pretty much the same. We don't think about it, particularly in the era of the trend for a complete or multiple arterial revascularization. That's one comment. The other one is regarding what we are doing for our patients after we did something for them, or what do they do for themselves after we did something for them. You know, they do nothing. You know, I'm like 40 years around, and I have a feeling that it is a little bit changing lately. That's just the feeling that patients are taking more care about themselves than they used to do years ago. I don't know if you know the fact that 50% of the patients in the United Kingdom start smoking again after the revasc. They start smoking again after the CABG. You know, 50%, not 5%, 50%. So that's a general, it's a human, I think that's a human, how to say, nature, you know, to when they feel well, they start doing whatever they were doing before they had an MI or something frightening, you know. So the patients, usually in my country, and I heard it many times, you know, I let them crack my chest what they want me to do more. Now I'm going to do whatever I want to do because I did everything what I can do for myself, which of course is not true. So we have to talk to them more, and I think that they are interested more in their disease last several years than they used to do 30 years or 20 years ago, which is good. And I think that, and that's the slide that impressed me very much. It's syntax and fame. You know, MACE and mortality in one and the other study. Why it is almost twice as low? I think because we understand better what we should do about with patients after we did something for them, and they do understand that more. Thank you.
Okay, is there anybody else who from auditorium who would like to comment or put a question for the first talk, which is a big overview? If not, maybe we go to the next talk, my favorite, the results of ischemia time.
Okay, thank you very much, and we reconvene after the necessary coffee break. Then they were all tired.
I have a plan. I have tomorrow a talk in Bosnia.
Yeah, okay. Oh, yeah, all right.
And in Montenegro.
Yeah, right.
So,
yeah.
But you know, just to tell you, I don't believe in ischemia.
Okay, thank you very much. Email in preparation of this meeting was sent to everybody that the talk should be in Serbian and slides in English, so I will continue in our domestic languages if it's not a problem with our guests. So, thank you very much. Hvala vam lepo što ste došli i hvala lepo na pozivu profesoru Mićoviću, hvala mnogo. Ja sam razgovarao sa profesorom Otaševićem još u maju mesecu za ovo kratko izlaganje. Ja ću biti vrlo kratak, ali blago provokativan, mada video sam u prethodnoj sesiji da se praktično sve pomenulo, ali ajde da ispoštujemo priču. Pre svega, poštovane koleginice i kolege, uvaženi predsjedavajući, kao što vidite, tema je bila bypass, ali malo je prošireno bypass i višesudovna koronarna bolest, CABG, odnosno bypass versus PCI. O tome se dosta sada zna, ali mala provokacija je vezana praktično za mesto pacijenta u svemu ovome. I mi uvek govorimo o heart teamu, ali tako, mi u četvrtkom imamo naš konzilijum u 7 ujutro gde razmatramo pacijente, uglavnom je diskusija između PCI-a i bypassa. Ne prezentuju se baš svi pacijenti kao što je bilo rečeno, oni koji su jasni se ne prezentuju, ali se prezentuju oni gde možemo da diskutujemo, tu su uvek i anesteziolozi, ne samo kardiohirurzi, imaging naš deo i praktično svi presenting doktori koji treba da prezentuju pacijente, s tim što se pripremaju slajdovi, tako da je to prilično ekstenzivno. Ono što mi zaboravljamo u ovom heart teamu je da je u suštini, pored nas koji tamo sedimo, pacijent je u centru u suštini, on ne učestvuje u heart teamu, ali treba da bude u centru i mi njemu treba da prezentujemo naše podatke, do čega smo mi došli i da mu objasnimo na osnovu kojih činjenica mi predlažemo neko dalje lečenje. Tako da je to suština, da pacijent treba da bude u centru i mi smatramo da ako postoji određeni broj podataka i postoji nekakva ravnoteža u tome kako treba lečiti našeg pacijenta, mi u suštini treba da mu prezentujemo to i da mu kažemo da može da izabere ukoliko je razuman i normalno kognitivne funkcije. Tako da na kraju pacijent, kada je ravnoteža, kad je equipoise, treba da izabere svoj način lečenja. Dakle, ono što smo već čuli, što se zna, pacijenti naši žele da žive duže, žele da žive bolje i u tom smislu možemo svašta nešto da im predložimo. I postavlja se u suštini pitanje zašto ti rezultati studija i onoga čega nalazimo variraju između PCI-a i bypassa u današnje vreme i gde je tu razlika? U suštini left main je, veliki su, to svi znamo, i da se PCI vrlo lako radi, to ne treba izmišljati, uglavnom su lezije kratke i jedan prilično iskusan operator to može vrlo brzo da uradi, znači ako lezija kratka, ako ne se ne uradi bifurkacija sa potom i sa ajvusom, otprilike to je do pola sata koža. S tim što su male komplikacije u smislu tromboze, infarkta i restenoze, to treba znati. Naravno, syntax score, koji mi svi koristimo, koji je izašao iz syntax studija i tako dalje, tako George Janos i naši prijatelji, često precenjuje značaj left maina, pogotovo kad je trifurkacija ili bifurkacija uhvaćena i kada je to medina 1.1, samo left main, ako je izolovana lezija, može biti preko 20 u sintaksu, tako da treba o tome voditi računa. Međutim, multivessel disease, odnosno višesudovna bolest, je kompleksnija stvar i sa tehničkog aspekta i naravno povezana je sa većim stepenom i tromboze, infarkta i restenoze, znači kompleksnija je za rad i obično duže traje, pogotovo ako su sva 3 suda, ako imate 6-7 stentova, ako je uključena neka bifurkacija, to traje dosta. Dakle, gde smo sada? Prvo, pacijenti žele da žive duže, znači mortalitet, to ste već pominjali, znači samo za left main, čuvena i svakako by far, kako se kaže, najbolja meta-analiza koja postoji, to je Mark Sabatini, oprostite, 4 velike studije sa 4400 pacijenata, svi znamo koji su to studije, tako Syntax, Pre-Combat, Noble i Excel. I koautori su vrlo interesantni, tu vam je senior autor je Eugene Brauwald, znači preko 90 godina, prošle godine je to publikovano sa sve Greg Stoneom, sa sve Kapeteinom i tako dalje i tako dalje. I vidite da u principu nema značajnosti, sad to se valjda vidi ovde, je tako, između ovom ukupnom mortalitetu kada je u pitanju bypass i PCI, s tim što je razlika 0,9, skoro 1% u apsolutnim procentnim vrednostima, tako da na kraju krajeva posle 5 godina praćenja nema neke razlike što se tiče ukupnog mortaliteta. Kada se pogledaju 2 studije, one prve, a to su Syntax i Pre-Combat, kad se pogleda 10-godišnje praćenje, te krive se na kraju sustiču ovde. Razlika je samo 0,5% mortalitetu, ali to je na 10 godina, to je 0,02% na godinu, to je jako, jako malo. Dalje, kada se napravi taj takozvana spline ili spleen analiza, u toj publikaciji, kada pogledate, znači, kardiovaskularni mortalitet, znači, pacijenti žele da žive duže, odnosno na Syntax score, koji je ovde dole na abscisi, na ordinati je taj hazard ratio za CEBG i za PCI. Kad pogledate gde je presek na 33, ovo su intervali poverenja, ali tako, i u principu do skora 33 je potpuna ravnoteža u ishodu lečenja kada generalno gledate sve ove 4 randomizovane studije, znači randomizovane gde su pacijenti mečovani, pa je statistika adekvatna. Tek kada pređe 45, bypass je bolji, znači interval poverenja prelazi gore. Između imamo neke stvari gde su intervali poverenja, još uvek nema statističke značajnosti, ali postoji taj neki trend da je bypass operacija kod ovih pacijenata bolje. Što se tiče moždanog udara, svi znamo da nakon prve godine je moždani udar nakon operacije, u principu prve godine statistički značajno češći nakon bypass operacije. To je poznata stvar, ali kako vreme odmiče, bolest ima svoj prirodni tok. Koliko god mi radili revaskularizacije, koliko god uticali, ona ima svoj tok i na kraju se ti moždani udari dolaze samo 0,4 razlike, to je 28 versus 42 događaja, a ovde je 13 versus 35. I to je uglavnom zbog Noble studije gde je stroke bio neobjašnjivo relativno visok u odnosu na sve ostale 3 studije. Što se tiče višesudovne bolesti, ovde je priča nešto druga, vidio sam da je Ivan pokazao već ove slajdove, ali kratko ću samo, znači mortalitet višesudovna PCI versus bypass, ovo je čuvena publikacija Heda i saradnika 2018. opet meta-analiza, ja se neću pozivati na pojedinačne studije, ali ovo je deo, ovde je bilo 11 studija, a ovo je 8 studija koje su imale multivessel disease, znači i to je 7000 pacijenata, razlika je značajna, negde skoro pa 3% na 5 godina, 7 randomizovanih studija. Ali to je 2017. ali 18. već smo tada imali te rezultate, prosto nema ničeg što bi nas tu promenilo i to je poznata priča da su dijabetičari jako ugroženi kad se napravila subanaliza. Razlika je u suštini proizašla iz ovoga, iz razlike kod dijabetičara 10 versus 15,5, znači mortalitet je značajno, znači 5-godišnji u korist pacijenata koji su operisani versus PCI. Kod ostalih nema razlike, ali ono što je interesantno opet je i tu razlika u učestalosti moždanog udara, pre svega, ali tako, kod pacijenata koji su bili na bypassu, odnosno na PCI. Dakle, to malo vraća ovaj rezultat, ali ukupno, definitivno, kod dijabetičara mi danas više nemamo dilemu, mada i tu možemo pojedinačno da razgovaramo o pojedinim slučajima. Kako interpretirati ove rezultate? To je sada jedna onako malo filozofski pristup. 3% razlike na 5 godina kad podelite 0,6% godišnje. To znači negde na 180 lečenih vam jedan strada više ako ne ide na bypass nego na PCI. To je ovako univerzalno gledano, ali 91 versus 78 je praktično razlika u mortalitetu na 5 godina i to znači da kako god ih lečite, bilo PCI, bilo bypass, 9 ljudi od 100 će umreti za 5 godina. Preostalih 3 će stradati ako idu na PCI, ostali će proći dobro. Znači, to je neka onako malo filozofska interpretacija, ali ostaju mnogi drugi endpointi studija koji su jako, jako važni. To je periproceduralni infarkt, to je neproceduralni infarkt, to je dispneja, odnosno srčana insuficijencija, to je infekcija, renalna disfunkcija, atrialna fibrilacija, komplikacije vaskularnog tipa, velika krvarenja, ponovna angina, bolovi u grudima, ponove vaskularizacije, rehospitalizacije, znači kognitivna funkcija, depresija koja je vrlo važna, imam i slajd o depresiji, ja sam izbacio praktično da bi bilo u vremenu i vreme do oporavka, opet pacijenti gledaju neke druge stvari, ne samo to. Dakle, pored mortaliteta i da žele da žive duže, žele da žive i bolje. Znači, to je quality of life, to je sad druga priča, kao što znate, mi smo imali jednu studiju koja se sada prilično citira vezana za CTO i baš smo zadovoljni, eto da vam kažem, da veliki autori nas trenutno citiraju, mi smo s toj tačke vrlo, vrlo srećni, ali kada se gleda quality of life, to nije tako jednostavna studija, znači Seattle Angina Questionnaire, samo ko je radio zna kako se to računa, to je stvarno dosta kompleksno. Da li se razlikuje, znači, kvalitet života PCI versus CABG? Imamo, znači, quality of life rađeno syntax studij na 1800 pacijenata i ovo su, znači, domeni Seattle Angina Questionnaire-a, bilo da je angina frekvencija, bilo da je fizička limitacija, bilo da je zadovoljstvo lečenjem ili ukupan kvalitet života. Samo ovde postoji razlika u korist PCI-a u prvih 6 meseci, da je kvalitet života bolji, posle se praktično te krive preklapaju. Iako je statistika malo drugačija, ali se krive preklapaju. U Excelu takođe je rađen kvalitet života, isto, naravno, Seattle Angina Questionnaire i kao što vidite, sva 4 domena, ovde jedino u fizičkoj ograničenju prvih godinu dana postoji prednost PCI u odnosu na bypass, što je potpuno logično, to je ovde prikazano i plastičnije, naravno, na prvih mesec dana jako, onda se to postepeno smanjuje do godinu dana, da se ne izjednače praktično krive u kvalitetu života. Kada pogledate Excel studiju i njene takozvane major adverse events unutar 30 dana, znači u toku hospitalizacije, ovo je bilo koji major adverse events, 12,4 na PCI-u, CABG 44. Znači, signifikantno. Naravno, veliki događaj, to smo već pričali, ali sve ostalo, kad pogledate dole, bilo krvarenja, revaskularizacija zbog ishemije, transfuzija, sve je nekako u korist PCI-a, velike aritmije i tako dalje, bubrežna insuficijencija češće nakon bypassa, infekcije, naravno, koje zahteva antibiotike, su češće nakon operacije. Znači, sve nekako ti manji endpointi su u korist PCI-a. Dakle, imamo jasne izbore i imamo izbore kada je ravnoteža. Ovde u ovom slučaju, ovo možda i spazam, ajde da kažemo da ali možda je i prava bolest. Ako dokažemo da je prava bolest ostijalni left main, ovo je procedura od 20 minuta, jedan stent koji malo viri u aortu i to nije nikakav problem. Ovde, kad pacijent ima stenozu left maina, kad ima proksimalno LAD zapušenu cirkumfleksu, zapušenu desnu, syntax 52, jasno da ćemo pacijenta uputiti hirurzima, ako ga ne odbiju zbog bubrežne insuficijencije ili nečeg sličnog, ali da budemo tu jasni. Kada postoji ravnoteža, tu je uvek problem. Ovo može da se uradi lepo, putem PCI-a, takođe ova desna, ovo takođe, a onda postavlja se pitanje šta treba uzeti u obzir. Uvek ista priča. Komorbiditete, da li je to dijabetes, da li je to hronična obstruktivna, da li je to druga kardiovaskularna bolest, njegova slabost, kako izgleda pacijent, zatim anatomija, to nam je uvek važno, da li hirurzi mogu da postignu kompletnu revaskularizaciju, da li PCI, to jest interventni, mogu da postignu kardiolozi potpuno kompletnu revaskularizaciju, zatim hiruške kontraindikacije. Uvek imamo i anesteziologa sa nama kada govorimo na heart timu, znači anesteziolog je kod nas uvek prisutan. Zatim operator expertise, to je bio govor u prethodnoj sesiji. Nije svejedno da li neko radi jednu operaciju nedeljno ili radi 3 do 4 operacije dnevno. To se važi i za interventne kardiologe, to važi i za hirurge. Tu postoji razlika u kvalitetu jako, jako velika. I na kraju preferencije samog pacijenta i to je ono što sam rekao da će u suštini biti malo provokativno. Ako na kraju dođemo do toga da je ravnoteža, znači naučni podaci pokažu, ravnoteža između PCI i bypass operacije, kažu da će pacijenti, ako im se dobro prezentuje, u velikoj, gotovo apsolutnoj većini izabrati PCI odnosno na hirurgiju. Tako da hvala vam lepo na pažnji, eto. Je li diskusija odmah ili na kraju?
The discussion is at the end.
Okay.
Professor Stojkovic, congratulations. It was a brilliant talk. I'd like to have your slides afterwards. I think the discussion is at the end, so we should move on. And I invite now Milan Milojević to give his talk entitled ESC EACTS Guidelines on Myocardial Revascularization. Milan, please.
Thank you, Miguel. Once again, it's a great pleasure and privilege of being here today with all of you, and thank you for making this day so special. So I will talk about the ESC-EX guidelines on myocardial revascularization, and at the moment we have tried to develop this program. Our intention was to present the updated ESCTS and EX guidelines, but unfortunately the decision of the ESC and the EX leadership is not to have new guidelines, just to update some particular chapters because they stay behind the recommendation published in 2018. And there is an announcement that European hospitals should stick to the European guidelines and not go to the American ones that are published last year. So these are my disclosures. I don't have any financial conflict of interest. Still, I'm chairing the Committee of Clinical Practice Guidelines at the ESCTS that will probably influence the way how I'm going to present some of the recommendation. And I am successor of Professor Jeffson, and before that of Professor Miguel Sousa-Uva, who were the past chairman of the CPG within the ESCTS. So here are the guidelines that I'm talking about. As you can see, it's a great honor having Professor Sousa-Uva here because he was the co-chair of this guideline together with Franz Josef Neumann, the colleague of Professor Beyersdorf from Freiburg. And they have published this guideline in 2018. I was not directly involved, but I know that it was a hard work behind that and extensive decision about all the recommendation that was taken more than 1 year in order to provide with the final statements over there. They use the common European framework. As you can see, there are always specific classes of recommendation over there, 1, 2A, 2B, and 3, and the level of evidence is distinguished between A, B, and C based on the quality of the data that we have behind these recommendations. And I will start with the first set of recommendations, which of course recommend that we should inform the patient about the all benefit and risk, not only about the myocardial revascularization procedure, but all other invasive procedure that we are doing as a diagnostic tools. But I will focus on the last two recommendations with class 1 and level C, which highly recommend the use of the heart team for treatment decision making, and in a hospital in which there is no cardiac surgery on site, they should collaborate with some of the cardiac surgical center and discuss the patient within the heart team over there in person or using some kind of the video conferences over there. The level is a C, but with the data that we have nowadays, this will probably be updated to the level of evidence B in the future guidelines. But let's remind us about the concept of the heart team. This concept has been introduced by the syntax investigators in 2005, and the syntax is a great study because it's the all-comer study, so they allowed the investigator at the site to develop the heart team and decide whether the patient is eligible candidate for both PCI and the CABG procedures. So this concept then was adopted by European guidelines published in 2010, and Professor Ostojić, who is not with us anymore, but he was one of the co-authors over there, and then subsequently in American guidelines published in 2011 for PCI and 2012 for CABG. So they said that the heart team, it's a multidisciplinary decision-making process, and that means that we have interventional cardiologists, clinical cardiologist, and a cardiac surgeon as integral part of the heart team. And then we have other specialists by the invitation based on the patient comorbidities. And of course, the residents and fellow, they should listen to this discussion in order to learn and of course, participate whatever is in their hands. But then this heart team will make the treatment recommendation and then patient preference come. So the heart team should make the treatment recommendation without knowledge of the patient preference. And then when the patient preference come also to this decision making, we have final treatment decision, which is evidence-based shared decision making concept. And this is adopted by the ESC, ACC, AHA, STS, AATS, and the EX. And I think that we are sometimes misinterpreting the patient preference in this decision process. So in order that heart teams stay blinded for what the patient prefer for, it's always best that don't know in advance what is her own preference. So when we are choosing for the revascularization, particular revascularization treatment, we need to look certain amount of criteria over there. The first place is, of course, the surgical risk, whether it's acceptable for heart surgery or not. Then we have anatomic complexity of coronary artery disease, and we have a left main, we have proximal left LAD, and we have a syntax score. Then we have anticipated completeness of revascularization and presence of the confounding factors. At the first place, diabetes mellitus. But we have other confounding factors that played a major role in the treatment outcome between the PCI and the CABG, such as the heart failure and gender and many, many other things. So recommendation regarding the surgical risk, it's always recommended that we use the STS score instead of Euro score. And I know that at least in our hospital using the Euro score is the way how we are doing that. Now we switch also to the STS score. And the reasoning behind this is that the STS score is the most powerful data set that we have in the world of the cardiac surgery. So more than 400,000 patients is enrolled every year. 10% of these patients have independent data auditing, and the correctness of information over there is above 98%, which is more than in vast majority of clinical trials. So they're doing very great job, and they update their risk coefficients for the mortality and other outcomes every year. And that's the reasoning why we should prefer the STS score instead of the Euro score. Also, I know it's much more time consuming, and we'll probably need to spend 20 to 30 minutes in order to calculate all of these things. Another thing is that we should consider, when we should consider decision between the PCI and the CABG, the completeness of revascularization should be prioritized, and this is very controversial issue, but it's supported by the good data. So this recommendation is actually supported by the meta-analysis of Garcia et al. Published in JACC in 2013 on the sample of almost 90,000 patients. And as you can see on these slides, so no matter whether we are using anatomical definition or non-anatomical definition, the outcome is always in favor of completeness of revascularization. Last year, we published our data from the syntax extended follow-up in circulation, and what we found over there, when the completeness of revascularization is achieved with the PCI, then outcome is comparable with the CABG. So the completeness of revascularization play major role in the PCI patients. So these are the recommendations for the patient with one vessel or true vessel disease. As you can see, the main decision driver over here is the proximal LAD. So when there is no involvement of the proximal LAD, so then the patient preferably should undergo PCI. When we have LAD lesion, which is significant, then we should decide between the PCI and the CABG, because both intervention hold class 1 of recommendation. And why we have both intervention as a class 1 of recommendation is because we didn't find the survival benefit of CABG over PCI in this patient. But what we have found, and here on the left side, you can see the results from the Leipzig randomized trial. This is the largest randomized trial that we have on the proximal LAD patients. So these are the single lesion. And as you can see over here, no difference in mortality and heart clinical outcomes, but there is a huge difference in the rate of repeat revascularization at 7 years of follow-up. These data have been confirmed in the large neuroregistry analysis. On the left side, again, it's a result from the Hanan and group, and they published a lot this paper on this particular topic. And again, as you can see, there was double more repeat revascularization at 3-year follow-up between the PCI and CABG, and there was no signal in the excessive mortality between these two treatment patients. And the most recently, we have obtained the updated data from the New York registry, from the Patel and group from Mount Sinai, and they found, again, as you can see, the event rate at 8 years of follow-up was a PCI versus CABG 12.7 versus 2.5, so 5 times more need for repeat revascularization in PCI patients than those who undergo CABG, and of course this has resulted in more angina recurrence in the patient who undergo PCI in comparison to CABG, and that's the reason why we have a class 1 indication for both treatments, and this should be decided by the heart team and then inform the patients, and then the final decision should be made. This algorithm actually presents a recommendation for the patient with 3-vessel disease and the left main coronary artery disease. As you can see here on the left side, when you have a non-diabetic patient with a syntax score below 22, the PCI and the CABG both hold the class 1A recommendation. When the patient has the diabetes, even the syntax score is low, the CABG is preferable over the PCI, but when the syntax score is above 22, the CABG holds the class 1A and the PCI class 3A, so we should not do the PCI in these patients. For left main, it's a different, so we have a PCI and a CABG for syntax score between 0 and 22, PCI 2A for 23, 32, and above 32 we have for PCI class 3 and for CABG class 1A. And these recommendations are based on our individual patient data meta-analysis of 11 randomized controlled trials. And as you can see here, for the multivessel disease, we found a significant P4 trend, because the P4 trend are preferable statistical analysis when you have more than 3, comparison of more than 3 categories. On the right side, you can see that when the patient had the multivessel disease and diabetes, you should certainly undergo CABG, not the PCI, but when there is no diabetes, then the PCI is also, patient is also candidate for the PCI. And regarding the left main recommendation, as you can see here, we have published a statement together with the ESC in October 2020, saying that because of all the controversies surrounding the Excel trial, that we informed our members that we will update the recommendation on the infield, but we were waiting to receive the IPDMA from the Sabatine and a group from Harvard. Over there, this paper was published, this is mistake over there, was published last November. So, and it's a not big screen, but I try to emphasize what was the outcome difference between those patients who has the acute presence and those who are elective. And as you can see here on this slide, this is very rare in cardiovascular medicine. This is the sign of qualitative interactions, which means that the intervention is beneficial in one group and harmful in another group. That means, from a clinical epidemiologist perspective, that the PCI should be preferable treatment option for patients in acute settings, but then for the chronic settings, the surgery do better. So, summary of revascularization for the stable coronary artery disease, and we will call this the chronic coronary syndrome in the future guidelines, is that operative risk, syntax scores are main contributors. Completeness of revascularization should be prioritized, because the completeness of revascularization is also a surrogate of the extent of the coronary artery disease. And diabetes is certainly the strongest predictor of survival benefit of CABG as compared with the PCI and the multivessel disease. Patients with the left main disease and the multivessel disease both require decision-making by the local heart team, guided by the assessment of all the treatment effect modifiers. And the work on the recommendation for the left main part is in progress. With that, I would like to thank you for your attention. We'll be happy to answer your question at future stage. Thank you.
Thank you very much for this very focused and enlightening lecture on the guidelines. So we move on, and I invite Dr. Mila Kovačević for Institute for Cardiovascular Diseases Vojvodina to present her lecture.
Thank you very much. Dear ladies and gentlemen, dear colleagues, distinguished guests, it's my pleasure to be here and to participate in this first coronary summit. Just to see, okay. So, I will continue in Serbian. Moja tema je koronarni heart team ili tim za srce u svetlu novih dokaza i preporuka. Da li imam neki od konflikta, da kažem, interesa osim što sam interventni kardiolog, drugih nemam, ali da kažem not biased ili unbiased. Kada govorimo o heart timu, već smo čuli da prvo spomenjanje heart tima kao tela koje donosi odluke kada je u pitanju CABG u odnosu na PCI datira od 2010. godine, a na osnovu rezultata Syntax studije. Već smo čuli kada, znači, CABG ima prednost u odnosu na PCI ili vice versa. Tačnije, kada govorimo o petogodišnjim rezultatima Syntax triala, vidimo da kod pacijenata koji imaju Syntax score do 22, da kod ovih pacijenata naravno da možemo reći da podjednako imaju korist i PCI i CABG. Kod onih pacijenata sa Syntax scorom između 22 i 32 možemo opet debatovati. Veća prednost je CABG kada je u pitanju multivessel disease, ali kada govorimo o left mainu, tada možemo isto dati neku, da kažemo, egal značaj i PCI procedure. I na kraju, kada imamo Syntax score koji je preko 32, očigledno je da CABG ima prednost u odnosu na PCI. Koje pitanja treba da postavimo u stvari kao heart team? Prvo, koji pacijent će imati benefit od revaskularizacije, broj 1. Drugo, da li ćemo se odlučiti za PCI u odnosu na CABG i šta imamo od novih dokaza što će nas voditi u tim odlukama. Kada govorimo o odluci da li radimo CABG ili PCI, naravno kod akutnog koronarnog sindroma tu možete se složiti da nemamo dileme da prednost definitivno ima PCI. Kada govorimo o hroničnom koronarnom sindromu ili stabilnoj ishemijskoj bolesti, tada opet možemo razmatrati da li PCI, da li CABG ili OMT. Ovo su nove preporuke, ali američke preporuke, gde vidite, nešto sam izdvojila samo crveno, šta nam je jako bitno u donošenju odluke. Prvo, da li pacijent ima refraktornu anginu. Ako ima refraktornu anginu, tog pacijenta moramo revaskularizovati. Drugo, da li je left main ili višesudovna koronarna bolest. Kada govorimo o left mainu i višesudovne koronarne bolesti, opet već smo čuli da prednost ima CABG u odnosu na PCI, naravno ukoliko je hirurgija pogodna, odnosno anatomija pogodna za hirurgiju. Kada govorimo o višesudovnoj koronarnoj bolesti, sa desne strane vidite, opet pitanje je kakva je istisna frakcija ovog pacijenta. Da li imamo reduced ejection fraction manju 30% ili imamo očuvanu istisnu frakciju. Kod onih pacijenata kod kojih imamo nižu istisnu frakciju, apsolutno vidjet ćete dole, znači imamo prednost CABG-a u odnosu na PCI. Kada imamo očuvanu pak istisnu frakciju, pogledajte nivo dokaza i za CABG i za PCI. Jako nizak nivo dokaza da treba nešto da radimo kod ovih pacijenata koji imaju stabilnu koronarnu bolest i istisnu frakciju preko 50%. Kada posmatramo studije koje su u stvari vođene kod ovih pacijenata sa višesudovnom bolesti i stabilnom ishemijskom bolesti srca, ja bih izdvojila 3 najvažnije studije do nedavno, do skora, a to su CARIG studija, BARI 2D studija i FAME 2 studija. I kada pogledate same kriterijume, odnosno dizajn studije, u CARIG studiji i BARI 2D studiji nije bilo neophodno dokaz ishemije, za razliku od FAME 2 studije, da smo radili FFR proceduru da dokažemo da bi trebalo da radimo PCI. S druge strane vidite da je revaskularizacija ili PCI ili CABG ili PCI i na kraju kad pogledamo primarni endpoint u prve 2 studije, CARIG znamo da je velika studija sa 2000 pacijenata, mortalitet i infarkt miokarda, zatim u BARI 2D studije mortalitet, a kod FAME 2 studije su obuhvatili i urgentnu revaskularizaciju. I kada pogledamo sada rezultate, da li ima razlike u primarnom endpointu, vidimo da u CARIG studiji i u BARI 2D studiji nema razlike, ali ima razlike u pitanju FAME 2 studija i to se pokazalo na osnovu, znači na račun u stvari pacijenata koji su zahtevali urgentnu revaskularizaciju. Spominjala sam ovde dokaz ishemije, da li nam je dokaz ishemije bitan. Još 2003. godine, kao što vidite, jedna velika observaciona studija na neki 12.000 pacijenata koja je pokazala da kad imamo dokaz ishemije preko 10%, da tada ima smisla raditi revaskularizaciju, jer definitivno utičemo na redukciju mortaliteta kod revaskularizacije u odnosu na medikamentnu terapiju. Međutim, ima ova studija manjkavosti, observacione studije, nisu bile izbalansirane grupe, 10.000 pacijenata u medikamentnoj, mislim da nešto dosta manje, odnosno 75% u medikamentnoj i 25% u interventnoj. Naravno, dolazimo do ishemija studije koju smo toliko puta čuli, citirali, spominjali i tako dalje. Ono što je bitno, i ova ishemija studija je vođena upravo po toj osnovi. Da li ima ishemije? Da imamo dokaz ishemije kod pacijenata sa višesudovnom koronarnom bolesti i stabilnom ishemijskom bolesti srca. Naravno, imamo dve grupe pacijenata. Ishemija studija je bila duplo veća studija od Carriage studije, 5000 pacijenata. I šta smo dobili kao primarni endpoint? Nije bilo statistički značajne razlike kada je u pitanju kardiovaskularni mortalitet, infarkt miokarda, hospitalizacija zbog aresta, srčane slabosti ili nestabilne angine. Međutim, kada pogledamo malo dublje, imali smo, iako je bila učestalost infarkta miokarda podjednako u obe grupe, ono što je zapaženo da je učestanost periproceduralnog infarkta, naravno, bila veća u grupi interventnoj, u interventnoj grupi, dok na kraju, kada pogledate spontani infarkt miokarda u periodu praćenja, bilo je statistički značajno više u grupi koja je bila na optimalnoj medikamentnoj terapiji. I dalje nemamo odgovore šta je tačno u pitanju. Da li oni pacijenti koji su bili u interventnoj grupi, bili su na dvojnoj antitrombocidnoj terapiji, pa smo imali manje učestalost spontanog infarkta miokarda, ili je samo zbog kao posledice intervencije. Takođe, meta-analiza koja je sad obuhvatila i ishemiju studiju, sve ove prethodne koje sam navela, i Carriage i Bari 2D kod dijabetičara i FAME studija, opet pokazala da kada gledamo ukupni mortalitet, nema značajne razlike da li lečiti pacijenta, odnosno revaskularizovati ili ići na medikamentnu terapiju. I opet u podanalizi, odnosno kada pogledamo, ono što je meni interesantno opet jeste kada gledamo infarkt miokarda, da je opet nešto veća prednost u grupi koja je bila revaskularizovana. Upravo ovo i kao posledice ishemije studije, ovo su nove preporuke američke gde imamo promenu klase preporuka sa klase 1 na klasu 2B kod pacijenata sa višesudovnom koronarnom bolesti i stabilnom ishemijskom bolesti srca. Tako da u ovim preporukama poslednjim, američkim, Cabbage može biti u stvari, može poboljšati preživljavanje kod ove grupe pacijenata. Za razliku od PCI, gde kaže da još uvek nemamo dokaze, odnosno efekat, odnosno uticaj na preživljavanje pacijenata je uncertain, odnosno da kažemo nije dovoljno dokazano. Kada pogledamo LAD, samo izolovanu stenozu prednje descendentne koronarne arterije, i ovde se postavlja pitanje isto koristi revaskularizacije kod ove grupe pacijenata. Znači, pacijent sa višesudovnom koronarnom bolesti, stabilna ishemijska bolest, ne višesudovna, znači left main, proksimalna LAD, stabilna ishemijska bolest srca, da li ima prednost revaskularizovati pacijente ili ne, i dalje nedovoljno dokaza. I na kraju, kada možemo naneti štetu, to je ova klasa 3, jeste kada imamo pacijenta sa jednosudovnom ili dvosudovnom bolesti i stabilnom anginom, stabilnom ishemijskom bolesti srca, kod ovih pacijenata praktično nema koristi. Još više možemo naškoditi pacijentu, to je klasa 3, ukoliko nemamo ni dokaz ishemije, ukoliko imamo leziju koja nije signifikantna kada uradimo FFR. Druga podgrupa pacijenata su pacijenti sa stabilnom ishemijskom bolesti, ali sa niskom istisnom frakcijom, sa disfunkcijom leve komore. Kakve tu dokaze imamo? S jedne strane, studije koje su poredile Cabbage u odnosu na optimalnu medikamentnu terapiju, od kojih je najznačajnija Stitch studija, pa to je CAS, veteran studija, i s druge strane, tek nedavno objavljena Revive studija koja je poredila PCI u odnosu na optimalnu medikamentnu terapiju kod ovih pacijenta sa reduced ejection fraction. Šta kaže Stitch studija? Stitch studija, iako u početku nije pokazala prednost Cabbage-a u odnosu na optimalnu medikamentnu terapiju, ta prednost se pokazala nakon 8 godina praćenja. Kao što vidite, i kada je u pitanju smrt bilo kog uzroka, kada je u pitanju smrt od kardiovaskularnog uzroka ili smrt, mortalitet i kardiovaskularne hospitalizacije. S druge strane, nedavno objavljena Revived BCIS 2 studija koja je poredila perpetualnu koronarnu intervenciju i optimalni medikamentni tretman, koja je opet pokazala, iako to nije baš bio veliki broj pacijenata, oko 700 pacijenata, ali je pokazalo da PCI nema prednost u odnosu na optimalnu medikamentnu terapiju kad imamo pacijenta sa stabilnom koronarnom bolesti i niskom istisnom frakcijom. Naravno, postoje opet neke, da kažemo, prednosti, ne prednosti, ali ono što je zapaženo da kada pogledamo akutni infarkt miokarda, nije bilo statistički značajne razlike između ove dve grupe, ali kada pogledamo procenat spontanog infarkta miokarda, opet se vraćamo na taj infarkt, vidimo da ga je bilo češće u grupi optimalne medikamentne terapije i takođe neplanirana revaskularizacija u grupi optimalne medikamentne terapije. Naravno, ovde možemo reći da nije bilo nekog dokaza iz hemije, jeste da su se rukovodili da li postoji vijabilnost, bar 4 segmenta, ali nije bilo dokaza iz hemije. Sad postavlja se pitanje, znamo i kakvi su rezultati iz hemija studije kada je u pitanju, kao što ste već spomenuli, anatomski ili funkcionalna kompletna revaskularizacija i to je isto, sad da kažemo, možemo i o tome pričati. I još jedna meta-analiza koju sam uvrstila ovde iz razloga velikog broja pacijenata, to je 22.000 pacijenata, od kojih imamo 4 randomizovane studije, gde opet kada je poređen CABG u odnosu na PCI i medikamentnu terapiju kod pacijenata sa stabilnom iskemijskom bolesti, niskom istisnom frakcijom, da prednost definitivno ima CABG u odnosu na PCI, u odnosu na optimalnu medikamentnu terapiju. I upravo je jedan od razloga zašto u poslednjim ovim američkim preporukama praktično stoji da se kod ovih pacijenata sa nižom istisnom frakcijom i koronarnom bolesti stabilno preporučuje CABG da poboljša preživljavanje ovih pacijenata. I na kraju, kada posmatramo heart team, možemo govoriti o funkcionalnim, disfunkcionalnim i heart teamovima. Znamo da više stvari igra, da kažemo, stoji u opticaju kada posmatramo pojedinačne heart teamove, da li tu postoje toksične relacije, profesionalni konflikti, lični interesi, zatim solo igrači koji misle verovatno da znaju mnogo bolje od drugih ili drugačije, odnosno različito tumačenje preporuka, odnosno stvarih dokaza. I na kraju reproducibilnost ovog heart teama. Mi je jedna lepa mala studija na 40 pacijenata gde su tražili od jednog istog heart teama da pogleda nalaze posle 9 meseci kod pacijenata koji su već dobili odluku, gde se ispostavio da je reproducibilnost heart teama bila 80%. 80% slučaja su doneli istu odluku. Ono što je bilo još bolje, da je 93% pacijenta tretirano onako kako je heart team doneo odluku. I na kraju, knjiga je jedna lepa koja se može, da kažem, translirati, preneti i na heart team kao proces koji treba da se zasniva principom kolegijalnosti, međusobnog poštovanja i posvećenosti, da kažem, najboljim. Brojni su radovi na tu temu, za i protiv heart teama. Pa zatim, šta možemo dobiti najbolje od samog heart teama? Vidite da ovde još piše da to nije, ne možemo reći da je rules free forum, ne bi trebalo da bude. I na kraju, ko je, da kažem, vođa ovog heart teama? Naravno, već smo čuli da bi pacijent, bez obzira da li govorimo o tradicionalnom heart teamu ili contemporary, odnosno savremenom heart teamu, da imamo milion stručnjaka, moram reći da u mojoj ustanovi ovako izgleda heart team, interventni kardiolog koji prezentuje slučaj i kardiohirurg. Bez obzira, znači, pacijent bi trebalo tu da donese, da kažem, odluku kako će on biti na kraju lečen na osnovu svega što mi njemu predočimo. I kada pogledamo Rembrandtovu sliku iz 17. veka, možete vidjeti tada je čas anatomije doktora Nikolasa Tulpa. Tada je praktično taj čas anatomije bio javan, odnosno sekcija, znači nakon pogubljenika nekog od zločinaca. I kada pogledate Rembrandtovu sliku, vidite da ovde na času anatomije, to sad mogu biti medicinski stručnjaci, ali mogli su biti aristokrate koje su platile da uđu, odnosno da prisustvuju javnom času anatomije. Pogledajte gde su njihovi pogledi usmereni. Nijedan pogled nije usmeren niti na anatomiji podlaktice, niti ka profesoru, odnosno Nikolasu Tulpu. Svi pogledi su usmereni ka knjizi. Smatra se da je to bio priručnik iz anatomije ili fabrika ljudskog tela. Tako da i naš heart team bi trebalo da se bazira na evidence-based medicini, na medicini zasnovanoj na dokazima, što u ovom slučaju, kada govorimo o heart teamu našem, to bi trebalo da budu vodiči, da li evropski i američki vodič, da kada posmatramo svakog pojedinačnog pacijenta, da treba da procenimo koja je kompleksnost njegove anatomije na osnovu syntax skora, vidite nivo preporuke po jednim i drugim vodičima i na kraju STS score da procenimo rizik od kardiohirurgije. Ja vam se zahvaljujem.
Thank you very much, Professor Milan. So, for the sake of time, I ask the next speaker to come to the podium, Professor Milan Dobrik. He's going to talk about cardiologist's approach to the distal left main patients. Thank you.
Thank you very much. Poštovani predsjedavajući, poštovane koleginice i kolege, nakon ovih lepih, interesantnih teorijskih predavanja koje su bilo vrlo sadržajna, moj zadatak je da pričam o jednom vrlo konkretnom problemu i moj pristup će biti malo više praktičan sa ciljem da kolegama koji pre svega nisu interventni kardiolozi približim koje su to osnovne stvari o kojima razmišljamo, koje su to dileme interventnih kardiologa i na koji način mi izvodimo intervencije pre svega na distalnom segmentu glavnog stabla. Pre svega nekoliko reči ću reći zbog čega glavno stablo je specifično u odnosu na ostale segmente koronarne cirkulacije. Mi znamo da ukoliko je desna arterija koronarna dominantna, u tom slučaju preko 75% krvi je vaskularizovano putem tog glavnog stabla, a da ne pričamo u situaciji kada je cirkumfleksna arterija dominantna. Jedna od retkih situacija kada je praktično bočna grana, odnosno cirkumfleksna arterija, uvek važna. Možemo nekada reći da neka arterija, bočna grana, nije bitna toliko, ali ovdje je praktično uvek bitna i uvek je važno da ostane prohodna nakon intervencije, po mogućstvu da dobijemo i optimalan rezultat. Ono što je također važno jeste da u nekim situacijama mi ne možemo, za razliku od drugih segmenta, ne možemo naći zdrav referentni segment prema kome možemo odabrati adekvatne veličine balona, stentova i sl. Posebno u slučaju kada je stenoza tubularna, odnosno kada je od ostiuma pa do bifurkacije sužena. Ono što odlikuje glavno stablo jeste i dosta veliki referentni dijametar koji je negdje u prosjeku oko 5 mm sa velikim rasponom, jer tako i do 6,5 mm u dijametra. Ono što je također važno, što se podrazumeva, što sam već rekao, jeste da i nemamo taj često zdrav referentni dijametar. Kritične stvari su korišćene imidžinga, u nekim slučajevima i funkcionalna procena pomoću koronarnih žica sa senzorom pritiska. Vrlo je važna priprema same lezije da bi se intervencija optimalno izvela i konačno odabir same strategije lečenja, pre svega da li ćemo koristiti strategiju sa jednim ili sa 2 koronarna stenta. Ono što smo već vidjeli na samom početku kada je profesor Stojković pokazao situaciju koju imamo izolovane stenoze ostijuma i središnjeg dela glavnog stabla, u principu tehnički nisu veliki problem i ono što jeste i cilj ovog predavanja jeste šta u situacijama kada imamo značajno suženu distalno glavno stablo, kako mi to kažemo, bifurkacionu stenozu glavnog stabla. Samo jedna kratka rekapitulacija. U važećim preporukama Europskog udruženja kardiologa vidimo da praktično jedino u situacijama kada imamo značajno glavno stablo, kada imamo nizak syntax score, perkutalna koronarna intervencija ima isti nivo preporuka kao i hiruška revaskularizacija, a za razliku od toga u ostalim situacijama hiruška revaskularizacija ima prednost. Gde se još pominje i šta je važno u preporukama vezano za samu intervenciju na glavnom stablu, već sam pomenuo ulogu imidžinga i iste ove preporuke predlažu korišćenje imidžinga za procenu značajnosti stenoze koronarnog glavnog stabla i ono što je možda još važnije za optimizaciju lečenja. Često se kaže u interventnoj kardiologiji da nam FFR, funkcionalna procena i slične stvari služe za postavljanje indikacije, dok intravaskularni imidžing, kao što su IVUS ili OCT, služe za izvođenje same planiranje, izvođenje i finalnu procenu rezultata naše intervencije. Uloga imidžinga je višestruka. Recimo, pre svega, kada uradimo intravaskularni imidžing, pre svega mislim na IVUS, da imamo najviše podataka za to, mi možemo utvrditi konzistenciju samog plaka i samim tim odabrati, vidite u jednoj situaciji možemo imati plakove koji su relativno meki, bez mnogo kalcijuma, zatim kombinovano kalcijumski lipidni i vidimo ovdje jedan cirkumferentni kalcijum, pod uglom od 360 stepeni, koji je vrlo rezistentan. I u tom smislu mi i odabiramo strategije same preparacije lezije, od toga da to može biti obična predilatacija najobičnijim balonom, pa do nekih ekstenzivnih procedura kao što su rotaciona aterektomija, intravaskularna litotripsija ili orbitalna aterektomija. Na osnovu intravaskularnog imidžinga mi često možemo, odnosno vrlo precizno možemo proceniti zahvaćenost ostijuma 2 završne grane bočnog stabla, što nekada ne možemo dobro vidjeti iz angiografskih projekcija koliko god se to trudili iz brojnih geometrijskih razloga. Korektno urađen imidžing omogućava mi vođenje same procedure u smislu odabira dijametra stenta, dužine stentova i naravno izvođenja dodatnih intervencija u samom stentu. Konačno procenjuje se ekspanzija i apozicija samog stenta kao konačni rezultat naše intervencije. Poseban neprijatelj sa kojim se srećemo jeste sve veći broj bolesnika sa kalcifikovanim lezijama i ovdje vidimo AIVU sliku jednog cirkumferentnog debelog kalcijuma i ovdje vidimo OCT sliku sa velikim kalcifikovanim plakovima i generalno možemo podeliti na dve vrste kalcijuma, kalcifikovanih stenoza. Možemo govoriti o površnim stenozama, to su one najdublje, tako, koje su najizloženije lumenu, tako, i u principu, ukoliko postoji ovakva AIVU slika, mi preferencijalno koristimo tako rotacionu aterektomiju sa dve cilje, debulking same lezije, znači smanjenje volumena samog plaka, ili ono što je možda još i važnije, pravljenje krekova, odnosno pukotina u samom kalciju, koje će omogućiti adekvatnu ekspanziju stentova. Za razliku od toga, ukoliko su kalcijumske naslage duboke u adventiciji ili duboko u mediji, mi ne možemo praktično obrijati to rotacionom aterektomijom i u tom slučaju imamo i druge vrste tehnika kojima to možemo učiniti, a to su pre svega primjena nekomplijentnih i cutting ili scoring balona ili intervaskularna litotripsija, slično kao metoda kojom se razbija kamen u bubregu, tako, pomoću ultrazvučnih talasa. Sljedeća vrlo važna stvar jeste odabir same strategije lečenja bolesnika. Iskusni interventni kardiolozi praktično samo mogu na osnovu izgleda same anatomije, bez nekih formalnih proračunavanja, tako, odlučiti se koju će strategiju koristiti i najčešće korištenja strategije jeste takozvani single stent provisional, kada celu bifurkaciju distalnog glavnog stabla rešavamo implantacijom jednog stenta i u principu to se radi kada imamo izolovanu bifurkaciju, tako, znači na samom distalnom glavnom stablu bez zahvatanja ostijuma, kada je zahvaćen ostijum glavne grane ili ukoliko je bočna grana zahvaćena u dužini manje od 10 mm, recimo, a ukoliko sama lezija nije kritično sužena, manje od 70%, a za razliku od toga imamo situaciju kad imamo kompleksne situacije sa glavnim stablom i neke dodatne otežavajuće faktore koji mogu ovu kompleksnost posebno naglasiti. Naravno, na sljedećem slajdu ono što je važno jeste odabir samih materijala, samoga stenta. Praktično nužno je kada radite bifurkaciju glavnog stabla doći u situaciju da imate jedan stent koji je ekspandiran na dva dijametra. Ovaj deo naravno će proći u recimo proksimalni deo ili ostijalni deo prednje descendentne ili u nekim slučajevima cirkumfleksne arterije, ali ukoliko vi i prema tom dijametru se i odabira materijal, odnosno stent koji će se staviti, ali ukoliko ništa ne uradite sa ovim delom u glavnom stablu, imat ćete da stratovi vise, odnosno plivaju slobodno u tom segmentu i zbog toga je nužno, praktično obavezno kada radite intervenciju bilo kojom bifurkacijom tehniku jesu takozvane proksimalna tehnika optimizacije ili POT, gde se nekomplijantnim balonima dodatno širi stent u samom glavnom stablu, postižući bolju ekspanziju i bolju apoziciju samog stenta. Naravno, ne može se svaki stent podjednako ekspandirati i mi znamo da imamo praktično različite proizvođače stentova, različite mehaničke karakteristike i imamo nove platforme, jer tako svaki stent ima maksimalnu ekspanziju koju može postići. Imamo i nove stentove kao što su recimo Megatron koji se mogu ekspandirati do 6 mm. Što se tiče uloge imidžinga u optimizaciji intervenciju u glavnom stablu, važno je reći da nije dovoljno reći koristili smo AIVUS ili OCT prilikom intervencije, jer naravno sam imidžing sam po sebi, ukoliko iz tog imidžinga ništa ne proistekne, ne može utjecati na nekakav dugoročni rezultat, znači nije dovoljno slikati se, ali ukoliko imamo smislene praktične interventne korake koji iz tog imidžinga proizilaze, možemo, smatra se, postići i bolju prognozu kod ovih bolesnika. Recimo da samo glavno stablo možemo podeliti na nekoliko delova. Centralni jeste takozvani polygonal confluence, gdje se praktično sustiču sve te tri grane, proksimalni deo glavnog stabla, ostijalni segment tela D i ostijalna cirkumfleksa i u jednoj studiji praktično na azijskoj populaciji, na južnokorejskoj populaciji, definisani su i kolike su to površine poprečnih preseka kojima trebamo najmanje težiti da bismo smatrali da je rezultat optimalan. Naravno, treba uzeti u obzir i da su različite antropometrijske karakteristike azijske populacije i bele populacije, ali recimo da je ovo jedan koristan vodič, jedno jednostavno pravilo kako možete 5, 6, 7 i 8, tako brojeve zapamtiti, da vam to bude neki jednostavan vodič ispod čega ne smete ići u tim intervencijama. I konačno, pitanje je da li taj AIVUS poboljšava korištenje intervaskularnog imidžinga kod glavnog stabla, poboljšava prognozu i sve je više dokaza da to jeste tako. Imamo različite studije, uključujući registre, mečovane kohorte i naravno subanalize velikih left main studija, gdje je pokazano da ipak korištenje imidžinga sa adekvatnim, jel tako, znači posledičnim merama koje postižete kako u odabiru samog materijala i izboru strategije i optimizaciji finalnog rezultata, možete u krajnjoj instanciji poboljšati prognozu ovih bolesnika. I konačno, umjesto zaključka, reći ćemo da glavno stablo ima jedinstvene anatomske karakteristike koje razlikuju od ostalih, rekao bih, i nebifurkacionih i bifurkacionih lezija. Ono što je važno da, pre svega, kompleksne intervencije na glavnom stablu je uvijek potrebno raditi pod dejstvom ajvusa sa 3 osnovna cilja: što bolje pripreme same lezije za implantaciju stenta, odabira stentova i optimizaciju finalnog rezultata. Ono što je važno jeste da korištenje ajvusa smatra se da može poboljšati ishod kod ovih bolesnika, tako da je to praktično danas standard u interventnoj kardiologiji za ovu vrstu stenoza. Ja vam se zahvaljujem na pažnju.
Thank you, Milan, for a very nice presentation. So then we move and invite Professor Lazar Velicki from Kamenica for Institute Vojvodina to present his lecture on the surgical aspects of the revascularization in left main.
Okay, thank you for a kind introduction. I will continue in Serbian. Dakle, poštovane članovi predsjedništva, poštovane koleginice i kolege, meni je izuzetno drago što je moj način razmišljanja bio i jeste vrlo sličan mom prethodniku. Mi smo se upoznali pre 20 godina i ovo predavanje će više biti klinički orijentisano. Ovo su podaci koje smo sada već nekoliko puta videli. Samo da rekapituliramo, slika levo gore prikazuje vizualno koliki je značaj left maina, odnosno glavnog stabla u vaskularizaciji miokarda. Dakle, kada govorimo o glavnom stablu, govorimo o segmentu arterije koji je dugačak oko 1 do 2 cm i koji ima dijametar od 4 do 6 mm i kroz koji prođe oko 200 ml krvi za minut na 100 grama srčanog mišića. Negde oko 5% bolesnika koji se upute na koronografiju budu dijagnostikovani sa značajnom stenozom left maina, tako da svakako left main stenoza značajno jeste važan klinički entitet koji, kao što smo videli, može se leči i interventnim putem i mnogo češće hiruškim putem, odnosno Cabbage-om. Za postavljanje dijagnoze left main stenoze, odnosno značajnog suženja glavnog stabla leve koronarne arterije, važna nam je adekvatna koronografija. Ovo su neki radovi koji praktično od prošlog veka pokazuju prve pokušaje revaskularizacije kod ovih bolesnika, sve sa trialovima koji su novijeg datuma, koji pokazuju i uspeh PCI-a u ovom segmentu. Videli smo i kroz prethodne slajdove, samo ću da podsjetim to da je shear stres glavni faktor koji utiče na nastanak plaka u ovom segmentu arterije, da je shear stres najveći na nivou karine, odnosno bifurkacije, i da je to razlog zašto plak nastaje na lateralnim zidovima same bifurkacije, znači distalnog segmenta, nešto ređe na nivou ostiuma i najređe na nivou mid-shaft dela koronarne arterije. Preporuke koje su, čuli smo ih, ponovili smo ih, i dalje je hiruška revaskularizacija faktički neprikosnoven način lečenja ovih bolesnika, iako postoje i preporuke da se kod bolesnika koji imaju niži syntax score i jednostavniju anatomiju može raditi i PCI, odnosno stenting levog koronarnog stabla. Ovo je studija koja je nedavno izašla i koja je nedavno objavljena, faktički jedna meta-analiza koja pokazuje head-to-head comparison između PCI-a i Cabbage-a. Ono što su pratili autori jeste sveukupni mortalitet, rate stroke-a, myocardial infarction i potreba za revaskularizaciju na 30 dana, godinu dana i 5 godina od same intervencije. Pokazano je da ne postoje značajne razlike u mortalitetu u odnosu na pristup revaskularizaciji. Ono gde postoje razlike jesu i koje su korist Cabbage-a, to je kada govorimo o pojavi infarkta miokarda, dakle na 5 godina je infarkt miokarda niži kod bolesnika koji su upućeni na Cabbage. Ono što daje prednost PCI-u, naravno i potpuno logično, je procenat stroke-a i potreba za ponovnom revaskularizacijom opet daje prednost Cabbage-u nakon godinu dana ili 5 godina. Ovo je, dakle, opet jedan, da samo sumiramo koji su to pacijenti eventualno pogodni za PCI, odnosno koji su to pacijenti za kebić. Prethodno smo razgovarali o tome da bi pacijent trebalo da bude uključen u donošenje odluke da li da se revascularizuje na jedan ili drugi način. Da pomenem, znači govorimo o left mainu. Objavljena je i studija novijeg datuma koja propagira ovakav jedan pristup. Ja ću samo da vas uputim na disclosure, gde ćete vidjeti da su faktički svi autori ove studije koje propagiraju zaključak da pacijent donosi odluku o načinu revaskularizacije bili podržani od strane industrije koja proizvodi stentove. Tako da kažemo. Sad, glavna tema i više onako klinički orijentisan pristup lečenju bolesnika koji se upućuju na kebić, a imaju left main, bazirat će se na miokardnoj protekciji tokom hirurgije, na proceni i evaluaciji bolesti, same koronarne bolesti, na tipu hirurgije, na odabiru konduita i na virtualnom planiranju kebiđa. Ono što je svakako inherentno kada govorimo o kardiohirurgiji jeste i miokardna protekcija tokom kardiohirurške intervencije. Postoje različiti modaliteti da se srčani mišić prezervira tokom aresta. Svaka ustanova ima svoje preference. Ono što nam je na raspolaganju svakako jeste anterogradna, retrogradna kardioplegija ili kombinacija anterogradne i retrogradne kardioplegije. Poseban problem kod left maina predstavlja suženje glavnog stabla. Ako se sjetite prve slike na prvom slajdu i irigacionog područja left maina, tada možemo lako da shvatimo da zbog ozbiljne stenoze i protekcija miokarda zbog nedovoljne instalacije kardioplegičnog rastvora može biti kompromitovana. Tako da u tim situacijama imamo na raspolaganju davanje kardioplegije preko graftova, obično venskih graftova koje graftujemo na target krvne sudove, odnosno koronarne arterije, i tada preko ovog posebnog aplikatora možemo da dajemo kardioplegiju i u ova područja. Brojni su radovi koji su ispitivali suficijentnost kardioplegije samo anterogradnim putem, anterogradno-retrogradnim putem, ali opet kažem, mi smo ustanova koja koristi u suštini samo anterogradni način davanja kardioplegije i kod ove grupe bolesnika i nismo primetili neke značajnije probleme s tim u vezi. Rad nemačkih autora koji se takođe bavio ovom problematikom, koji je pokušao da predlog kako da se većina kardioplegičnog rastvora koja se daje kroz aortni koren instilira kroz sužen left main. Oni su posebnim tehnikama koje se koriste i u off-pump hirurgiji vršili podvezivanje, privremeno podvezivanje desne koronarne arterije, vrlo visoko, i čime bi se faktički arterija okludirala i najveći deo kardioplegije redirigovao kroz left main. Ono što je takođe još na raspolaganju, imali smo prilike da sa ovim termovizijskim kamerama radimo, doduše u naučno-istraživačkom radu, jeste da se putem ovih kamera vrši vizualizacija teritorija i regija miokarda i da se vrši procena adekvatnosti perfuzije kako bi se optimizovala samo davanje kardioplegije i postigao zadovoljavajući efekat. Ovo još uvijek nije u kliničkoj praksi, ali postoje radovi koji ovo pokazuju, tako da u nekoj skorijoj budućnosti, znači, jedan od načina za verifikaciju adekvatnosti kardioplegije može biti i putem termovizijskih kamera. Dalje, procena ekstenzivnosti bolesti. Nije sve jedno, znači, da li je pacijent ima single left main leziju, stenozu, da li je ona na bifurkaciji, trifurkaciji, da li postoje udružene stenoze na ostalim arterijama levog koronarnog sistema ili desnog koronarnog sistema. Sve je to nešto što nama diktira i operativnu strategiju i pristup lečenju ovakvih bolesnika. Ono što nam je vrlo važno da znamo, kada planiramo već operaciju i kada se pacijent upućuje na planiranu hiruršku intervenciju, jeste da znamo da li od ranije postoje prisutni stentovi u koronarnom stablu, koja je pozicija tih stentova, kakav je funkcionalni status tih stentova. Ono što nam je još jako važno je da znamo kakav je status proksimalne aorte i luka aorte, jer od ovih podataka, znači putem ovih podataka ćemo da mi potpuno prilagodimo strategiju da li u smislu off-pump hirurgije ili već nekog drugog načina revaskularizacije. Isto tako, vrlo nam je važno da znamo, budući da ćemo govoriti i da su preporuke takve da se koriste multiarterijski graftovi, da znamo kakav je status leve i desne supklavije, budući da iz njih izlaze lima i rima. Dakle, ukoliko kompletnu revaskularizaciju baziramo na limi preko YT graftova, a ona ima neadekvatan protok zbog stenoze, tada je taj pacijent potencijalno u velikom problemu. Tip hirurgije, priča on pump, off pump je priča koja je već ispričana, koja je priča od pre 20 godina. U suštini su se pozicije za on i off pump hirurgiju iskristalisale i svaka ustanova je napravila verovatno sam određeni algoritam u kojim situacijama će da koristi on pump hirurgiju, u kojim situacijama će koristi off pump hirurgiju. Ono što je priča sadašnjosti jeste mid-cap ili minimalno invazivna direktna revaskularizacija, gde se kroz male rezove, kroz međurebarne prostore pristupa toraksu, mediastinumu, vrši se preparacija graftova i vrši se njihovo ušivanje, odnosno kreiranje anastomoza na target vesolima, odnosno najčešće to je LAD, mada mogu da se revaskularizuju i ostali krvni sudovi na srcu. Studija koja je dosta značajna i koja je ispitivala opet head-to-head efikasnost minimalno invazivnih pristupa CABG-u i PCI procedurama DES stentovima prve, druge generacije. Takođe, u slučaju left maina takođe je pokazano da je prednost, čak i kada govorimo o minimalno invazivnim hirurgijama, na strani CABG-a. Sledeći korak je TECAB ili totalno endoskopska revaskularizacija koja je robot asistirana, koja nije u prevelikoj meri zastupljena u svetu, ali postoje ustanove koje se baziraju samo na ovom pristupu. Dakle, to je korak još dalje, gde se kroz posebne portove vrši takođe preparacija graftova i njihovo anastomoziranje na koronarnim krvnim sudovima. Postoje radovi koji su uporedili TECAB i mid-CAB i da li zbog krive učenja, da li zbog tehničke kompleksnosti, rezultati su takvi da je TECAB povezan sa ranijim graft failurom i povećanom potrebom za ponovnom revaskularizacijom. Znači, ovo je sigurno tehnologija koja će u budućnosti da se razvija i dalje i čiji će rezultati biti, nadamo se, komparabilni sa mid-CAB-om. Tehnika koja se retko koristi, koja je opisana, koja je publikovana, čak je opisana i serija bolesnika koja je na ovaj način lečenja, to je osteoplastika, gde se pristupom kroz aortni koren vrši i longitudinalno otvaranje left maina sa augmentacijom ostijuma i samog left maina, da li putem bovinog perikarda ili autolognog venskog grafta. Tehnika koja se retko koristi, ali kažem za hirurgije možda može biti interesantno da ih imaju u svom armamentarijumu. Odabir graftova, vrlo važno pitanje na kome se puno insistira, čak su i evropske i američke preporuke snažno podržavaju primjenu multiarterijskog graftinga, tako da to je nešto što će sigurno biti budućnost i opet svaka ustanova ima svoja iskustva i domete u kojima koristi totalne arterijske revaskularizacije. Različite su konfiguracije koje mogu da se koriste, ovde su prikazane samo od neke od konfiguracije i strategija. Ono što je svakako standard to je lima LAD, sve drugo, da li ćemo da koristimo venske graftove koji bi trebalo da se napuštaju, da li ćemo da koristimo radijalnu arteriju ili ćemo da koristimo bima u različitim konfiguracijama ili kroz anastomoze T ili Y anastomoze na limu. Znači, to su sad sve preference samog hirurga. Ne treba da zaboravimo da značajan broj krvnih sudova revaskularizujemo putem takozvanih jumping anastomoza i svakako tehnike adekvatnog jumpinga, odnosno sekvencijalnih anastomoza su nešto što mora biti u delokrugu svakog savremenog koronarnog hirurga. Rad koji je definitivno pokazao da postoji razlika u long term rezultatima u smislu preživljavanja kod bolesnika koji se revaskularizuju lima plus venski graft u odnosu na lima radial arteriju u Y konfiguraciji. Već nakon nekih 3 do 5 godina krive se razilaze značajno u tom smislu da je preživljavanje znatno bolje kod bolesnika koji se revaskularizuju totalnom arterijskom revaskularizacijom. Isto tako, značajan podatak koji treba da imamo na umu, studija novijeg datuma ukazuje na značaj irigacionog područja određene arterije. Dakle, što je to irigaciono područje miokarda veće, tada ima više smisla tu arteriju, naravno koliko postoji značajna stenoza, revaskularizovati arterijskim graftom, jer je tada benefit maksimalan i long term rezultat odličan. Za kraj, htio bih da vam pokažem, ovo ste sigurno već videli, upoznati sa ovom tehnologijom. HeartFlow je kompanija koja nije jedina na tržištu, ali je sa najdužim stažom od nekih 7-8 godina. Kalifornija je u pitanju gde se na osnovu CT-a, odnosno CT angiografije, sada već na osnovu klasične angiografije može izvršiti rekonstrukcija koronarnog stabla i izračunavanje putem posebnih matematičkih numeričkih modela i FFR-a kroz kompletno koronarno stablo. U ovoj godini objavljen je i protokol za jednu studiju koja se zove Fast Track CABG Study, gde se pokušava kompletno isplanirati CABG hirurgija samo na osnovu CT-a, odnosno virtualnog, odnosno FFR CT-a. Tako da pacijenti se uključuju, vidjet ćemo kakvi će rezultati biti, ali ovo je nešto što sigurno ukazuje na jednu dobru budućnost kada govorimo i o CABG-u i o PCI-u. Umesto poruke za zaključak, ja bih hteo da kažem da je koronarna hirurgija u poslednjih 10 godina izuzetno uznapredovala, pre svega kao rezultat značajnog napretka interventnih procedura koje su se u velikoj meri približile CABG-u, u mnogim segmentima ga i prestigle. Koronarna hirurgija je sada poseban segment iz specijalizacije ili subspecijalizacija unutar kardiohirurgije i najbolji rezultati se postižu onda kada koronarnu hirurgiju radi hirurg koji je tome najviše i posvećen. Umesto zaključka, znači rat između ili borba između kardiologa interventnih i hirurga će sigurno da se nastavi dalje, znači sve do momenta dok se toj borbi ne priključi jedan heart failure kardiolog koji evo prođe ovako. Hvala vam na pažnju.
Thank you very much for keeping your time. So the last presentation is by Dr. Srđan Bošković. Is there outcome equity in patients with proximal LAD coronary artery disease? Please. I think we are on time.
Yeah, I'll try to shorten it as much as possible. So good morning, everything, and thank you for the invitation. And as a gesture of goodwill towards my friend Dr. Mićović, I will continue my talk in English and try to be as fast as possible. So we're talking about the left main disease and the left main PCI or CABG. So now we are moving toward something that is lower of importance in anatomy, which is proximal LAD. And I was raised with something that was called the cardiology dogma, which means that we all know that proximal LAD supplies the vast majority of myocardium, which is more than 50%. And when I started to work as a cardiologist, there was a dogma that REVASC, whether it's CABG and mostly CABG, improves survival in those patients with a significant proximal LAD disease. And that was 25 years ago. And we know that over 3/4 of all patients with a proximal LAD have involved other blood vessels of the heart as a diseased ones. Cardiac surgeons are, let's say, mocking that the lima is a superior, it's immortal, but there is nothing more than lima. And as we know, as an international cardiologist, which I am, we're improving in imaging, in debulking, in stents every year, so on. So we don't know whether it's lima still now. It's superior to any stents, including the last generation DS. And that translates to other dogma, which says that surgery is superior to PCI for proximal LED. We all know that stents are prone to thrombosis and stenosis, but TVR and TLR are single digits in recent clinical trials regarding the new DES. So the last remaining and still remaining the guidelines of the REVASC in the Europe are those published in 2018, and almost all the lecturers went through them. So I'll just repeat the parts which are important for my lecture. That means that the proximal LED is involved in decision making regarding REVASC, and with proximal LED, two-vessel disease, according to expert consensus, can be treated by both CABG and PCI. And if we talk about the three-vessel disease, it remains the difference between the high syntax score and the diabetics. If the syntax score is more than 23, then the CABG is favorable option, and if the patients are diabetics, also the CABG is a favorable option. But what is the most important goal of our trials? Are those symptoms, REVASC, non-fatal MI, or just the mortality? If we look at the mortality, there is a nice overview of evolution of PCI versus CABG for the proximal LED regarding the results of the New York percutaneous core intervention reporting system. The first paper that I'm going to show was published in 2014. So no new generation DES, no debulking, less IVUS, less OCT. And comparing to surgery, there is no difference between PCI and surgery in mortality. There is even no difference between surgery and PCI and mortality, stroke, or myocardial infarction. The most important difference is in repeat revascularization. And of course, in every clinical trial, there is a bias regarding the including patients. These patients who received DES were more likely to be women, be of different ethnicity, have higher body mass index because we are afraid of overweight, obese people in cardiac surgery, and they had higher ejection fraction. The many people who talked today just emphasized the importance of ejection fraction in a complete REVASC when you go to the decision whether to do a PCI or CABG. So 7 years later, that was 2014, in 2021, the same registry, almost 15,000 patients, almost 13,000 received PCI. Still, no difference in mortality, no difference in mortality MI stroke. Yes, there is a difference in subsequent REVASC regarding higher incidence of subsequent REVASC in patients with PCI. There are relatively rare randomized trials which randomize patients to PCI, CABG, or optimal medical treatment for the proximal LED. One of them is MASS. Those clinical trials were low in numbers, and this one included just 214 patients. There is a difference, of course, in MACE, but these MACE are driven by repeat REVASC and non-fatal MI. But if you look at the mortality, which is probably the most important endpoint in all clinical trials, the mortality was completely the same. And just to be aware, there was an arm in the clinical trial that regarding the patients for the optimal medical treatment with significant proximal LED disease. This is a very nice trial by Greek authors, where they compared the PCI and the CABG patients for the isolated lesions of the proximal LED, and just look at the death. This is the first line. The death mortality in patients which underwent the PCI was twice lower than the death in the CABG patients. Okay, we are not talking about that this is a heterogeneity of the patients, but if you look at the other endpoints were more or less similar, and there was no benefit of CABG over PCI in this population. But if you go through the subpopulation of the trial, you can see if the patient has a diabetes, that favors CABG. If the stent length is very high, very big, more than 30 millimeters, that supports probably the CABG as the first option. yes, there is some other trials that compare the proximal LED and involvement in other coronary beds, PCI versus CABG, and one of the best published papers was done by Patrick Serraios and the group. They included two big clinical trials, BEST and SYNTAX trial. And if you look at the overall population, the PCI is less favorable or worse option in these patients. But if you look at the patients with a SYNTAX score between 0 and 22, there is no single difference between the PCI and the CABG strategy for proximal LND and subsequent involvement of the other coronary blood vessels. If you look at the other clinical trials which were comparing the, let's say, modern approach to the proximal LED revasc, so using internal memory graft versus PCI of the LED, there is no difference in the outcome, in the mortality outcome, unless you put a big stent, which is also more than 30 millimeters. There is a meta-analysis of 9 randomized trials, more than 1,000 patients. Most of the patients had lima, but these trials were done in the first decade of 2000, in the 21st century, and most patients received POBA or BMS, and even without using the modern technology, there was no difference between lima revasc of the LED and the POBA and the BMS revasc of the proximal LED. Of course, we know that the angina relief was greater with CABG. The repeat revasc was significantly greater after PCA, but what is interesting, there was no significant difference in the quality of life. And there is we were the part of the Nabori 2 trial. There is a big misconception that the stents in the proximal LED behave differently than in other parts of the coronary vessels, which is definitely untrue. Why? First, the diameter of the proximal LED should be bigger than other diameters in the other vessels. The other thing is we are using much more often imaging, debulking, and trying to optimize those stents comparing to different parts of the other coronary blood vessels. So if you look at the Nabori 2 trial registry, when you compare the Nabori stents that were placed in the proximal LED and in other parts of the blood vessels, you can see that yes, the cardiac death is completely the same after 2 years, which is very low, 1.56 and 1.63%. TLF is a little bit higher, but it's not significantly significant. And if you combine all these endpoints, cardiac death and EMI, there is no difference between the proximal LED in 1 year follow-up and 2 years follow-up in the Nabori 2 trial. So if you look at the curves are completely parallel. They are not separating after more or less 2 years. And the proximal LED is not any different as other parts of the coronary blood vessels in the heart. Based on our findings, which was the conclusion of this trial, the authors suggested that the proximal LED may in the future be regarded and discussed in upcoming guidelines as any other coronary artery lesions. I will just emphasize 2 other clinical trials which were more or less similar than the Nabori 2 trial. After 10 years of follow-up of stents placed in the proximal LED and non-proximal LED, you can see in the first row there is no difference in death. So the death is 24.9 in the proximal LED and 26.3 in the non-proximal LED. There is no difference in cardiac death. There is just more cardiac death in the non-proximal LED in the absolute figures. And as you can see, as you can go through the p-values, there is no difference in any other sub endpoints of this trial. And you can appreciate that through these curves listed in the article. The PROTECT trial was the patient-related outcome with Endeavor versus Cypher stenting trial, also trying to see whether the placing stents in the proximal LED makes any difference comparing to other places in the RCA and the CIRC, even in the left main. And as you can see, the same thing, the curves are completely the same. There is no difference between stenting the proximal LED and the stenting any other part of the vascular bed of the heart. Conclusion, the finding may suggest the proximal LAD lesion may not confer substantial additional risk in the DES era. And there is just 4 years between the ESC guidelines and the ACC/AHA guidelines of revascularization that was given to us in January 2022. And there is a huge difference in approach. The approach that preferably I like as a clinical cardiologist and interventional cardiologist, the old guidelines and the old REVASC guidelines were downgraded from the class 1 to the class 2B regarding stenosis in the proximal LAD, even the stenosis of the multivessel coronary artery disease. The explanation is the dedicated randomized clinical trials found no survival advantage for either CABG or PCI over medical treatment in this setting, and the ischemia trials show no difference in event rates with either CABG or PCI over medical treatment when patients had multivessel coronary artery disease involving the proximal LAD. Finally, I don't think this is a simple solution. I don't think this is straightforward downgrade of the REVASC, and I do believe that the heart team remains the core of our decision-making process in our hospital. But unfortunately, the heart team has to be aware of so many variables considering the technical aspects of the procedure and the aspects of the patient. And there is a perfect review of the REVASC in stable coronary artery disease with the Berninger as a senior author, where the proximal LAD, as you can see, is involved if the patient has so-called high atherosclerotic burden in other blood vessels of the heart, then probably the CABG or the PCI is preferable option, but if the syntax score is low, maybe the medical treatment should be the primary option. This is the perfect review and of the trials comparing CABG, PCI, and optimal medical treatment in stable coronary artery disease. And if you see the majority of trials comparing those options in multivessel coronary artery disease with and even without and even with diabetes are neutral. They don't give advantage to any form of REVASC or optimal medical treatment. If you see the proximal LAD, which was the topic of my talk, as you can see, only three studies give advantage to CABG. 2 of them were done in mid-90s of the last century, but the vast majority gives equal treatment options of CABG, PCI, or PCI for the proximal LAD. As a cardiologist today, and I started with some dogma which were given to me 25 years ago, the only thing that stays unchanged is the anatomy. Everything else has changed. So REVASC for proximal LAD just might improve outcome over medical treatment. It doesn't matter what type of REVASC we are doing. Lima is immortal, but my personal opinion is not superior to new generation DES and our new technologies. And surgery looks not superior to PCI for proximal LAD in terms of survival. The problem with individual approach is that there are so many variables included in the decision, and there are so many variables that need to be accounted for. Thank you for your attention.
Okay, I would like to thank all the lecturers for the efficient and timely based lectures, and it is obvious that all of them make all the efforts to prepare very nice lectures. And yeah, that is clear. Okay, we are almost done because in 5 or 6 minutes we are about to start the keynote lectures. And maybe some words from the panelists. I have only one short question for the surgeons, and it is, does it reopen or not? So following time when you put the Lima to the mild grade stenosis, and then by the impact trial 90% after 6 months is not functionally working. So the question is, does it reopen or not over time when the stenosis becomes significant? So, or we should wait for the impact late trial, so then they will.
Let me ask my crystal ball.
Okay, maybe some comments, or is it the same or it is not the same after these 2 hours of the and 2 sessions?
Well, I think they have to separate left main first.
Yeah, okay.
Okay, just a question for Milan. Regarding syntax trial, when will we start to consider trials that used second generation DES imaging and let's say contemporary PCI to compare with CABG? I don't know, there are no many randomized ones, but do we have a perspective of that? Are there any studies that are planned?
We have a BEST trial. It's a newer generation drug-eluting stents. Then after we have a Noble and Excel. Now there is a 3 randomized controlled trial in the planning phase. One of them is in the left main, another one is their heart failure, and then we will see about the third one. We are not sure about the final study design. But I think the very important message that we have received from these studies with the new generation drug-eluting stents, comparing to those with the first generation drug-eluting stents, is of course that there is a substantial improvement in the PCI. We have a less repeat revascularization. But I think that we are missing also one important observation is that if we are comparing the surgical outcomes from the syntax left main patient and those from the Excel left main patients and just focusing on those with the syntax score below 32, so to have some kind of the comparable population, we'll see the double less adverse events in Excel. That means that the PCI is improving, but the surgery is also improving. And that's the reason why we need to have more comparative studies. I think all of these advances in the interventional cardiology really push the surgery at a higher boundary because they need to think about their perioperative complication and long-term follow-up. That was not the case in the history because they have the exclusive rights of doing the treatment for 2 particular patients. So we need more comparative studies. We don't have a definitive answer in this era, but the answer will come for sure. Thank you.
Thank you.
Do you have any additional questions? We have a very short, quick share.
Very short in time. So
okay. Yeah, thank you very much.
Okay, thank you.
Thank you.
Take a coffee and
thank
come
you
back
very
in
much.
2 minutes.
Thank you. Mogu sve da vas zamolim da ostanete u sobi. Počinje nam uživo predavanje iz Njujorka za 2 minuta. Mario Gaudino će nam se pridružiti, pa da ne napuštate sobu. Izvinite, mogu sve da vas zamolim da sednete, počet će nam predavanje za 2 minuta. Aha, okej.
Poštovane kolege,
Mićko, možeš da kažeš na mikrofon da ljudi ostanu, pošto...
ja se izvinjavam.
Excuse me, we don't...
Poštovane kolege, ja se izvinjavam. Došlo je do zabune. Za 2-3 minuta počinje predavanje profesora Marija Gaudina iz Njujorka, tako da vas molim da ostanete u sali. Hvala.
Mario will join us soon.
Hvala.
May I ask you to take your seats, just to see with the techniques. može on da nas čuje? Ili... Može. Aha. Okay. Good morning, Mario. Could you hear us?
Hi, Milan. I'm trying to share my screen. It's coming. Can you hear me?
Yeah, we can hear you.
Thank you.
Welcome through this new technologies. It's so pity that we cannot have it here in Belgrade, but I hope so you will come to visit us soon.
Sure.
So.
That will be my pleasure. Let me try to, again, find where my... Let's see where I can share my screen.
So allow me the opportunity to present you to our audience here in the room. So can you just close the door, please? Okay. Okay. So the ladies and gentlemen, dear colleagues, I have the privilege to introduce our keynote speaker. So the Dr. Mario Gaudino, he has had a distinguished academic career in the cardiovascular research and in particular in the coronary research. And now I will need to read all of your Mario titles from the paper because you have too much of them. So Mario Gaudino is Stefan and Suzanne Weiss Professor in Cardiothoracic Surgery. He's Assistant Dean for Clinical Trials at Weill Cornell School of Medicine. He's a Professor of Clinical Epidemiology and Health Service Research at Weill Cornell Graduate School. He's Director of the Joint Clinical Trial Office. He's Director of Translational and Clinical Research at the Department of Cardiothoracic Surgery. He's the Chair of Coronary Task Force at European Association for Cardiothoracic Surgery, and thanks to him we have fantastic program over the last 5 years at every annual meeting. But behind that, and privately, the Mario is just Italian in New York, I must say that. He is passionate in everything that he is doing in his daily life. He is the fitness lover, he is the animal lover, and finally, he's a good friend, approachable 7 days a week, no matter of time. So Mario, thank you very much for taking your time to join us today, and the floor is yours, please. Looking forward to listening to your presentation.
Well, thank you, Milan. Thank you for the great privilege of this invitation, and I agree it would have been much better to be with you in Belgrade. Unfortunately, the travel schedule was a little bit crazy, and we couldn't do it, probably hopefully next year. And you asked me to discuss the challenge of clinical trial in surgery, a topic that I'm very passionate about, so thank you for this invitation. And I will start by admitting that as a surgeon, we really do not have a great reputation for generating high-quality randomized trial. That was in 1996. Richard Orton is a legendary editor of The Lancet, and it defined surgical research a comic opera, but he was not the first one to do that, because in the early 1900, Major Greenwood, another legendary statistician, essentially used the same definition for clinical research in surgery. And this was mostly due that surgeons were doing and publishing mostly observational series rather than randomized trial, as our medical colleagues were doing. And you know, observational studies in surgery, comparative observational studies, are biased by definition. And the reason why they are biased is the same reason why surgery is successful, is because we are trained as a surgeon from the very beginning of our clinical training to adapt our intervention to the patient that is sitting in front of us. we do not do the same operation in two different patients. We individualize the surgical treatment to the individual characteristic of the individual patient. And this is, again, the key to success in clinical surgery. However, when you are then performing comparative study using observational, non-randomized data, this is a key challenge, because the reality is that you are not comparing two different interventions, but you are comparing instead two very different groups of patients. And there is no statistical adjustment that can overcome this key limitation. And this is an example, and we use an example from something that everybody knows very well, the use of bilateral versus single internal thoracic artery for bypass surgery. So we look at the literature that has been published over the course of 40 years, and we identified only the propensity match study. The propensity match study, as we all know, are the best level of observational evidence. Some methodologists call them quasi-randomized. So what we found, like we all know, at the end of the follow-up, patients who received the bilateral versus single internal thoracic artery had better survival. And this is expected, well known. But then we did something a little bit new and provocative. So we extracted the hazard ratio in the same study at 1 year. And the reason why we selected the 1 year time point is because we know that the patency rate of the saphenous vein and the right internal thoracic artery is essentially the same at 1 year. And if there are small differences, they cannot impact significantly an outcome like mortality. Well, at 1 year, we found that the hazard ratio was exactly the same that at 7 years. So this, to me, tells that the two groups were different, not because of the intervention. The intervention at 1 year produced the same result, but the difference in mortality is related to the fact that the two groups were different to start with. And unfortunately, even though we need randomized trial, we are not doing randomized trial. This is an analysis of the 10 most common surgical procedures in the United States, not cardiac surgery, overall surgery. And in red, you have the number of total study. And in blue, on a totally different scale, the percentage of randomized trial that you can see has been around 10% for the last 20 years without any sign of improvement. And this is the same looking at cardiac surgery. And I mean, we are not doing better than our general surgery colleague, with a percentage of randomized trial that has been consistently in the single digit compared to the total amount of cardiac surgery publication. So why we are not doing randomized trial? Well, there are several reasons, and we have identified some of them in this table. But essentially, there are three key explanations. First of all, it is difficult in surgical trial to enroll patients, so it's relatively difficult to get to a number that is meaningful. And then even when you do that, the number of events is low, so the statistical power in general is low. But then the other two key questions are the lack of equipoise and patient preference. Patients are less willing to accept randomization for a surgical intervention compared to a medical intervention. So let's discuss equipoise. What exactly equipoise mean, and why is it important? So equipoise, the definition is that is real uncertainty on the comparative merits of the two treatments. And it is the ethical basis of any RCT, you can accept to randomize the patient, so to leave to chance the choice of the treatment only if you really do not know what is the best treatment for that patient. And there are two different levels of equipoise. The professional equipoise is at the level of the profession. We as a group, we as a scientific community do not know if a single arterial grafting is better or worse than multiple arterial grafting. But then there is the individual equipoise, and that related to the individual surgeon in this case. Me, Mario Gaudino, really do not know, and so I am willing to randomize Mr. Jones, my patient from this morning, because I genuinely do not know what's the best treatment for him. So while professional equipoise is a key determinant of whether a study should be done, because it's the right moment for the field and for the amount of knowledge we have to know that study. Whether a study can be done or not depends on individual equipoise, because you can design the best clinical trial in the world, but if the surgeon do not have a personal equipoise, they will not enroll patients in the study, and the study will fail. And again, Dr. Orton also remind us that probably some of the personal characteristics that make of a surgeon a great surgeon are not necessarily those that are required for collaborative multi-center research. And this is very true. And unfortunately, some of us have invested a lot in, for example, a specific technique or a specific approach, and they may not be willing to test that approach in a randomized trial because they are concerned about the effect on the result on their career and reputation. The other challenge with surgical RCT is timing, and this is a very nice summary of it, Buxton Law, that is said it's always too early for a surgical RCT until all of a sudden it's too late. And the meaning of that is that surgical techniques are not perfect when they are introduced in clinical practice. They are generally introduced by innovator, but then perfected over the course of the time by the contribution of a surgeon or a group of surgeons that adopt them and slightly modify them. And also, more than often, industry and technology step in and provide instrument and device that make the operation easier. So if you test a new intervention too early after its introduction, that intervention is probably not yet mature. And so you take the risk of essentially shutting down something that could have been promising. But on the other hand, if you wait too much, there is the risk that the surgical community that just perceive that technique as better, or because the patient requests that technique rather than the old one, so the surgical community will just adopt the technique, and at that moment, there will be no equipoise, and the randomized trial will not be possible. And we have seen that with, for example, endoscopic technique in general surgery. Another key question is the surgeon effect. Well, we all know this is the seminal Nijm paper that for the first time defined a volume to outcome effect, but we know there is a volume to outcome effect in surgery. Repetition leads to perfection. This is the ART trial, and this is the crossover rate by surgeon, showing how some surgeons crossover in each individual cases they performed in the ART trial, whereas other surgeons essentially never crossover. And crossover, as we know, is a surrogate of experience with the operation. And crossover is problematic in all kinds of trial because it dilutes the treatment effect and clearly breach randomization. But in surgical trial is particularly concerning because it's a red flag for the methodological quality of the trial and suboptimal delivery of the intervention. If in a trial there is high crossover rate, I am concerned not only because of dilution of treatment and loss of power. But I am concerned that those surgeons are not familiar with the new intervention, and so potentially, even in cases that have not crossed over, the delivery of the intervention may be suboptimal. And we have shown using a meta-analytic approach that in cardiac surgery trial, when the proportion of crossover from experimental to control is above 7%, the trial are almost always neutral. There is no treatment effect. Now, how do we deal with that? Well, I have a good news and the bad news. The good news is that there are techniques to deal with the surgeon effect. You can define minimum case volume. You can monitor site and surgeon outcome like we are doing in Roma, using proctoring technique, pilot phase, running period. So there are methodological way of addressing the surgeon effect. But when we looked at all the surgical trial published from 2018 to 2020 with one of my fellows, we found that the overwhelming majority of trials did not take the surgeon experience into consideration. They did not account for it or adjust for it in any way. But not only that, almost all trials, 95%, did not monitor in any way the quality of the surgical intervention. And even more concerning, the majority, more than 60% of the trial, did not provide a detailed description in their protocol of the experimental procedure. So if you don't even describe how the intervention should be performed, you cannot expect that it's performed appropriately and in a standardized way. Now let's switch topic, and this is something that has been discussed very often, what the outcome of surgical RCT should be. Well, the issue is that important clinical events, yes, clearly they are important for the patient and the trialist, but they are relatively uncommon. So that's why you need to use composite outcomes that include a variety of clinical events and increase statistical power. The problem with doing that is the choice of individual components of the composite outcome. And the key is that the individual component of the composite outcome should share the same common pathophysiology and have the same clinical relevance. Because in general, less clinically relevant events are more frequent. And there is the risk that they can drive the primary composite outcome even in spite of a difference in more important but less frequent clinical events. Now, lately, the use of hierarchical composite outcome, such as the win ratio, has been proposed as a new and, in my opinion, interesting solution to this problem. Another question is, in particular, with regard to mortality, what kind of mortality to use in a primary outcome of a randomized trial, all-cause mortality versus cause-specific mortality. And yes, sure, all-cause mortality is the most solid outcome because there are no bias and error in adjudication. However, it's also the less sensitive of the measure. Here, this is not a surgical trial, this is a trial on heart failure. But you see how the treatment effect becomes progressively larger when we go from all-cause mortality to cardiovascular mortality to mortality due to heart failure. Because mortality due to heart failure, because this is a heart failure trial, is the most sensitive of the outcome. However, look also how wider are the confidence interval compared to all-cause mortality because the power is clearly lower. Now, what about blinding? Well, blinding, it is important. It reduces bias by patient and caregivers, and it is particularly important when you are assessing outcomes that are not by their nature objective, such as, for example, quality of life, of length of stay. But in surgical trial, blinding is problematic. This is the classic pyramid, as you know, of surgical intervention is problematic and is generally not done, with few exceptions. And this is a trial that was comparing open versus open surgery versus laparoscopy for cholecystectomy. And the author went to a great length, actually using dressing that were stained with blood-stained fluid to mimic a real intervention. But that is just an historical reference. In reality, blinding in surgical trial is very uncommon. In our systematic review of surgical trial, the majority of trials did not use any form of blinding, and in the best case scenario, only the assessor or the patient and the outcome assessor were blinded. I've mentioned one of the challenges, enrollment. So in our systematic review, 20% of the surgical trial did not reach the target sample size. And if you look at the missing percentage of the amount of patients that were not enrolled compared to the sample size that was originally planned, well, the majority of trials missed their sample size by more than 25%, with some of them not enrolling only half or less than half of the patients that they have initially planned. But even when we reach the sample size that we have planned for the surgical trial, there are very important issues in underrepresentation of racial minorities and of women that generally represent less than 15% of the patients that are enrolled in surgical trials. And another very painful from NIH, overall funding of the NIH has gone up in the last 15 years. But when you split between medicine and surgery, the trend is evident for medicine, but for surgery is the other way around. There has been a reduction in funding for surgical trial. Now we do not have the denominator. Why is that? It's because we as a surgeon are applying less often to NIH, or is because our grant proposals are being rejected more often? We do not have the answer, but we know that funding for surgical trial is challenging. And it's particularly challenging because the industry in general is not interested in surgical trial unless a device is involved. But in trials that compare to surgical intervention, when there is no new device, there is no new drug, industry is not interested. And in fact, here we are looking at the difference in funding between industry-sponsored trial and investigator-initiated trial for surgery and for interventional cardiology. And you see how in interventional cardiology, the industry-sponsored trial are much more frequent than in surgery. I want to touch about the issue of superiority versus non-inferiority, because I think this is a misconception. Now we have this general concept that non-inferiority trials are the devils and they are bad, and I would disagree with that. Superiority and non-inferiority trials are intrinsically different. A superiority trial is meant to establish that one treatment is better than the standard of care. A non-inferiority trial is designed to demonstrate that a new treatment that may have advantages that are different, that improve the efficacy, for example, in terms of being less invasive or costing less money, is not unacceptably worse than standard of care. So the approach is different. The key for non-inferiority trial is clearly the definition of the non-inferiority margin, and there are no statistical rules to define a non-inferiority margin. It is an expert opinion-based decision, and clearly this is where some of the issues sometimes arise. And also, something that generally people ignore, methodological quality in general affect the result of a trial, but in a very different way. everything that reduce methodological quality in terms of low recruitment, low event rate, high crossover, high loss to follow-up, all these bias a superiority trial toward the null hypothesis, towards showing no difference between group. But it's the other way around for non-inferiority trial. For non-inferiority trial, the worse is the quality of the trial, the higher the possibility that the trial will meet non-inferiority criteria. So that's very important to keep in mind. I like the fragility index. The fragility index is defined as the minimum number of patients where status would need to switch from non-event to event to render a significant result not significant. In other words, if you have a trial that have shown a statistically significant difference between the two groups, the fragility index tell you how many patients would need to switch from one group to the other to make that significant result non-significant, on how many patients is the positive result of a trial based. And clearly, the lower the fragility index, the lower the solidity and the robustness of your result. So we have looked at the fragility index for surgical trial published over the course of 20 years, and I mean the number is pretty low. It's 3, meaning that the median number of patients that explain and support the result of positive trial is 3. And when you calculate the fragility index minus the number of patients lost to follow-up, which is a particularly important metric because we all know that patients lost to follow-up may experience more frequently events. That number is 0. So not only we do not perform a lot of randomized trial, but our randomized trial are also not very solid. Another issue is the reporting bias or spin. Spin is defined as the use of strategy that in presence of a lack of statistically significant difference tended to imply that a statistically significant difference may have exist. And there are way of objectively measuring spin in clinical trial. We have done that for surgical trial, and we have found a concerning increase in the use of spin strategy over the course of the year. And also we have found that overall more than half of surgical trials that were neutral were presented with some kind of reporting bias. So I hope this short overview of surgical RCT was not too boring, and my quick conclusion would be that randomized trials are essential to estimate the treatment effect in surgery. Comparative study based on observational data are essentially meaningless. However, in surgery, randomized trials face additional specific challenge compared to medical trial. Equipoise, delivery on the intervention, and binding are often problematic issues. However, as a community, we need to design a better randomized trial and really stop wasting money and resources on observational study. And having said that, I thank you for your attention. Happy to take any question.
Mario, thank you for your outstanding talk, as always. So I'm not sure whether you're able to see us or not, but
yeah, I can see you.
Today with me are 3 prominent academic physicians on the stage as a panelist. And introduced to them, this is Professor Petar Tashević, clinical and interventional cardiologist. Then we have Professor Goran Stanković, interventional cardiologist, and then it's Professor Slobodan Mićović, cardiac surgeon. And I'm sure that they have some question for you.
Okay, Professor Gaudino, first I want to thank you very much for sharing your knowledge with us and to give us such a wonderful presentation. Just one short question. Is there any non-coronary trial, randomized trial that you will do now that you will recommend the timing and that it's doable at this moment?
Well, sure. I mean, there are a lot of them. I think, for example, we are in the phase of launching. It's called EPIC, and it will be a multi-center randomized trial testing the posterior pericardiotomy hypothesis. Because, as you know, in a single-center trial, we have shown that posterior pericardiotomy, left posterior pericardiotomy, may reduce significantly the risk of postoperative AFib. So it's a very good hypothesis that we have generated, the potential important because postoperative AFib is the most common complication of cardiac surgery. But that was a single-center trial performed at Cornell, and so we needed to test that the intervention works in the real world. So together with the cardiothoracic surgery network, we are working on a multi-center confirmatory trial. I am also a great fan of the primary trial that Joe Chikwi is leading, that is comparing transcatheter versus open repair of organic mitral valve insufficiency, because I think this is a trial that we need to do as a surgeon before a company does it and show clearly non-inferiority. I mean, I'm not saying non-inferiority doesn't exist, but I think it's better that if we as a surgeon design a fair trial rather than waiting industry to step in and design the usual trial that go in the direction that they want. So, and finally, what I really believe now it's important is the role of, we all know the debate about ischemia. I think it is the time to revisit all the paradigm in terms of revascularization and probably test even surgery against medical therapy in selected group of patients.
Thank you very much. One more regards from Belgrade. Hope to see you next year here.
Thank you. Thank you.
Professor Gaudino, my name is Goran Stanković. I'm interventional cardiologist from Belgrade, Serbia, and I have conflict of interest that I'm also president of the European Bifurcation Club. So my question for you is related to the Excel, but more in general to use of definition of periprocedural myocardial infarction when we compare PCI versus bypass in left main or in multivessel disease. There are some opinions that we should not take into account at all periprocedural MI when evaluating long-term outcome of both procedures. And the second more practical small question is how much in your daily practice you use syntax score, any of the variants, to individualize treatment decision for each individual patient. Thank you very much in advance.
Well, thank you. Those are both great questions. So let's start with the perioperative MI. Look, the challenge, I don't think the issue is if PMI is important or not. I think PMI is important. And every form of large myocardial necrosis is important for the patient, no doubt. Now, the problem is that we do not have a definition that is fair to both interventions. The two interventions, PCI and CABG, are intrinsically very different interventions. So using a definition that apply the same criteria to both is probably a mistake. But on the other hand, using definitions that are too sensitive to biomarker elevation is also not fair. So we really need to work on a better definition of PMI, but I do not think that the solution is to ignore it, because large PMI are relevant. I agree that there are probably small PMI that are not prognostically important, probably more in surgery than PCI, but this is not proven. But large PMI are clearly relevant, and this is something that has been consistently seen, no matter what the definition has been used. So I think that the solution that I have heard of excluding PMI from the outcome is a simplistic solution, but it's not the right solution. It's just ignoring the problem. A much more complex but more appropriate solution is to define, to work on a definition of PMI that is prognostically relevant and take out the background noise. Now, I do not use the syntax score at all, but I definitely look very carefully at the severity and extent of coronary artery disease. I was a strong proponent of the downgrading of the syntax score in the ACC/AHA guideline to a class 2B. It's not that I do not believe that complexity and extent of coronary artery disease should not be the key to individual revascularization decision. It is very important. It's just the syntax score per se that has a very important limitation. First of all, there is a large variation, as you know, between different operators in evaluating and calculating the syntax score. And also some, as you know better than me, some anatomic location give a very high score, whereas other even more important plaque distribution give very low syntax score. So I think overall the severity of coronary disease is very important, but the syntax score is kind of an imperfect method of measuring it.
Yeah, thank you very much. I fully agree with your comments on peri-procedural MI. That was just discussion between surgeons and interventionists at big meetings, so I really wanted to know your opinion. Thank you, and looking forward to seeing you next year in Belgrade. Thank you.
Thank you.
Hello, my name is Petar Otašević. I'm cardiologist from Belgrade, Serbia. First of all, I would like to thank you for a very insightful lecture regarding the current status of clinical trials in surgery. So being cardiologist, I would just like to ask you one question. Because we see in cardiology that the landscape of clinical trials are generally changing. So we're moving to a more focused clinical research based on phenotyping particular patients, having smaller and more feasible and cheaper trials. So how does this fit into cardiac surgery? And the other one is that we're seeing that the scope of the clinical trials in cardiology is more and more moving towards quality of life. So I would like to know what is your opinion on that issue as well.
Well, let me start with the second, because I am a great advocate, and actually Greg Stone and I have designed the first PCI versus CABG trial that was primary outcome is quality of life. And I think this is really the new model for revascularization trial, because of the challenge that we have in the definition of non-fatal events. I mean, we have discussed PMI, but you can say exactly the same thing about stroke. 20 years ago, a stroke was always a clinically meaningful stroke. Nowadays, with new MRI and more careful diagnosis, you can have a patient that had a stroke and is totally asymptomatic. So the two things, if you are hemiplegic or you have no symptom, is not the same, right? And but they are both counted in a classical clinical trial as event, as a stroke. So I think overall, probably quality of life is the right answer to our challenge in defining non-fatal events. If any event, MI, stroke, repeat revascularization, another challenging task. So if any event has an effect on patient quality of life, then it's an important event. If not, then it's not important. So probably quality of life should have a very relevant role in the primary outcome of revascularization trial. There are challenges in doing that, analytical challenge, methodological challenge. You must use the hierarchical component, but I think this is exactly the direction where trial should go. And more in general, I would say that, that probably answers your first question. I think we should, we have been doing the same trial that the Oxford group was doing for thrombolysis versus not thrombolysis in the 80s, trying to show if one technique is better than the other in a relatively selected patient population that is not representative of clinical practice. And then we are all excited about the P for non-inferiority or the P for superiority. Is PCI better? Is PCI non-inferior or not? This is totally the wrong question. PCI and CABG are there to stay. They are not going to be abandoned because one trial showed non-inferiority or lack of superiority. The question that the trial needs to answer is in which patient one can provide different result. I'm not saying better result, but different result than the other. And what is the temporal horizon? I think we have understood that if you look at the mortality, there are not really a lot of difference, at least for the first many years. If you look at repeat revascularization and MIS, there are differences, but in the long-term follow-up. So I think the patient need to be informed on the difference that are mostly different in the temporal horizon of the two interventions, and based on that can make his or her choice. But we don't have that information except for the very selected group of patients that we have enrolled in randomized trial. So I would say that the new generation of randomized trial should be much larger, not smaller, include a more heterogeneous group of patients, so that can provide estimate of event rate at different time points for the two interventions, and that will be the foundation of individualized treatment decision. Honestly, I don't think that the trial that is testing again if surgery is better than PCI makes any sense. What are we going to do? Are we abandoning the PCI or CABG because the trial show that one is better than the other? That is just clinically makes no sense.
Thank you very much for your answer. Just one quick question. Should we go for disease-specific questionnaires for quality of life or more general?
Great question. I would say general because you don't treat the heart only, right? You treat the whole body, and especially with surgery, there are implications that are not only cardiac. The problem with like the SF12 or the whole SF family is that they are not very sensitive measure, so you can miss difference just because of the fact that the instruments are not very sensitive, whereas disease-specific instruments like the SAC are much more sensitive. So if you want to know what Greg and I have done after months of discussion, the SF12 is in the primary outcome, not the SAC. But I can see both ways. I think we need to also develop better generic quality of life instrument.
Yeah. Thank you so much once again.
Thank you, Mario. Very, very provocative answers, I must say. But I also agree with you getting back in 2013 where we discussed the design of Excel. And then I had, of course, a lot of discussion with Peter. I was his fellow then, and he told me that there is only two important outcomes in any clinical trial, and that's mortality and quality of life. But we don't have a way to measure the quality of life. And then we use the quality of life for the win ratio as a secondary analysis in that trial. But I know that you are very busy. I hope you will allow us to have one or two questions from the audience. You have 3-4 minutes more. Thank you very much.
Sure.
Professor Perić, Miodrag Perić, he has a question for you.
I'm just waiting for the microphone. Good morning, Mario. I suppose it's morning in New York, right? Okay, yes. So I would like to know what is your personal attitude regarding intent to treat principle. To my personal opinion, it is really biasing most of the studies, and even poisoning most of the studies. And it is the cause of our bitter discussions regarding many studies which are relevant to our clinical practice. What do you think? Should we blame them, this principle, or we should support it in the further studies?
Well, clinically, I understand what you are saying, and I always struggle at the beginning of my academic career to understand why exactly, if a patient did not receive an intervention, I should count that patient in the group that received that intervention. That doesn't make any sense to me. That was my initial reaction. But and again, clinically, that is a very reasonable concept. However, the key strength, the real strength of randomized trial is random treatment allocation, because random treatment allocation match not only for known, but most importantly for unknown variable that can affect outcome. And so the only poor estimate of treatment effect derived from a randomized comparison. Anything else than the ITT analysis, unfortunately, breach randomization and introduce bias. So if you use any other form of analysis, you are essentially doing an observational analysis within the context of an RCT. So I understand it is painful, but I am a supporter of the ITT approach.
Yeah. Thank you.
Yeah. So final question, any final question for Dr. Gaudino? Okay, Mario, once again, thank you for your time. It was a really outstanding talk, and on the behalf of the association and the all people in the audience, we are really grateful for your time. Thank you. Thank you once again.
It is my pleasure, and I hope to see you soon. Bye-bye. Ciao. Bye.
So
ladies and gentlemen.
Before we conclude, I would like to give a word to Dr. Mićović, but I also this morning missed to thank Dr. David Gliner for his presentation. Unfortunately, due to technical reason, because he's located in Ottawa, it was impossible for him to join us in 3 in the morning, but he was really eager to be here in person, but many things happened, and I look forward to seeing him next year. So, Professor Mićović, could you please conclude?
Thank you very much. I want to conclude this, to close this session. And we heard so many very nice presentations, and unfortunately we didn't have too much time for discussion, but maybe we can do it during the break. So now we will use now we will make a half an hour break, and we will serve lunch in the restaurant just beneath, just at the...
Nastavit ćemo na srpskom, takav je bio i dogovor, a čini mi se da je sada i unilingvalno odnosno unilingvalna publika. Veoma kratko, kada sam dobio zadatak da kažem nešto o jednom, 2 ili više arterijskih graftova u kardiohirurgiji, mislio sam da će taj zadatak da bude mnogo jednostavniji, odnosno mislio sam da ću proći kroz nekoliko studija radova i izaći pred vas sa zaključkom da što više arterijskih graftova, to je prognoza za bolesnika bolja. Međutim, već kad pogledate naše i dalje važeće preporuke iz 2018. godine, a deo preporuka koji se odnosi na hirušku tehniku i za nas nekako jako važan, po prvi put sa nekako jasnim smernicama po pitanju mnogih tehničkih aspekata hiruške revaskularizacije miokarda, dakle nekako jasne preporuke, pa dođete do ovog poglavlja Conduit Selection, vidite da nije prvo sve zeleno, dakle da imamo nešto što je zeleno, nešto što je 2A nivo dokaza, a da je, 2A klasa, a da je nivo dokaza sve B. Dakle, nemamo praktično ni jedan dokaz koji je proizašao iz više prospektivnih randomizovanih studija. I zaista, ono što je za nas jedna od najvećih istina u kardiohirurgiji, a to je da je lima na LAD zlatni standard u revaskularizaciji miokarda, pa taj zaključak je proizašao iz ove studije. Dakle, mi radimo i pričamo da je mamarija na LAD zlatni standard, odnosno najbolja terapijska opcija za svakog bolesnika još od 1986. godine na osnovu studije koja je zapravo jedna observaciona, retrospektivna studija, istina obuhvatila veliki broj bolesnika, negde preko 5000 bolesnika, u kojima je pokazano da bolesnici koji imaju samo venske graftove imaju 1,6 puta veći rizik od smrti unutar 10-godišnjeg perioda. I na osnovu toga, širom sveta mamarija je postala praktično merilo kvaliteta usluge koje kardiohiruška ustanova koje kardiohiruška ustanova ima. Dakle, naša današnja priča bi trebala da izgleda ovako, ili sam je bar ja tako zamislio. Arterijski graft ima bolju prohodnost, samim tim to će rezultovati manjim brojem MACE-ova, samim tim imat ćemo manje repeat revascularization rate i na kraju imat ćemo bolje dugoročno preživljavanje. I onda imate niz radova koji su se bavili limom i svi ti radovi su observacione retrospektivne studije. Ovo je jedan od njih, objavljen nakon 18-godišnjeg, odnosno 20-godišnjeg follow-upa, gde se poredilo 100 bolesnika operisanih sa limom, izolovanih LAD proksimalnih stenoza i 100 bolesnika koji su dobili venske graftove. To su bili konsekutivni bolesnici, dakle nivo dokaza je možda malo veći nego da se radi o klasičnoj retrospektivnoj studiji, all comers tip studije, i viđeno je da je upotreba unutrašnje leve arterije mamarije dovelo do boljeg preživljavanja unutar 18-godišnjeg, odnosno 20-godišnjeg vremenskog perioda. I mi smo sa tim taj deo priče završili. Potom imamo zadatak da kažemo nešto o multiplim arterijskim graftovima. I meni je veliko zadovoljstvo što nakon mene profesor Perić i doktor Žika Jonjev imaju praktično prezentacije koje će nam ući u još malo više detalja vezano za ove teme i zato ja i predlažem da mi diskusiju imamo nakon ove 3 prezentacije. Dakle, nivo dokaza nam je, klasa dokaza je 2A, nivo B. Opet imamo pretpostavku sada da je više arterijskih graftova, će dovesti do još boljeg prohodnosti tih graftova, do još manje MACE-ova, do manje ponovljene revaskularizacije i boljeg dugoročnog preživljavanja. I kada pogledate ovaj veliki review, dakle meta-analizu, kojom je obuhvaćeno preko 15.000 bolesnika, 7 studija koje su ispunili inclusion criteria za uključivanje u ovu veliku meta-analizu, u kojoj se analiziralo, dakle, poredili bolesnici koji imaju jednu arteriju, mamariju u odnosu na bolesnike koji su imali više, odnosno najmanje dve anastomoze sa drugom arterijom mamarijom. Rezultat je da je preživljavanje bolje, ali i dalje nemamo ni jednu randomizovanu studiju i dalje možemo samo da izvučemo zaključak da je bilateral ima zapravo izgleda da daje bolje rezultate nego jedan arterijski graft. I onda smo dizajnirali veliku studiju, prospektivno randomizovanu, po prvi put hirušku studiju koja se bavila temom 1 versus najmanje 2 arterijska grafta. To je inače najveća studija, odnosno studija koja je uključila najveći broj bolesnika. Ako je posmatrate kao broj bolesnika i broj godina follow-upa, dakle 10-godišnji follow-up, preko 3000 bolesnika, mislim da je nešto 3012 bolesnika recimo uključeno u ART studiju, ona je veća od svih ostalih koronarnih studija, dakle i studija koje su se bavili interventnom kardiologijom. Imali smo 10-godišnje rezultate koji su, ja bih ipak rekao, nažalost, bili negativni ili, ajde preciznije izraženo, rečeno ne negativni, nego neutralni. A zašto je to tako? Pa kad malo pažljivije tu studiju analizirate, prvo što možete vidjeti da imala jedan jako ovako puristic endpoint, a to je samo mortalitet. Dakle, to je bio prvi endpoint ove studije, naravno intention to treat analiza. A onda kad pogledate da je zapravo 40% od ovih 3000 bolesnika dobilo drugačiju terapiju nego što je bilo namenjeno, onda shvatite da rezultati te studije jako teško mogu biti interpretirani u jasnom i izneti u jasnom naučnom dokazu. Naime, 14% bolesnika kojima je bilo namenjeno da dobije 2 mamarna grafta, dobila je zapravo samo 1, a 22% bolesnika koji su imali jednu mamariju, odnosno levu mamariju na LED, je dobilo radijalnu arteriju. U to vreme još uvijek nisu postojali dokazi da radijalna arterija može uticati na preživljavanje, dugoročno preživljavanje koronarnih bolesnika. I na kraju jako važan komentar, a to je hirurško iskustvo. Naime, uslov da bi bili centar koji može da uđe u art studiju, ja mislim da je bilo 28 centara koji su uključeni u studiju i da imate hirurga koji ima preko 50 bita. Ispostavilo se da taj broj nije dovoljan ili da neki hirurzi nisu se pravilno prijavili. I kod hirurga koji su imali mali broj bita prijavljenih kao svoje ranije hirurško iskustvo, imate jako visok rate crossovera, dok kod hirurga koji koriste totalnu arterijsku revaskularizaciju u svakodnevnoj praksi, rate ovih crossovera je praktično 0. U svakom slučaju mi smo ostali bez jedne prospektivne randomizovane studije koja može da nam digne nivo dokaza ili koji može da promeni klasu dokaza za dvostruku arterijsku revaskularizaciju. A šta je sa više arterijskih graftova? Dakle, ponovo pretpostavka da bi svi arterijski graftovi doveli do još bolje, odnosno imali bi još bolju prohodnost svih graftova, imali bi manje mejsova, manje ponovljene revaskularizacije, bolje dugoročno preživljavanje. I kada pogledate ovu analizu, ne znam da li je Milan u sali, ovo je podgrupa ili subanaliza sintaks studije, dakle, hirurška ruka studije podeljena je na multiple arterijske grafte ili jednostruki arterijski graft i viđeno je da je u grupi koja ima višestruku arterijsku revaskularizaciju dugoročno preživljavanje, 10-godišnje preživljavanje je bolje. Ali opet kada to izanalizirate vidite da su ti bolesnici bili mlađi i da su imali manje rizika. I ako se ne varam, Milane, ispravi me, propensity matching analizom nije ustanovljeno da postoji značajna razlika između grupa. Zaključak i te studije bi ponovo bio da bi svi arterijski graftovi mogli biti bolji nego jednostruki arterijski graft. I na kraju dolazimo do analize i radial triala. Ja mislim da će profesor Perić nešto više o tome reći, pa zato ne bi ni ovde dužio, odnosno Roma triala koji je nešto što bi trebalo u budućnosti da nam da odgovor. Ja znam da su kolege sa Dedinja direktno uključene u Roma trial. Mislim da je i dalje u toku enrollment i da sa velikim nestrpljenjem čekamo rezultate takve studije. Zašto je to važno? Pa videli ste na osnovu ovoga. Mi zapravo ne možemo da damo nikakav take home message, ili bar ja ne mogu da ga dam. Ja se izvinjavam panelu zato što sam ovako zaista vrlo brzo sastavio jednu seriju pitanja, dakle, koje, izvinjam se zato što sam im uzeo posao, dakle, da li je drugi arterijski graft, odnosno procedura izbora za sve bolesnike ili, a to je opet, kažem, pitanje za sve nas, treba da razmotrimo patient life expectancy, rizik od komplikacija sternuma, da razmatramo kakva je koronarna anatomija, da razmišljamo o stepenu stenoze, krvnog suda, kakav je kvalitet graftova koji možemo da dobijemo i naravno kakvo je hirurško iskustvo. Sa druge strane, šta raditi sa hitnim bolesnicima, šta raditi sa podgrupom dijabetičara koja je ogromna grupa bolesnika, šta recimo raditi kod bolesnika kod kojih je revaskularizacija konkomitantna procedura kod intervencija na aortnoj valvuli, a takvih bolesnika imamo u ogromnom broju i oni su svi u podmakloj životnoj dobi i svi imaju visok frailty index. I potom recimo, da li biste vi stavili radijalnu arteriju teniskom treneru, ja sam ga operisao, desnorukom ili levorukom, potpuno svejedno. Da li biste stavili radijalnu arteriju čoveku koji svira klavir i od toga živi? Da li biste stavili radijalnu arteriju na stenozu od 70%? I na kraju, ipak, i pored toga što postoje određeni evidence-based dokazi, da li biste stavili radijalnu arteriju koja je skoro urađena, kroz koju je skoro, odnosno koja je bila pristup za skorašnju kateterizaciju.
I najvažnije pitanje, da li biste stavili radijalnu arteriju hirurgu?
Tako je. I to sam imao, i tu dilemu sam imao si i ti. Jeste. Dakle, ja bih sa ovim završio. Zahvaljujem se organizatoru na pozivu za učešće na ovako sjajno organizovanom sastanku. Bilo je pravo zadovoljstvo, meni je žao što nisam došao jutros jer sam shvatio kakav niz fantastičnih predavanja je ovde održan, a ova poslednja sesija i naše ovako keynote lecture su bili zaista neverovatni. Hvala, profesore Mićoviću.
Hello. Okay. Thank you very much, Dr. Putnik. We go on to the next presentation. It's about when, which, and how to use Rita for cabbage. Is presented by Dr. Joniev.
Thank you so much for giving me a chance to present this topic on this very and extraordinary organized meeting. I would like to start this presentation with a, I have nothing to disclose. I would like to start this presentation with a little background. Professor Putnik told us a little bit about background of this approach. This paper was published about 35 years ago, and we all witnessed during the last 35 years that the results published in a New England Journal of Medicine is actually true. Our clinical practice confirmed that arterial grafts are much better than venous grafts in a term of survival, less MACE during the long-term observation, and this is a kind of a paper and a kind of a graft which is a pretty good base for every single publication published during the last 35 years witnessed this conclusion. 35 years after that, Bruce Lytle, who is actually a co-author of this paper, gave a statement a year ago that if you use 2 memories for myocardial revascularization, it is equivalent of no diabetes in diabetic patients. So this is another step as a confirmation of the previous statement that 2 memories are much better than 1. Bilateral IMA has been recognized as a more advanced surgical option. However, there are some traditional exceptions and traditionally accepted limitations for this sort of surgery. And these traditionally accepted limitations are age, because a lot of people propose this surgery for only younger patients. Sex, most of the surgeons propose this operation for male instead of male and female. Diabetes is another limiting factor. Chronic obstructive pulmonary disease and obesity are also traditionally accepted risk factors for this type of surgery. And I would like to say that these limitations have been accepted in patients who received pedicled, not skeletonized IMA, published during the last 20 years or so. So we witnessed a lot of advanced techniques and a lot of improvements in the surgical approach during the last 10 years. And I can say, as a surgeon who is doing a lot of coronary patients, that one of the most advanced surgical subgroup of people improved cardiac surgery in the aspect of coronary surgery. And everybody who is doing coronary surgery noticed that a lot of improvement happened during the last 10 years. And we should make a lot of different approaches, statements, and overviews about what we are doing in this specific subgroup of patients that we are dealing with. One question is still on the panel: which type of surgery is better, pedicled versus skeletonized? And I always want to show during the presentations this slide published by Calafiore and co-authors, that skeletonized IMA is less traumatic to the sternal bone instead of pedicle IMA. And that's one of the reasons why I'm trying to do bilateral skeletonized IMA and promote bilateral skeletonized IMA wherever I go. You can create configuration with bilateral skeletonized IMA on many different ways. But one way, which is anatomically, from my point of view, the best, is using bilateral skeletonized IMA for different coronary territories. This morning was a presentation with a take-home message that if you give arterial revascularization to different coronary territories, you can achieve much, much better result on a long-term run than using only arterial grafts for one coronary territories. So this is a concept presented here on a front page of the book recently published by David Taggart and John Pushkash. And I would also like to present my personal results in this approach and in this field of coronary surgery. We can divide mammary artery usage in two different phases. One phase is harvesting and the second phase is deployment. And both of these phases are extremely important. And one of the biggest mistakes that we can make during our surgery is to give an unexperienced surgeon to do one of these two phases, because if one of these two phases of this coronary surgery is doing with a less experienced surgeon, you can compromise the complete results, overall results. So in this phase of harvesting, it is extremely important to follow all these aspects of harvesting that I stated here. So after 25 years of doing skeletonized IMA, last year I switched my operative technique to skeletonized harvesting with harmonic technology. I believe that it is much better, and I also have preliminary results as a personal results that the flow rate, quality of the graft, and every single aspect of the graft is much better than skeletonized harvesting with clips. So I call this clipless skeletonized IMA with harmonic technology. You should always use no-touch technique, keep the intact pleural space. This approach gives us a chance to have extensive graft length, to complete and detailed visual inspection of the graft, and the positioning of the graft is extremely important. I usually put it in a Frankenauer pathway, which gives us a chance to have a good position without pressure and to avoid pressure of the other structure which can compromise the flow in the IMA. This is a little movie that I want to show to you, how we do this nowadays. Could you start the movie? So we use this old-fashioned retractor for the last 30 years or so, which gives us a very good exposition. We try to use a lot of different types of retractor, but every single retractor that we are using usually makes a significant pressure. Can you turn the sound off, please? So every other retractor gives us an unavoidable pressure to the right side of the chest instead of only lifting the left side of the chest, which sometimes gives us a hemodynamic instability, and this retractor actually avoids all of this. So this is the first phase, putting retractor on a good position. The second phase is dividing fat from the endothoracic fascia and giving us exposure of the mammary artery launch. This is extremely fast and not time-consuming. The third phase is the exposition of the mammary artery. You have to cut the transversal muscle, and you have a good exposition after that. And as soon as you get the exposition of the mammary artery close to the diaphragm, you can use venous spots and cut the endothoracic fascia, and that gives you a chance not to damage pleural space and to keep it intact. And the next phase is extremely important because the harmonic scalpel has a very, very specific tip. And I was planning to use it many years in the past, but it was practically unusable because of this phase. I was not sure how I can prepare the lodge of the mammary artery only with harmonic scalpel. But now I'm using the tip of the catheter just to divide mammary artery from the lodge without electrocautery, just to use it as a blunt tip, and after that, after exposure of every single branch that you have in the mammary lodge, I use harmonic scalpel and cut every single branch without putting any clips at all. So the timing of this procedure is about 5 to 6 minutes, and you can see that the exposition and everything is very clear. every single structure is visible. The inspection of memory artery is nice and easy, and we are not using clips at all. This operative technique is very convenient for the small memory arteries, and it gives a chance to a surgeon with a less technical performance to achieve excellent results in harvesting of the memory artery. I believe that this is very, very important, especially for a surgeon who is in the middle of his training with a lack of experience.
Okay.
This is how it looks like at the end. And when you finish this, you can just switch the retractor to the other side of the chest bone, to the other side of the sternum, and do it in a reverse fashion, like the picture in the middle. There is no trauma, there is no blood, there is nothing. This operative techniques help us to save time and to improve the initial blood flow.
Okay.
So this is the full memory artery after harvesting with harmonic technology. There is no clips at all. And you will see another picture with the initial flow of the memory artery just before the implantation, which is extremely good. So deployment is also important. We use 8-0 monofilament stitch, in and out technique, single or sequential grafting, and it is extremely important to know that memory artery is underutilized if you use only one, if you use it just for one anastomosis at all. So in the last 10 years, we did this study with 211 patients in a propensity match scoring fashion. And you can see some of the risk factors presented on the right side of these slides. All of these have a diabetes, COPD, hypertension, hyperlipidemia, smoking, and the family history. And
12 minutes
yes,
expired,
yes,
please.
okay. So these are preoperative data, and you can see that everything is pretty much the same. There is no significant difference in these two groups. Cross-clamp time is 62 minutes, and it was pretty much the same in both groups. The difference is not significant. And there is no immediate postoperative mortality in both groups. There was no perioperative myocardial infarction or cerebrovascular incidence at all. So there is no immediate differences between these groups. However, survival curve 10 years after surgery is significantly different, and the difference is about 6.5% between these two groups in survival. So if you have a thrombolytic therapy in myocardial infarction, with and without thrombolytic therapy, it's only 3% different. Cabbage versus PCI is 3% different, and there are a lot of arguments in that. But single versus bilateral IMA, the difference is 6.5 in a 10 long-term survival, and we should know about that and fight more for that. Long-term follow-up is reserved
13
for
minutes.
CT scan. And the contraindications are subclavian stiff syndrome, chest fibrosis, small insufficient flow for the memory arteries, and extensive graft atherosclerosis, and some technical difficulties in harvesting. Otherwise, there is no contraindications at all. So as a conclusion, I would say that memory bilateral IMA provides better long-term than single IMA. Harvesting with skeletonized techniques provides better length, visual inspection, and minimal trauma to the chest. Immediate and long-term results with bi-IMA are much better. Harmonic technology gives a chance to a surgeon with a lower technical performance to achieve perfect results in harvesting. IMA demonstrates the best results in coronary stenosis, over 75%. Long-term patency should be estimated by coronarography, not with the CT scan. And the implication of modern techniques for harvesting and deployment of IMA grafts make traditionally accepted limitations for the usage of IMA absolutely irrelevant. Thank you.
I would call the next presenter, Professor Perić, to talk us about his attitude and experience in radial arteries, graft in arterial revascularization, coronary arterial revascularization. Professor Berić, thank you very much.
So first of all, I would like to express my satisfaction with this meeting. I'm really nicely surprised how well structured the lectures I have heard today, and I will congratulate the organizers for the nice pickup of the subjects and the speakers as well. Okay, so my lecture today is not a controversy anymore. That's what I believe. So, as you all know it, radial artery in myocardial revascularization has been introduced like 50 years ago, but was very soon it was abandoned due to the miserable results of at 12 months, like 50% of occlusion rate of the radial artery. That was attributed to the tendency of the radial artery to spasm. But that spasm was induced by the manipulation, you know, because they were trying to overcome the spasm that was induced by the poor surgical technique, I assume, you know. They tried to put larger probes one after another, and then they completely destroyed probably the endothelium that we now understand it's extremely important in the patency rate of any graft, not only the radial graft. So, but of course, like it is in life, you know, everything comes to its closed circle. You know, in 1993, Akar, which was Carpentier's cardiologist, accidentally found several patent radial arteries 20 years later. So the interest for the radial artery started again, and then. Unfortunately, it was accepted in 90s, at least at 90s, as a graft in coronary surgery by a negligible number of surgeons. I'm proud of the fact that of 1997, we started to do radial artery occasionally. And then when Professor Mićović came from Australia, from Professor Tatulis, where they used the radial artery routinely, you know, he just pushed us to do this kind of graft, and now we have like thousands of radial arteries performed during the last 20 or so years. Okay, compared with other grafts in many studies to follow during the last 20 years, we got variable results due to the different reasons. I wouldn't have time to discuss all these reasons, but these unequivocal studies were not good for the surgeons to be sure that they should use the radial artery. But last year, finally, radial artery as a graft reached class 1A recommendation for myocardial revascularization. So, due to the fact that patency rate is steadily over 90% after 5, 10, 15 years of follow-up in majority of randomized controlled trials. So, when to use it? For the best long-term results comparable to the results achieved with the mammary, use it for the left coronary system. As simple as that. For the stenosis over 80, if you have over 90%, even better. For the coronaries, more than 1.5 millimeters, of course, but if not, smaller coronaries also will accept the radial artery nicely. Use only good radials, which means at least 2 millimeters in diameter, no calcification, no harvesting damage, of course. And then age doesn't matter, but younger patients will probably benefit more because of the lifespan, possibly new myocardial infarction, recurrent angina, and so on and so on. How to use it? Harvesting, gentle, of course. Don't naked the artery. Save the pedicle. Endoscopic is acceptable. But we still don't have, we have to wait to see the long-term results after endoscopic harvesting. But I believe that it will, like endoscopic vein, will be acceptable. Distal anastomosis, standard. Proximal anastomosis as appropriate. What does it mean? Of the ascending aorta in majority of cases, of the hood of the vein graft, legitimate, preventing late occlusion and loss of both grafts. Of the vein graft as Y anastomosis, only if short. That's at least my attitude. Of the mammary as Y anastomosis, only in absence of additional vein graft that you can put on the hood, of course. So you're doing 2 grafts, you don't have the vein to put it on. In a hostile ascending aorta, of course. If you judge the aorta, ascending aorta as not good place to put the proximal anastomosis, you will do it off the graft. As an extension for the other grafts used, which is rarely, but it's legitimate, it could be done, and that way you can even promote the total arterial revascularization if you want. So if properly treated, radial artery is a very friendly graft. That's my feeling about it. Easy to handle, difficult to twist, kink, or induce the spasm. Regardless of the fact that they regard this graft as a spastic graft. Of course, it is a muscular type of artery and it is prone to spasm, but gently handled, it's not going to go to the spasm. At least I've never seen one that went into the spasm. Okay, in whom? Of course, in young as well as in older patients, as long as the radial artery looks good. That's, of course, again, my personal attitude. In males and females, there is no difference. In diabetics, non-diabetics, of course. In patients with preserved as well as with low ejection fraction, no difference. In elective and in combined cardiac procedure. That was one of the questions that Professor Putnik raised up today. You can do it in combined cardiac procedures. It's really not a contraindication. In renal procedures, particularly since the lack of good saphenous vein, of course, you can do it. But in emergency, again, the question from Professor Putnik, if you are not in a hurry, of course, and you have a proper target, why not? But that is a question mark. Okay, so radial artery, how good are the results currently, today, 2022? Patency rate, early, over 90%, late, similar. Not much of the attrition rate. That is the difference between the radial artery and the saphenous vein, classical, the standard, the typical way of harvesting saphenous vein, but not if you are using no-touch technique. That no-touch technique is equally good graft. That is what is proved in a study that I'm going to show in a minute. Survival is excellent. Complications quite rare. Practically no complications we witnessed. Patient satisfaction very good, which was published by Dr. Milutinović and co-workers in one of the journals 4 years ago. How often it is used in 20s to 2020s? No data. Because there are some concerns among the surgical society to use the radial artery still in 2022. If we assume that it is still not used widely, the question is why? So fear of the hand damage, legitimate, okay, but if you do properly before the operation, if you examine the radial artery properly with the Doppler ultrasound echo, you are not going to have any problems. They are afraid of course, that radial artery is prone to spasm, followed by rhythm and hemodynamic instability in early postoperative course. Might happen, but we've never seen anything like that. Laziness, disturbing the everyday routine. Hard to believe, but quite frequent. That's what I learned, talking to people over the years. I'm convinced that the radial artery is a good graft. Confusing, why? Because we have confusing data in the earlier published literature up to 2015, particularly because of one of the studies that was published at the Cleveland Clinic. Absence of big randomized controlled trials or meta-analysis, including more patients, not really the fact anymore. Plus, we have Roma study pending that is going to include I think 3,500 patients, with a long follow-up. So we are going to know finally what are the results of the long-term patency rate. And at the end, satisfied with good, old, 40 years old strategy in myocardial revascularization. As old Chinese saying, the worst enemy of the good is better. So they don't want to make anything better than one good Lima on one good LAD, plus eventually a couple of good properly chosen pieces of vein, and that's it. So they don't want to change anything. And studies that are confirming the excellent long-term patency rate and good clinical outcomes, of course, RAPCO, RCVP, RAPS, and so on and so on. All of them have a reasonable and very nice patency rate of longer than 5 years. But this meta-analysis that has been published recently in Brazilian Journal of Cardiovascular Surgery analyzed total of 859 studies, of which 18 have been included in the final study because all others they discarded because of some mistakes, some flaws, they did not meet the criteria. So, but they have chosen 18 of these studies, including 6,500 patients, and they analyzed various combinations of radial artery versus right mammary, versus no-touch vein, versus standard technique taking vein, and so on, various combinations in these 18 studies. So in all of these studies, the patency rate is around 94%, roughly.
1 minute to time,
with
please.
average, thank you, with the average of 3.5 years of follow-up. So now finally we have something that we can lean on. And Rama study, of course, pending. Word of caution, preoperative assessment of the radial artery by echo Doppler is a must. So in Apple, 27% of patients with radial artery cannot be used for various reasons that we have published years ago, 14 years ago, Dr. Vuković and associates. Allen test is highly subjective and unreliable according to our opinion. Use of the radial artery for the RCA territory is highly questionable, at least. And patency rate is similar, because the patency rate on the right coronary artery is similar or even worse compared to saphenous vein. Use of the radial artery as a sequential YT or other kind of shapes of the grafts requires perfect surgical techniques, but is
12 minutes.
And we should avoid proximal anastomosis on the calcified or thick wall ascending aorta, regardless of how good you think you are. And finally, do not put any instruments into the right radial artery. Do not over-distend it, that's what we know. Blood or fluid at the room temperature is okay. Vasodilating agents or combination of agents are recommended. However, papaverine has pH of 3.5. Be careful. Put it externally only. That's for the younger surgeons. Clip the accompanying veins. They communicate with the lumen, so they bleed. So we have to be careful with that, but they probably keep the wall of the radial artery alive. So be afraid, but use radial artery, or to rephrase it, use radial artery, but be very cautious, even afraid. Thank you.
Thank you very much, Professor Perić.
Thank you. Thank you very much. We go on in the program. This time with endoscopic graft harvesting by Dr. Živković, please.
Poštovane koleginice i kolege, želim da vas pozdravim u ime Instituta za kardiovaskularne bolesti Dedinje. Danas ću pričati o jednoj temi koja možda više interesuje mlađe kolege koji se bave pripremom graftova za aortokoronarni bajpas. Praktično, endoskopska priprema graftova je krenula još sredinom 90. godina, tako što je endoskopska vena počela da se koristi naročito u Sjedinjenim Američkim Državama, gde je i ona najčešće zastupljena. Praktično negde oko 80% svih harvestinga vena je izvedeno ovom metodom. Nešto manje prisutna u Engleskoj, a kod nas uvedena tek 2019. godine i obavljamo relativno mali broj tih procedura sa tendencijom postepenog rasta i širenja na ostale centre. Trenutno se radi na Institutu za kardiovaskularne bolesti Dedinje. Što se tiče endoskopske radijalne arterije, koju takođe možemo koristiti, odnosno preparisati na ovaj način, ona je takođe uvedena u slično vreme kao i vena. Intenzivno se koristi ova metoda u Sjedinjenim Američkim Državama, a na našem institutu je uvedena 2021. godine i mi praktično tek počinjemo sa ovom metodom ovog harvestinga. Šta je primarni cilj endoskopske pripreme graftova? Znači, prevencija komplikacija koje nastaju tokom klasičnog uzimanja i preparacije graftova. Dobro znamo svi da takve komplikacije dodatno opterećuju naš zdravstveni sistem, odnosno naše bolnice. Veliki broj infekcija rana koji zahtevaju produženo lečenje predstavlja veliki problem, zatim bol i senzorne tegobe koje se javljaju u postoperativnom periodu su produžene i mogu trajati po više godina, što predstavlja jedan veliki diskomfort za naše pacijente. Sekundarni cilj ove metode jeste neki kozmetski efekat, manje više nekom je to značajno, nekom ne. Međutim, zašto ne primeniti takvu tehniku i smanjiti ožiljak i samu traumu kod bolesnika? Šta je osnovna briga kod uzimanja i preparacije graftova endoskopskom metodom? Zapravo koliko smo mi oštetili taj krvni sud tokom harvestinga, odnosno tokom preparacije. Uvek se postavljalo pitanje i oko toga koji je stepen oštećenja. Nažalost, nema puno randomizovanih studija i meta-analiza koje pokazuju te rezultate. Takođe je u studije koje su već publikovane uključen je mali broj pacijenata, što dodatno otežava donošenje nekog zaključka. Međutim, neke studije koje su objavljene, a koje su u značajnim časopisima, pokazuju da praktično nema razlike u oštećenju, stepenu oštećenja zida krvnog suda kada se harvestira na konvencionalan, odnosno klasičan način i endoskopski način. Takođe, studija koju je objavio profesor Gaudino u Interactive Cardiovascular Thoracic and Surgery pokazuje da nema razlike u stepenu oštećenja zida radijalne arterije, uzimanje na preparisane klasičnom metodom i preparisane endoskopskom metodom. Praktično, iz ovoga možemo da donesemo neki zaključak da ne može, odnosno ne postoje metode koje su grube, već hirurzi koji mogu svojom tehnikom da naruše tu metodu i da smanje kvalitet pripreme samog krvnog suda. Ono što je veoma značajno, a što predstavlja glavni cilj revaskularizacije, jeste taj outcome, odnosno klinički ishod koji nastaje nakon revaskularizacije. Velika meta-analiza koja je uključila ogroman broj bolesnika ispitivala je zapravo klinički ishode nakon harvestinga, odnosno revaskularizacije klasičnom venom i nakon revaskularizacije venom koja je preparisana endoskopskom metodom. I možemo videti da je praktično endoskopska metoda bila signifikantno bolja u prevenciji komplikacija, što je očekivano. Ono što je malo atipično jeste taj rani mortalitet. Moguće da je to neka, ovako da kažemo, više zbog studija koje su komparirale, pa je pokazala neku statističku značajnost, ali ostale stvari kao što su ostali parametri kao što su stenoza, zatim ponovni infarkt i revaskularizacija ponovna nije se pokazala signifikantno značajna u nekoj od ove dve grupe. Velika randomizovana studija koja je ispitivala preko 1000 bolesnika u 16 centara pokazala je da nema razlike u velikim događajima između ove dve grupe ispitanika. Follow-up ove studije je bio negde oko 3 godine. Kada govorimo o radijalnoj arteriji, odnosno kliničkim ishodima nakon revaskularizacije endoskopskom i klasičnom pripremljenom radijalnom arterijom, opet isti rezultati, zapravo komplikacije rane su manje bile učestale u endoskopskoj grupi, što je očekivano, dok je prohodnost graftova, dugoročno preživljavanje i mortalitet bio jednak u obe grupe. Ovo je praktično naše istraživanje koje smo sproveli na institutu. Komparirali smo tri grupe u koje smo uključili sva tri načina harvestinga ove vene. Koristili smo klasičnu venu, no touch, preparisanu venu i endoskopsku venu. imunohistohemija, odnosno da kažemo bazična histologija je pokazala da je no-touch vena najprezerviranija od ove tri grupe praktično ispitivanih vena. Imunohistohemijske analize koje su uključile 4 antitela takođe su potvrdile rezultate da je no-touch vena ipak manje oštećena u toku harvestinga, ali ono što je značajno da nije bilo razlike između klasične, odnosno konvencionalne vene i endoskopski preparisane vene. S obzirom da mi u našoj nekoj praksi na našem institutu i uopšte, ja mislim, u kardiohirurgiji Srbije koristimo najčešće klasično pripremanu venu, onda možemo da izvučemo neki zaključak da praktično možemo dobiti benefit, jer sledeći slajd će pokazati da je komplikacije koje su se javljale nakon harvestinga su mnogo manje, odnosno signifikantno niže u grupi endoskopske pripreme, tačnije nismo imali infekcija, bol i senzorne neuropatije su znatno niže u ovoj grupi. Veliki neželjeni događaji u prvoj godini nisu pokazali razliku između grupa. Što se tiče radijalne arterije, trenutno izvodimo jednu studiju u saradnji sa Kliničkim centrom Srbije, gde ćemo komparirati neke zapravo tehnike harvestinga radijalne arterije na različite načine i procenjivati stepen oštećenja krvnih sudova pripremljenih na ovim različitim tehnikama. Na kraju mogu da kažem da na osnovu svih podataka možemo slobodno reći da je strukturno oštećenje vene nije bilo različito između klasično pripremane vene i endoskopski pripremane vene. Kada isključimo no-touch venu koja je, da kažemo, u neku ruku superiornija, definitivno su komplikacije rana na nogama bile mnogo manje u grupi endoskopske pripremljene vene. Idealna tehnika zapravo ne postoji, moramo prilagođavati tehnike za pacijentima u zavisnosti od zahteva pacijenata i kombinacija eventualno dve tehnike, tačnije razvoj i implementacija endoskopske no-touch tehnike bi bila možda neki idealna, da kažemo, opcija za naše pacijente. Hvala na pažnji.
Thank you, Dr. Živković. Next presenter will be Dr. Milutinović. He will talk about reborn saphenous graft in coronary revascularization.
Dobar dan svima. Ja sam Milutinović Aleksandar, kardiohirurg sam na institutu Dedinje. Poštovanje za sve predsjedavajući i za sve kolege. Ono o čemu ću ja danas da govorim je no-touch tehnika preparacije venskog grafta. I pre nego što bih ili šta rekao, hoću da kažem da u suštini, s obzirom da se razlikuju dosta gledišta i po pitanju graftova i ovde i generalno je tako, ne bi trebalo u suštini da se shvati bilo koja diskusija, da se jedni rezultati, da kažemo, unižavaju druge ili da se nadgornjavamo ili tako nešto u tom smislu. Tako da u suštini je to jedna opcija koju možemo da ponudimo ili ko nije radio da možda razmisli ili tako. To je neka početna ideja. Samo da se ja snađem s ovim. Nekih par opštih podataka, znači ishemijska bolest srca je, kao što svi znamo, vodeći uzrok smrti na globalnom nivou. Po Svetskoj zdravstvenoj organizaciji to je oko 16%, znači smrtnost je. Koronarni bypass je operacija koja se jedno od najčešće izvodi generalno i u kompletnoj hirurgiji. I venski graft, bez obzira na sve druge trendove i radove i tako i dalje, je najkorišćeniji graft, a opet u isto vreme je i graft koji je ovako kako je pripremljen najviše i podcenjen u nekom smislu i možda ima najviše prostora za napredak sa tako nečim. Sad, pre nego što bih nastavio dalje, ja sam iskoristio par čisto podataka da shvatimo, mislim, svi to generalno znamo, ali u suštini problem sa kojim se suočavamo kao kardiovaskularne bolesti, posebno kod nas, je prilično dramatičan i u suštini šta god mi radimo, ipak je to, naš ceo trud je ipak vrh ledenog brega. Znači, neka prevencija i nešto bi trebalo u perspektivi da bude ono što je glavno za naše društvo. Uzeo sam 2 zemlje koje su, da kažemo, slične po broju stanovnika i često se u našim, da kažemo, generalno istupima javnih radnika i tako govori da bi Srbija trebalo da radi nešto, recimo, kao Izrael. To je zemlja sa kojom nas vezuje i neka sličnost u pojedinim aspektima istorije i tako, znači, ali se puno razlikuju, vidjet ćete u nekim brojevima. Znači, srpska populacija je negde oko 7 miliona, dok je izraelska oko 9 miliona. Od zadnjih 20 godina kod nas umire godišnje oko 100.000 ljudi. Od tih 100.000 ljudi preko 50% su kardiovaskularne bolesti, a u Izraelu je, znači, 45.000 je, kako se zove, obično ta brojka. U zadnje 3 godine, kad su svuda zdravstveni sistemi bili upregnuti u vezi sa jednim patološkim stanjem svima poznatim, ti brojevi su još veći, znači kod nas je oko 130.000, kod njih je to prešlo na samo 5-6.000 više. I ono što je zanimljivo, znači njima već zadnjih 20 godina kardiovaskularne bolesti nisu vodeći uzrok smrtnosti. Uzet ćemo u to da kažemo da je naša populacija drastično starija, znači 40 i nešto godina odnosno na 30. I stvar koja isto nije beznačajna, znači bruto društveni proizvod je njihov 5 puta veći u odnosu na naš. Tako da kažemo sve to zajedno utiče. Sada što se tiče no touch vene na srpski način, koje su neke prednosti što bi mi mogli da kažemo koristimo u svakodnevnoj praksi. Ako gledamo na nekom mikronivou, znači takva tehnika omogućava znači veći uticaj azotoksida u endotelu, pošto endotel ovakvom preparacijom bude gotovo intaktan. Takođe, što se tiče perivaskularnog tkiva, ono je bogato raznim, da kažemo, hormonima i supstancama koje povoljno utiču na dug život ovog grafta, a vaza vazorum kod venskog grafta ovako spremljeno, znači, pošto on generalno iz adventicije dublje ide u mediju nego kod arterijskih krvnih sudova, tako da kada je sačuvan, znači taj graft duže živi za razliku od konvencionalne endoskopske vene gde se adventicija, odnosno vaza vazorum uglavnom ili teško ošteti ili uništi, tako da bi trebalo onako kako je po studijama, uglavnom se upravljamo na Sousu i njegov tim i mada to sad rade mnogi i objavljuju mnogi, nije to više da kažemo ekskluziva jedne grupe ljudi. Druge stvari znači koje su bitne ovako tehnički koje mogu da se iskoriste, to je da graft, ono kao što je profesor Perić rekao, za radijalku slično i ovo zbog peteljke, znači može da se koristi za multiple džampove ukoliko je da kažem neko pristalica toga, ima ljudi koji nisu, i omogućava da se revaskularizuje sitni krvni sudovi i da se, mislim, traži malo truda, jeste zametnije i priprema, ali da kažem, eto, prezentovat ćemo neke rezultate koji opet ne moraju biti 100% merodavni jer je još uvek mali uzorak, ali su na nekom tonu ljudi koji su već to radili i koji to objavljuju. Ovo je, da kažemo, za sada imamo negde oko 100 pacijenata koji su uključeni u sve to. Pošto je to sve krenulo pre poznatih ovih događaja zadnjih 3 godine, imali smo jednu pauzu, u smislu ne pauzu u radu, ali pauzu u follow-upu, jer počeli smo pre i onda je trebalo da prođe, nismo hteli niko ko je manje od godinu dana da zovemo na kontrole, tako da imamo tu kohortu od 41 pacijenta i dobili smo ih 33, 4 nismo uspeli da dobijemo iz raznih razloga, nisu bili voljni ili nisu mogli. I imamo 5 smrtnih ishoda, s tim što 2 su bila, da kažemo, intrahospitalno, a 3 su u toku follow-upa od nesrčanih uzroka. Ova 2 koje smo imali u bolnici, jedan je bio srčani uzrok, a drugi je čovjek bio sasvim druge problematike i nije umro, da kažemo, nije imalo smrt veze nikakve sa time. Radili smo ih i sa kombinovanim i sa čisto bypass, znači u bypass hirurgiji. Naravno, predominantno je to bilo 90 i nešto posto su bili čisti bypassevi, ali bilo i kombinovanih. Ovde, klasika je neka koliko je to trajalo i u intenzivnoj nezi i ovako. Eto, imali su značajni njihov broj je bio sa preko 40% su imali dijabetes. Follow-up je bio taj neki prosečan preko 2 godine. Imali smo u toj grupi 120 graftova i 78 no-touch vena, međutim, naravno, to je bilo u 41 bolesniku, ova 33, tu je bilo 99 ukupno graftova i 65 venskih graftova, gde smo imali samo 2 okludirana, nismo imali nikakvog, da kažemo, između da je bila neka stenoza ili tako nešto. Mamarije su sve radile, to je bilo u redu, ova su 2, tako da bili smo zadovoljni sa tim kako je to išlo. Ja lično obraćao sam dosta pažnje, pošto, da kažemo, jedinu slabu tačku ove tehnike, pod pretpostavkom da ne odbacujemo venu napred, je ta u smislu zarastanja, tako da gledao sam kad to može da bude natkoleno, da ukoliko je pacijent premršav, izbegao sam potkolenice, tako da eto, malo smo tu, ovo su neki procenti gde smo šta, od čega uzimali. I druga stvar, eto, naši mlađi specijalizanti, ja sam zadovoljan stvarno što se tiče tog dela i svi se trude i stvarno nemamo neku, za sad, da ne ureknem, nemamo neku razliku u zarastanju ili u problemu sa ranama što se toga tiče. Imali smo jednu pacijentkinju koja je mesec dana posle operacije došla, imala je, ona je natkoleno je bila uzimana vena i imala je tu infekciju, tako da plastični hirurg je to, naš konsultant, lepo sredio, tako da nismo imali ni sa time problema, ta žena je dobro, radi i sve normalno. Ovo je sad, ne znam kako se film pušta, ne znam da li ovi ljudi, samo da se mutira, pošto smo pričali svašta. A nemamo mnogo snime, eto. To je, hvala. Tako da, znači, to je neki način, ovo je natkoleno konkretno vena, kako to izgleda. I, eto, nije neka preporuka, neko ekstremno jurcanje oko svega toga, znači, u smislu ko je od godina ili po temperamentu, da nije preterano smiren, možda nije prava metoda. Tako da, eto to. I šta drugo imamo? Ovo je, eto, kako je to, da kažemo, prvi put je objavljeno 96. Sousa i njegov tim u Švedskoj. Na početku, kao i sve, bilo je tako kao što piše. Sada je to, da kažemo, 2A klasa preporuke i ima neku svoju budućnost. Tako da, eto, to je što se mene tiče. Hvala.
Thank you very much. So we have come to the last presentation. It's by Professor Sigrid Sanner from Vienna in Austria. I think you were probably introduced by Milan earlier today, so yes. I think we just start.
All right, so while I wait for my slides, thank you very much for the invitation, and I would really like to take this opportunity to congratulate the organizers on an excellent meeting and all the speakers on their excellent presentations. So, just by way of disclosure, I am an investigator in the European Multicenter Registry to assess outcomes in CABG patients, which uses DuraGraft as the preservation solution. So this is the DuraGraft registry. So there are several factors that influence vein graft failure. Patient risk factors, trauma during harvesting, storage, grafting are all risk factors that contribute to vein graft failure. And then we have secondary prevention medications that mitigate vein graft failure, and it is usually antiplatelet therapy that I am asked to talk about, but Milan asked me to talk about storage solutions, so I am happy to oblige. So, during harvesting, the vein grafts incur damage, or there's mechanical trauma, as we've also heard in the previous presentations, and they then undergo a period of ischemia and then reperfusion after grafting, and all of this leads to endothelial damage, so endothelial and subendothelial damage. And this is then followed by exposure of the extracellular matrix. This in turn leads to platelet activation and aggregation and activation of the coagulation cascade. and thrombosis, which is the primary mechanism of early vein graft failure, which is then followed by intimal hyperplasia and atherosclerosis, which are the pathophysiologic mechanisms of later vein graft failure. But the initial injury that sets this whole process in motion is the damage to the endothelium. And storage solutions, their role is to protect the endothelium and mitigate endothelial damage. So what properties should storage solutions have? Well, they should be biocompatible in that they should be pH balanced and buffered, they should be ionically balanced, and they should protect against ischemia reperfusion injury. So they should support nitric oxide synthesis, they should contain antioxidants, and they should support anaerobic metabolism. And there are a number of saphenous vein graft preservation solutions which are currently available. And the most widely used solutions are normal saline and autologous whole blood. And this despite the fact that there is abundant evidence in vitro, but still a lot of evidence that normal saline is actually detrimental to endothelial integrity and function. And then there is a number of buffered solutions that have been recently developed. The Gala solution, which is a precursor to DuraGraft, is a solution that contains glutathione, ascorbic acid, and arginine. And then there are others, Tarpotec, University of Washington solution, Hayes solution, HTK are the ones listed here. But buffered solutions distinguish themselves in the fact that they contain ions, they contain antioxidants, they contain high molecular weight molecules, all of which support a pH balance in the storage solution. So I'm going to show you a couple of studies that compare these different storage solutions. So this is an in vitro study, and you can see very nicely on the right-hand side, and just by way of explanation, the red cells are the dead endothelial cells and the green ones are the live ones. So using multiphoton microscopy, this group showed that within 60 minutes of harvest and storage in standard preservation solutions, and these standard preservation solutions again being normal saline and autologous whole blood, over 90% of endothelial cells were no longer viable. Whereas in this Gala solution, which is a buffered solution, there was no substantial loss in cell viability over 24 hours. This is a very well-known post-hoc analysis of the PREVENT-4 trial that was a randomized controlled trial. And this post-hoc analysis looked at vein graft failure and clinical outcomes in their over 3,000 patients, stratified by which storage solutions the vein grafts had been preserved in. And what they found was that patients whose vein grafts were preserved in a buffered saline solution had significantly lower vein graft failure rates and also trend towards better long-term clinical outcomes compared with patients whose graft had been preserved in saline or blood-based solutions. This is another US study. It's a retrospective adjusted observational study where vein grafts that were stored in DuraGraft were compared with those stored in saline, looking at clinical events over a mean follow-up of, as you can see, 8.5 versus 9.9, so almost 10 years. And what they showed was that DuraGraft was associated with a reduction in non-fatal myocardial infarction, incidence of repeat revascularization and MACE, but comparable mortality. So what this suggests is that if you have effective intraoperative vein graft preservation, this may reduce the incidence of vein graft failure related clinical events. And this finally is a randomized clinical trial. As far as I know, I think it's the only randomized clinical trial looking at storage solutions so far. It's by Louis Perot's group from Canada. And the design of this randomized clinical trial was a within-patient randomization. So patients had 2 vein grafts grafted, and one of them was randomized to be stored in DuraGraft. One of them was randomized to be stored in saline, and randomization was stratified by territory. And then patients underwent CT angiography at 1, 3, and 12 months after surgery. And what they showed was that the DuraGraft-treated vein grafts had a lower mean wall thickness at 12 months compared with those that had been stored in saline. And as we know, and as Fitzgibbon has published in the 80s and 90s abundantly, is that increased wall thickness or beginning intimal hyperplasia is an indicator of later vein graft disease and late vein graft failure. So this is the design paper of the European DuraGraft registry that I mentioned earlier. And we have actually completed enrollment, and the full cohort paper is actually under review at this point. And the DuraGraft registry aimed to enroll 3,000 patients. We ended up enrolling, I think, close to 3,000, so 2,900 and something. It was all patients that had their vein grafts and all free arterial grafts stored and or flushed with DuraGraft for those who flush grafts. And the primary outcome measure was the occurrence of a major adverse cardiac event, so death, non-fatal MI, or repeat revascularization. And the registry also looks at patient-reported outcomes, so quality of life. But as I said, it's a registry, it's not a comparative study. And this is actually a study from one of my fellows who had a background in molecular biology, and he wanted to look at the effect of DuraGraft versus lactated ringer solution, which is what we use at my institution, to look at the effect on the endothelium of radial artery cells, because up to that time point, there had been no data in arterial grafts. And unfortunately, I think we can't see all the nice pictures that I put there, but what we showed was that DuraGraft also maintains the integrity of radial artery endothelial cells, and that DuraGraft also in arterial grafts reduces endothelial and subendothelial damage. So he found lower levels of reactive oxygen species, reduction of hypoxic damage, and increased expression of molecules that are indicative for vascular protective function. Now, what the clinical relevance of this is, to be honest, I think is unclear, because the mechanism of arterial graft failure is distinctly different from that of vein graft failure, but nevertheless, balanced storage solutions are also superior to preserve, apparently, arterial grafts. So with this, I'll finish. I do want to come back to my first slide. As I said, there are multiple factors that contribute to vein graft failure, and storage solutions are only one piece of the puzzle. Thank you.
Thank you very much, Sigrid. I have a question for you, actually. We have a couple of minutes, time for 1 or 2 questions. So, DuraGraft has been around now for like 5, 6, 7 years. When is it coming a prospective, randomized study with clinically important endpoints? Why didn't you do that instead of a registry?
Well, you know, unfortunately, it wasn't up to me. But as far as I know from the company and the major people involved, Maximilian Emmert from Berlin, they are actually planning a prospective comparative study looking at also molecular mechanisms. Clinical outcomes, I'm not so sure, but you make a great point. And you know, there's actually you know, it's important, and also because all of these studies, they have important limitations in that there are so many confounders in these studies, which you would also have to recognize if you're planning one, which is, of course, you know, distension pressure for saphenous vein grafts, the duration of storage in the storage solution, the temperature. So there are a lot of confounders which probably need to, you know, be taken into consideration. Just my take.
Okay, thank you very much.
I would like to ask for just one short question or comment from the audience regarding this topic altogether at the end of the session, since we are very, very short of time.
Yes, please.
Yes, please.
Can I get a microphone? Once again, I would like to congratulate to all the presenters for really outstanding presentations. When it comes to conduit selection, well, there is a lot of things to consider. First, we went to Sweden and we implemented in our center no-touch SVG harvest. But the problem with that is essentially without harmonic knife, it's not easy. The bleeding issues from the branches not primarily identified may present really significant issue. Another thing was infections of the SVG harvest site that we noticed. And other problem is basically for the patients, we also did at the same time the endoscopic saphenous vein harvesting, but that went bad in our center. So one of the problems was the compliance among the physicians. It took us way more time. The other problem is the patients with the high BMI that are basically the best patients for endoscopic harvesting were found to be technically very hard to harvest. We could barely harvest one length for the one bypass, which was not found very good. And on the other hand, the patients that have the normal body weight usually do not benefit from the endoscopic harvesting, and if subject to endoscopic harvesting have very, very tight vein and it's very hard to harvest veins below the knee in such a patients where the vein was actually found to have the best quality. And finally, when it comes to beta, I can tell that as a surgeon who does over 50 betas in my practice. I completely agree for the skeletonized fashion in harvesting mammaries. It's not possible to use, in my practice, to use right internal mammary if not harvested in skeletonized fashion. For what I use, right internal mammary artery is lateral wall with the OM1 and sometimes, if possible, OM2 targets. And I run the right internal thoracic artery throughout the transversal sinus transversus, and usually it's long enough, so we do not have cross over the aorta. And for the right coronary artery, we used to use the radial artery, but since we use Medistim flowmeters, we found basically no any additional benefit of using a right radial artery on the right side, and we switched to no-touch saphenous vein. So to wrap up here, it depends on the...
Sorry, can you be a little more concrete about your topic,
yes,
because it takes a little bit time, you know.
Yes. So whenever we consider what I meant to say was when you make your decision upon the conduit you use, you need to think about the center where you work. We are tertiary center. So basically, I think so that we need to have all of these conduits in our armamentarium, but usually the practice requires shortening of the time to harvest. And I think so basically that Lima and Rima are even the literature suggests possibly the use of those. I think so it's not designed for every patient. We need to choose patient for beat us, as basically it
Absolutely, there are no disease, there are only patients. I completely
Yes.
agree. Is there any other question from the audience or comments, please? Very short one.
About the no-touch technique, is there tips and tricks to decrease the rate of wound infections? Because it's the main drawback. I mean, I personally use it. Is to be meticulous, certainly closing, or using eventually a drain, or I would like to know the...
I'm here. So in our practice, we were very, I don't know, meticulous with closing all the layers, and I personally like to use the vein from the thigh if it's because it's easier to close, and in general, patients who are tiny, I try to avoid from the lower leg. And in general, with some kind of that strategy, if, for example, if the lower leg is thick, we don't have a problem to harvest from that side. But for the time being, we are pleased with this technique. We cannot we are in some way we are afraid of something like that. But in general, it was all good for the time being. I hope it will be continuing like that. In our group, we had 43 patients. 43% of patients were diabetic. So I don't personally, I don't pay so much attention about that. I more pay attention site where I want to choose and to have enough tissue to close it.
Okay, I think we need to stop here, and this concludes this session. I thank the presenters and discussants. Next session will start in 10 minutes from now, exactly 10 minutes from now, according to the organizers. Thank you very much.
Puzzle hundreds of other items. Just have it remain harvested. Water, saline, and the solutions, and then electron microscope look to the epithelial cells, and it's only short term, only very short. Exactly, that's the reason. I once visited Italy, and they showed us the vein surgery, and they asked us to make the forceps and to hold it with the forceps, and then they put it under the microscope and to see if it's strong. It looks like the ball is going into this suture. So this is, as you see, still in my mind after 30 years. And something like this, you know, so to have a terrible picture after saline turn. Epithelial cells, destruction, everywhere. And then you could have the saline every solution. And then at least it looks fine. So that's it. You cannot do anything more. And of course, if it's, then you can subgroups along with the pressure whatsoever. And other groups. From this at least will show that what we are all doing is wrong. I mean, that's enough. You cannot, so therefore, to put the choline with the forceps is crazy. We should not do it. And we can have a picture on the wall.
Still we do it sometimes.
And sometimes we still do it, yeah.
But you know, you put lung cancer pictures on cigarette packs.
Yeah, nobody cares. But we as doctors should care, and that's why we also something else. And there they have strict rules, They do it exactly as it is, very strict. And they have no problems with that. And even one, the co-pilot is controlling the pilot, and vice versa, and they have no problems with that. We have huge problems. Everybody does it differently. You know, I get crazy. We should have one, even if we don't know what is right or wrong, that's fine, but we say, this is standard. But we do, and therefore, you have no results, because it's not standard. And also, they do it, which I remember, because I was very much for standardization. And they said, no, this page was different, this was different. This 747 in Chicago is not different than the 747 in Frankfurt. Just do it the way we do it, but they don't do it. But they, several don't do it.
But I don't think as a profession we have responsibility when companies come and try to sell things
Yeah,
that
absolutely.
ask for the evidence.
Exactly.
Because if you buy everything that comes up,
And it's
it will be
expensive.
so expensive.
And the solutions
we
are
need to
expensive.
force them to actually, yeah.
There's no way, zero, that's a finish.
Did you say 1,000 euros? Yes, it is. I thought it was 100. No, it was
I think it's it's observation on the graft. We could do it ourselves. I mean, just what kind of parameters do you want to change? Whatever, osmotic pressure, like this or that, then you can formulate your own solution, your pharmacy. Whatever. I mean, it's an interesting topic. That's interesting. Because we use blood, as you see, pH 3.5. We did a study for segments of solutions. We have to test relaxations and contraction. And you know what was first? We had rapid side and that was the worst. That was absolutely the worst. That was the worst. Exactly. The oxygenates the free radicals in there. We never published that. Yeah, it is. But it was more that the guy who had the guy who had like try to find the old data. Probably happens. Lots of good relaxation. Exactly, that's what I mean.
So, dear colleagues, ladies and gentlemen, let's start with the final session. First of all, I would like to thank Professor Sigrid for being here with us. Okay, so it works now, okay? And making this session actually more international and, let's say, more scientific. Then we have Dr. Banović, who is interventional cardiologist here with us, and Professor Perić, who is leading cardiac surgeon in Institute Dedinje. So welcome all. And I would ask Professor Sigrid to announce our first speaker. So please.
So it is my great pleasure to introduce to you Professor Jeppsson from Gothenburg in Sweden, who will be speaking on early and long-term outcomes after CABG.
Thank you very much, and I also want to thank the organizers for inviting me here. There has been some confusion about the title and the content of my presentations, but I will present what I have prepared, nothing else. Okay, these are my disclosures. I don't think any one of them are relevant to this presentation. So I'm going to just ask a couple of questions and then try to answer them. And the first question, which relates to the title, is: does ischemic cardiomyopathy and or reduced left ventricular ejection fraction increase short and long-term mortality after CABG? So we used Sweetheart registry data. We have not specifically looked into reduced EF in this study, but the Sweetheart registry is a registry which combines both this cardiac surgery registry, but also the angioplasty registry, the coronary care registry, the catheter-based technique registry, and secondary prevention registry. And the big thing with this is that you can look at different diseases, but also that we can combine it with other mandatory registers like the cause of death registry and the pharmacy registry. So we looked at isolated first-time CABG during a 12-year period. This was 28,000 patients, 80% men, typical CABG populations. And out of these, 12.7% of the patients had a heart failure diagnosis before CABG, and 30% had a reduced left ventricular ejection fraction. So when we looked at the unadjusted mortality in patients with and without heart failure, these are the 30-day mortality, and as you can see, it's 3.5 times higher in the heart failure group compared to the no heart failure. And likewise, the long-term survival differs substantially between those patients, with a 10-year survival of 75% in the no HF group and 45% in the HF group. Instead of looking at left ventricular ejection fraction, you can see that here that 70% of the patients had normal ejection fraction, 25% between 30 and 50, and 5% less than 30%. And this proportion was to have been stable over time. And again, looking at early mortality, you can see it's 10 times higher in patients with reduced ejection fraction, with really reduced ejection fraction, those with less than 30%, and the same pattern in long-term survival. So, of course, this is not a surprise, but both heart failure and low left ventricular ejection fraction is associated with a much higher mortality. It also seems that it's more important, the heart failure diagnosis, than the reduced ejection fraction. I mean, we have today patients with heart failure with preserved and reduced ejection fraction, and the worst outcome is in patients with both heart failure and reduced ejection fraction. So again, ischemic heart failure and or reduced LF is associated with increased short and long-term mortality. This has been shown many times before. So the next question is whether CABG is better than optimal medical therapy in patients with heart failure or significant coronary artery disease. So this was investigated in the STITCH trial, which at the first publications from the STITCH trial with outcome up to 6 years, there was a strong trend but not a significant difference in all-cause mortality between patients randomized to medical treatment or CABG. If you combined cardiovascular hospitalizations with mortality, there was already that 6-year difference between the groups. But in the 10 years data or 11 years data in the study called STITCHES, which is a follow-up of the STITCH trial, these differences have now reached statistical significance. So we know from this study that CABG is better than optimal medical therapy in these patients groups. So then we have the recommendations in the guidelines. And as you can see here, there's a recommendation. There's a recommendation with the 2A classification to relieve symptoms of angina in patients with a reduced ejection fraction. And a 2B recommendation, a very weak recommendation to improve outcome in this patient, despite the STITCH trial. These recommendations also say that CABG should be considered the first choice, a 2A recommendation for CABG and a 2B for PCI, that PCI should be considered as an alternative to CABG. So these are the recommendations. So the next question is then whether PCI, is CABG better than PCI in patients with ischemic heart failure and reduced LVF in patients with coronary artery disease? Well, there is no randomized studies published. But there is actually a study which was presented at the ESC meeting most recently, the REVIVE study, which compared percutaneous revascularization with PCI for ischemic left ventricular dysfunction with optimal medical therapy. And these are the outcomes data, and I hope you can see, but there was absolutely no difference in the primary endpoint, which was death from any cause or hospitalization for heart failure. It's almost a perfect neutral study. The only difference that was detected was in unplanned revascularization and in myocardial infarction. So this is in spontaneous myocardial infarction. So when it comes to comparing PCI with optimal medical therapy, there is no difference. But this, of course, does not argue that not CABG is good for these patients. In fact, patients that were eligible for CABG were excluded from this study. So this study is made on patients that were not undergoing surgical revascularization. So what do we do when we don't have randomized data? Yeah, we look at observational data. And this was a study that we published last year in European Heart Journal. It's mainly done by Elmir Omerovic and Sebastian Wölz, but I was also involved, looking at long-term mortality in patients with ischemic heart failure, revascularized with either PCI or CABG. This was 2,500 patients. All had LVEF less than 35%, and they were treated with PCI or CABG during a 19-year period. All patients had multivessel disease. 56% were treated with PCI and CABG 44%. The mean follow-up was 3.9 years with the primary endpoint all-cause death. And this was applied really advanced statistical methods, including instrumental variable analysis, which I hope you don't ask me about. This is an interesting slide because this shows actually the evolution over time. The blue bars here are, it's difficult to see here, but the blue bars here are the PCI, which increased from a much lower proportion than CABG from the beginning, but increased more and more over time, despite the lack of support in the guidelines, or also in the recent guidelines, but also in previous. So PCI increased with 13% per year. So this is the primary endpoint. The adjusted OR was 0.62 in advanced for CABG with a higher mortality. And as you can see here on the landmark analysis to the right, during the first 3 years there was no difference, but then these curves started to divert. Thank you. Okay. This is one of the most interesting findings in the study. And actually this was in the supplementary, because here we have the quintiles of hospital for PCI preference. This was the quintile with the highest use of CABG, and then going down to quintile number 5. And as you can see, the patient who had the least CABG has lost almost 10 years in survival, 10 months in survival after a median follow-up of about 4 years. So this is an important slide. So we are not the only one who have looked into observational data. This was from Mario Gardino and Stephen Frames, 23 studies, 4 subgroups analysis from randomized trials combined with observational data in all over 23,000 patients. And they find more or less exactly the same as we found in our study, with better outcome in CABG patients compared to both PCI patients and medically treated patients. But these studies, both our own and the one from Mario, are retrospective studies. Selection bias and residual confounding may impact the results. These are hypothesis generating, not conclusive, and randomized trials are warranted. And luckily, there is such a study coming up. This is the STITCH 3 initiative, mainly by Stephen Frames and colleagues. This is a study that is planned to be in at least 8 countries, where every country make their own study, and then we combine the results into this international. So far, this study has been funded in Sweden, in Denmark, and in Canada, and we hope that all more countries can jump on the wagon. So the STITCH 3 trial, the international one, is looking at all-cause mortality as primary endpoint, and the patients will be followed up to 10 years. But it is difficult to run such a study in one country, so the different studies in the different countries looks a little bit different. So this is our study, where we're looking at the CABG or PCI in patients with ischemic cardiomyopathy. We call it the STITCH Sweetheart trial. We're going to include 470 patients. All should have a reduced ejection fraction. And we have a primary endpoint, which is a composite of all-cause death, stroke, non-procedure-related myocardial infarction, or hospitalization for heart failure within 3 years after randomization. So this is a register-based RCT, which means that we will include the patients, operate the patients, but we will not follow them with visits. Instead, we will follow them in the Swedish quality registries. It is financed by the Swedish Research Council. There is no industry money at all, which I think is important. And we will start very soon. Actually, we had a startup meeting in our hospital last week. So my take-home messages is that ischemic cardiomyopathy and or reduced LVF impairs outcome after CABG. CABG is better than optimal medical therapy after CABG. In patients with ischemic cardiomyopathy and or reduced LVF. There's no difference between PCI and optimal medical therapy in REVIVE, but again, CABG patients were excluded. And observational data indicate that CABG is better than PCI. Now these screens are. Observational data indicate that CABG is better than PCI in patients with ischemic cardiomyopathy, but randomized data is lacking. Thank you.
Thank you, Professor Jeppsson, for the wonderful talk. I think we should leave the discussion for the end because we are a little bit behind the schedule. Yeah, we have facing here some technical problems. These 2 monitors are out of order, so please, if you can fix that for the next speaker. And may I announce the next speaker? It is Dr. Miloš Matković from University Clinical Center of Serbia, and he's going to tell us some evidence-based data regarding on versus off-pump surgical myocardial revascularization. Please.
Hvala još jednom čestitke organizatoru za ovaj sjajan fokus sastanak. Ja ću vam reći nešto o operativnoj strategiji, odnosno izboru metode da li bolesnike operisati on ili off pump. O selekciji graftova smo čuli dosta na prethodnoj jako dobroj i poučnoj sesiji, tako da bi se ja ovdje bazirao na operativnoj strategiji kod ove jako teške grupe bolesnika sa niskom ejekcionom frakcijom. Dakle, 90. godina prošloga veka u našu svakodnevnu kardiohirušku praksu ulazi off-pump hirurgija, odnosno hirurgija na kutajućem srcu, koja je iz prve htjela da potisne konvencionalnu hirurgiju za upotrebu vantelesnog krvotoka i da prenebregne njegove praktično nedostatke. Od tada pa do dan danas se vodi jedna velika debata koja definitivno ne prestaje. U par navrata s nekim studijama smo mislili da smo debatu rešili, međutim, ona je i dan danas aktuelna. Debata je krenula od toga da li je metoda superiornija ili, kako već sada biva, neinferiornija, da se tako izrazim, nije u duhu našeg jezika, ali ne postoji bolji prevod, odnosno da li je validna alternativa i kod kojih bolesnika. Danas se sve više diskutuje o tome, o kompletnosti revaskularizacije kod off-pump hirurgije. Zašto? Naravno, u pitanju su tehnički razlozi. Dakle, mnogo je teže, veća je kriva učenja i zahteva mnogo uvežbaniji tim. Zatim, da li je ona bolja kod visokorizičnih bolesnika, naročito ovih koji su tema naše današnje sesije, to su bolesnici sa niskom ejekcijom frakcijom. Zatim, diskusija danas ide u pravcu toga ko bi trebao da radi ove operacije i kada bi trebalo da ih radimo. Naravno, kao i svaku diskusiju, moramo upotrebiti evidence-based medicinu i ovo su 4 landmark randomizovane kontrolisane studije koje su u početku trebale da reše ovu problematiku, međutim i dalje izlaze novi rezultati. Najveći od njih je svakako Coronary studija koja ima svoj jednogodišnji i petogodišnji follow-up, koja je pokazala da nema razlike između on i off-pump hirurgije u composite outcome koja se sastojala od smrtnog ishoda, šloga, infarkta miokarda, ponovnih revaskularizacija i bubrežne insuficijencije nakon petogodišnjeg perioda praćenja. Naravno, ovo su bolesnici sve uglavnom bili sa dobrom frakcijom i nisu bili tako visokog Euroscore profila. Zatim, Ruby studija koja je u početku 2002. godine kada je izašla govorila protiv off-pump hirurgije sa drastično lošim rezultatima. Tadašnji kritičari, odnosno proponentni off-pump hirurgije, su kritikovali da u Ruby studiji centri koji su bili uključeni, to su centri u okviru posebne osiguravajuće grupe u Sjedinjenim Američkim Državama, nisu bile dovoljno iskusne u tome, odnosno da je svaki od operatora imao po manje od 20 operacija, da je svaki centar radio manje od jedne operacije ovog tipa nedeljno. Međutim, ovo su nakon 10 godina objavljeni prošireno znati Ruby studije sa dužim follow-upom. Kao što vidite, tu ima par stvari na koje bi mogli da obratimo pažnju, a to je da, kao što vidite, jako mali procenat žena je uključen u ovu studiju, ne znamo zašto. Bolesnici su dosta mladi, također bolesnici su sa dobrim ejekcijnim frakcijama i nakon 10 godina nema razlike u preživljavanju, u all-cause mortalitetu, nema razlike u ponovljenim revaskularizacijama, razlika je samo u time to eventu, u composite outcome-u koji se dešava nešto brže kod bolesnika u off-pump grupi. Nakon toga postavlja se pitanje kompletnosti revaskularizacije sve češće, naravno rekli smo zbog čega. Ovo je jedna od studija australijskih autora koja je otvorim meta-analiza koja je obuhvatila 13 studija sa preko 13.000 bolesnika, koja je pokazala da je povišen rizik za all-cause mortalitet kod bolesnika koji su podvrgnuti off-pump hirurgiji i da je, to je nakon 5 godina i u svojoj diskusiji su postavili pitanje kompletnosti revaskularizacije kao faktora rizika za ovaj ishod. Nisu ga pokazali statistički, ali su ga iznali. Nakon toga nama vrlo dobro poznata tako Excel studija, nećemo se baviti njenim kontraverznim delom oko izbora metode revaskularizacije left maina, već samo analize jedne njene podgrupe, a to je on i off-pump bolesnika. Dakle, vidite, veliki broj bolesnika je uključen u ovu studiju. Istraživači su pokazali da bolesnici operisani off-pump tehnikom imali su značajno lošije rezultate, značajno lošije preživljavanje i kao što vidite mnogo manji rate, odnosno, sad izvinite, slajdovi su na engleskom, a pričam na srpskom pa mogu pomešam. U svakom slučaju drastično manje revaskulizovane teritorije lateralnog i inferolateralnog zida miokarda, što naravno je značajno tehnički teže kod ove hirurgije, naročito ukoliko ne radimo svakodnevno. Naravno,
Ovo su također bili bolesnici koji su bili drugačijeg Euroscore profila, znači nisu bili high risk bolesnici. Naravno, ART studija koju smo danas više puta pomenuli, također njena podgrupa. Taggart i saradnice, Taggart koji je jedan od najvećih proponenata off-pump hirurgije, kaže da su rezultati značajno lošiji kod off-pump grupe bolesnika, ali samo ako je ova procedura izvođenja od strane hirurga koji nemaju veliki volumen u ovoj proceduri i ukoliko imaju veliki broj konverzija, što je naravno u skladu s njihovim iskustvom i naravno manjeg broja graftova. Kako je postavio ovu sumnju, diskusija naravno ide dalje da je off-pump hirurgija validna alternativa tako on-pump hirurgiji, da može da redukuje morbiditet i da izbor graftova ne treba da utiče na izbor tehnike. Naravno, šta nam kažu preporuke za ovu našu grupu bolesnika, svakako CABG je opcija izbora za bolesnike sa niskom ejekcionom frakcijom. Naravno, ovo su prvi guidelinesi koji su u obzir uzeli i kompletnost revaskularizacije koja nam je očigledno bitna kod izbora da li ćemo se odlučiti za off-pump ili on-pump hirurgiju. Naravno, i ovaj slajd smo danas vidjeli više puta, ali svakako kompletnost revaskularizacije je zastupljena sa klasom 1B, ali isto tako je i minimizacija aortne manipulacije preporučena sa klasom 1B, koji je teško izbjeći, tako ukoliko se odlučimo za on-pump hirurgiju, moramo klajmovati aortu. Zatim isto tako, off-pump hirurgija je metoda izbora sa klasom dokaza 1B kod porcelanskih aorti, ali samo ukoliko se izvodi u iskusnom centru sa iskusnim hirurzima. Sa klasom 2A ona je preporučena za high risk bolesnike, odnosno pacijente koji su tema naše današnje sesije. Dakle, što se tiče visokorizičnih bolesnika, ova je studija objavljena ove godine od strane grupe autora. U svakom slučaju obuhvatila, to je jedna retrospektivna analiza, propensity matched. Propensity matching je korišćen, tako da otprilike preko 1100 bolesnika je uključeno u tu studiju, sa mortalitetom za obe grupe oko 5%, dosta iskreno od strane autora, što znači da su ovi bolesnici u dosta visokom riziku koju god metodu mi primenili. Pokazali su da je metoda bezbedna i efikasna, da su rezultati komparabilni sa nešto manjim procentom, naravno, graftova u off-pump hirurgiji, inkompletnijom revaskularizacijom, ali koja ovdje nije uticala na mortalitet. To se može objasniti sa značajno manjim preživljavanjem ove grupe bolesnika generalno, obzirom na njihovu ishemijsku kardiomiopatiju. Dakle, grupa nemačkih autora također je uključila 111 konsekutivnih bolesnika u svoju studiju, podijelila ih na on-pump grupu naravno. Također nije našla razliku u all-cause mortalitetu. Naravno, nije pronađena razlika u kompletnosti revaskularizacije, tako da vidimo i kada je kompletna revaskularizacija i kada nije. Prema ovim studijama kod ove grupe bolesnika koji generalno imaju skraćeni životni vek nije presudna na ishod u smislu mortaliteta. Ko bi trebao da radi ove operacije? Kao što su i guidelinesi rekli, trebalo bi da rade uglavnom iskusni operatori. Zašto? Izdvojio sam dve studije, obe su retrospektivne i propensity matchovane. Zašto su nam ovdje važne? Obe su rađene u centrima gdje se preko 50%, u nekim centrima i preko 60% radi koronarna hirurgija isključivo off-pump, gdje svi operatori u svojoj praksi imaju više od 30, neki 40%, neki 100% off-pump hirurgije kod svojih bolesnika, gdje je grupa španskih autora pokazala superiornije ishode kod off-pump hirurgije u odnosu na on-pump, dok je grupa britanskih autora na preko 13.000 bolesnika pokazala iste rezultate, odnosno nije pokazala superiornost, pokazala non-inferiornost. Obe govore u prilog da samo iskusni hirurzi treba da se bave iskusni u off-pump hirurgiji treba da se bave ovom vrstom revaskularizacije. Ovo je jedna studija koja je rađena u našem centru, također su retrospektivna studija, propensity matchovana, gdje su bolesnici koji su rađeni off-pump hirurgiji imaju značajno viši Euroscore profil, uključeni su samo operatori koji su imali preko 150 off-pump urađenih revaskularizacija u svojoj praksi i pokazali smo također neinferiornost ove procedure i kod ove high risk grupe bolesnika. Dakle, kada bi trebalo da radimo ove operacije? Dakle, kada imamo visok rizik ili kontraindikacija kardijalni pulmonarni bypass, to je sigurno porcelanska aorta. Koliko bi se nas ovdje složilo, bilo bi zanimljivo da vidimo danas na izbor ove procedure navede niska ekcijna frakcija ili skorašnji infarkt miokarda, da ne pominjem akutni infarkt miokarda, to sad nam prelazi okvire ove diskusije. Sigurno sam da većina nas ne bi se odlučila samo zbog prethodnog cerebrovaskularnog događaja ili nekih sekvela za ovaj tip hirurgije. Svakako renalna insuficijencija ili bolesnik na dijalizi sigurno bi to bila činjenica koja bi nas približila izboru ove metode. Stariji bolesnici sa respiratornim problemima ili drugim sistemskim bolestima koji se smatraju visokorizičnim za hirurgiju, pitanje je sad da li bi ih poslali na PCI ili na off-pump proceduru. Ovo je već sad dosta kontroverzno pitanje i za neku, kako da kažem, baš širu diskusiju. Dakle, take home message bi bila off-pump hirurgija nije za svakog bolesnika, nije za svakog hirurga i nije za svaki centar. Kako nam je pokazalo poslednje evropsko prvenstvo u košarci, ne pobeđuju uvek najbolji pojedinci, nego najiskusniji tim. Hvala.
Thank you very much for your presentation, and I would just add to that all the randomized trials on off-pump versus on-pump actually have very few patients with low ejection fraction, so there is actually insufficient evidence to recommend one strategy over the other in this patient population. But the paper by Piro's group and others have shown that if you do this safely, if you can do it safely, you can probably also do it in patients with low EF. Okay, so our next talk is going to be on concomitant procedures, mitral repair, atrial fibrillation, aortic repair or aortic valve replacement by Professor Stojanović.
Hello everybody. I will talk about mitral valve disease, ischemic mitral valve disease and mitral valve repair surgery. Once we get myocardial infarction, we shouldn't be that happy, particularly if there is a concomitant or conjoined mitral insufficiency, since our life expectation will be not that brilliant. The situation gets worse with the degree of mitral regurgitation and survival after the myocardial infarction, and the severity of mitral regurgitation is dependent to the degree of the regurgitation. Fortunately, there is a solution for this, and medicine offers us either valve repair or replacement. If we got valve repair, we will survive better than ones who get valve replaced, but we risk recurrent mitral regurgitation, which is the major problem today in ischemic mitral regurgitation. Surgery and market offers a bunch of different ring products that are trying to fix this problem, but generally it is a two-dimensional technique trying to fix a strict tri-dimensional problem, which is, exactly what the ischemic mitral regurgitation is. With this two-dimensional repair technique, which is generally called, reduction annuloplasty or whatsoever, within 6 months after the surgery, almost 30% of patients operated that way gets important MR again. So this is not good, and solutions are limited, and we need to offer something else to the patient and something that works for me. Okay. So the main questions we have to ask ourselves as a surgeons and as a doctor particularly, not as a surgeons, but as a doctors who is treating the heart, is do we really understand the mechanism of functional ischemic mitral regurgitation, and or do we truly understand the mitral valve? Well, probably neither of those two. Why? Generally because we are reading too much and learning too much and thinking not that enough. Problem is that everybody who tried to treat the mitral valve from the anatomic textbooks that exist in some percentage of patients, but not that frequently. And unfortunately, we are treating, we are treating this mitral valve, we are treating that everybody, and each and every papillary muscle is like this one, which is not the case. You see how papillary muscles looks in quite a number of patients. This is a dysplastic papillary muscle, and believe me, this dysplastic papillary muscle is almost always goes along with the hypoplastic posterior leaflet. And what happens when we got an inferior infarction, which is generally most frequently the cause of functional MR, the tethering with this dysplastic papillary muscle is more accentuated than with normal papillary muscles. And if we have, which is, as I said, the frequent combination hypoplastic posterior leaflet, it is not possible to treat or to fix this problem with the reduction annuloplasty. And unfortunately, the reduction annuloplasty used to be the most frequent repair technique in those patients. These are some examples of repairs I did in patients with functional MR, but I will show you a short footage from a patient who was refused. He is from Bosnia, and he got 30% of ejection fraction, and due to inferior myocardial infarction, he was stented. He needed revascularization, but he was refused from surgery. He was offered, some kind of LVAD and so on. He came to Belgrade and we operated on him. And so, what was the preoperative finding? Ischemic mitral regurgitation. So, functional mitral, the myocardium is bad. We can't do anything with this patient. He was his NIHA 3 class with a central MR jet. So, let me just try to start the movie. Okay. And that's what I found during the surgery. Firstly, I found a huge cleft on the anterior leaflet. Thereafter, I found, as I said, dysplastic papillary muscles, hypoplastic posterior leaflet that leads to very immobile posterior mitral leaflet and difficult to clot, particularly in cases in huge inferior infarction. They are attached to the posterior wall with numbers of trabecular muscular bridges or whatsoever. Call it whatever you want. Firstly, I resect the anterior leaflet, or better to say resect the cleft and close it. I'll try to speed it up a little bit. Once I closed the cleft on the anterior leaflet, I tried to close those indentations on the posterior leaflet, which are normal finding of the leaflet necessary for the leaflet to open and to close properly. And at this point, you saw earlier, you found, can you stop the movie for a second? I would like to control the situation, but it's impossible. You saw the water probe when I closed anterior leaflet, cleft and posterior leaflet indentation. We arrived at the point we generally find, ischemic MR, and that were generally the results before putting a smaller ring. And in those two, we have, now
anatomic fine leaflets, but the posterior leaflet is still very, very small, so it will co-opt for some time, even with the reduction, but not last that much. So that's the reason I decided, you can go on with movie, to detach complete posterior leaflet from its annulus attachment. To cut secondary cords, which is not that important on functional MR, although a lot of surgeons think it is. The most important in those cases is to mobilize papillary muscles, to detach those muscular bands that attach the papillary muscle to the wall. So it's like, you see now, it's like you're treating Epstein disease of the tricuspid valve. You have to mobilize it all the way down the apex, and that way you get, you know, leaflet moving, and you put a huge patch. There is no risk of the SAM in those patients because the ventricle is dilated, and on the other side, your stitching line will eat a lot of leaflets. Can you speed it up a little bit? No, it's the end. So can you just, can I control the movie with this? No? Can you go till the end of the movie, but just to show the results of the repair? We are losing time. If you don't find it, they will think I'm lying, so you have to do it. So advance with the movie. Yes, go on. Go on. Okay. Here is a normal ring annulopathy according to the size of the anterior leaflet, no reduction. Here is the water probe, which is not conclusive in those cases because you can't make enough pressure in the left ventricle to make leaflet coapting, and you will see the post-op echo, which is very, very, very important. You see, the anterior leaflet is moving, and the posterior leaflet, this bunch of the posterior leaflet, this one here, is the free margin of the posterior leaflet, and that would be its position without patch enlargement. So that will be, it will be that restricted. With placing a huge patch, you are making, firstly, you're increasing the length of the subvalvular apparatus, you're increasing the pliability of the posterior leaflet, and you're getting very long coaptation line that will last, that will make this repair procedure last for a long time. I know, I got the 2 months ago echo results of this patient. He is still doing well. He's in IHA 1 class, and he has just a trivial MR. So I lost a little time due to technical problems, but generally those are my takeaway message. Just as I said in before session before, don't treat the disease, treat the patient, because there are so many variables in cardiac surgery and in surgery in general, and you have to treat each patient on individual basis. Thank you very much.
Thank you, Ivan, for a wonderful presentation. I was hoping that you are going to exceed your time so I can
stop you, but you were on time regardless of these technical problems. And now we are moving on to the next presentation. It is the role of mechanical circulatory support. Professor Borović, please.
Dear delegates, dear members of the panel, I would like to thank the organizing committee for the opportunity to give this presentation. So, talking about MCS, MVS, I will tell something about from the perspective of the Dedinje Heart Failure Center. This is a specialized unit dealing with those patients with end-stage heart disease, with human and spatial resources allocated to this center specifically. Our portfolio is, as you can see, VA ECMO, Impella 5.5, HeartMate 3, ELVA, Syncardia, TAH, hopefully soon heart transplantation. Nevertheless, one digression, talking about successful revascularization in the patients with reduced ejection fraction. Last week I implanted an ELVA in a female patient. They had 2011 CABG and all 3 grafts were patent. But nevertheless, the patient developed end-stage heart failure. Next week, I'm going to implant one LVAD in a patient that had 20 years ago Lima 2 LAD, which is patent. And also, meanwhile, the patient had stented right coronary artery without in-stent stenosis. So whatever you do, the God says it's going to be end-stage heart failure, it's going to be end-stage heart failure. So we are somewhere in the center of all clinics functioning in our institution. Nevertheless, we are managing on the synergy and interaction and giving the place for the best results we can get. What can we do dealing with the patient with heart failure? Are the acute or chronic heart failure for the service of cardiac surgery or for the service of interventional cardiology? Talking about cardiac surgery, you have, of course, in everyday practice, unacceptable high-risk surgical cases which refuse to be operated on. Also, patients with severe refractory, unfortunately, post-cardiotomic cardiogenic shock, which happens, of course. For the interventional cardiology, we took the part in the creating of the institutional algorithm for high-risk percutaneous coronary intervention, and we are working. This is in the pipeline for the hub-and-spoke referral network. Let me show you a couple of cases. It's going to be more interesting. Like everybody is almost sleeping now, so let's see some interesting stuff in everyday practice. Male patient, you see, relatively young. Intermax 4, the structural heart disease is almost horrible for any decent cardiac surgeon, so the patient obviously was refused for cardiac surgery. And you have also right heart cath results and quantitative echo that showed moderate mitral valve regardless ischemic or chronic or hemodynamic, whatever you want. So what did we do? From the center, the surgeons from the center performed this type of surgery and implanted at the end of the case just to win the patient from the CPB and to support the patient in the following days. Impella 5.5, right subclavian artery graft insertion, which was tunneled subcutaneously. Impella was weaned successfully and explanted on 6th postoperative day, and echo assessment on 48 hours following Impella removal. You can see substantial improvement in the performance of the heart. Nevertheless, this was the first Impella 5.5 implantation in Serbia. Hospital discharge on 11 postoperative day and New York Heart class 1 on follow-up. So this is the patient walking on the third postoperative day. Can you, možda smanjite volumen, ima dosta glasova koji, okay, I will just play the movie. Not my microphone, just, okay. So it looked a little bit shocking for the staff and for the doctors and nurses. You see the third postoperative day, that horrible and complex procedure. The patient was walking. Obviously, it's very convenient to have the monitor, in front of the patient because the patient is not wearing underwear. So this is very convenient place to have the monitor. Nevertheless, the patient is doing very nice. He stopped, and this lady which is a physical therapist, you know, just asking the patient, are you okay? Are you okay? Seriously, are you okay? He says, yes, I'm okay. Let's go on walking. So the patient walked on the third post-operative day with Impella 5.5, so like 4 liters Impella contribution. And you see, everything went well. He had very good support round. You see the numbers there, 4.5 liters on Impella. It's almost 1 cardiac output, cardiac power output, so the pressure is okay. Patient is doing very much fine. He's okay, and convincing the surrounding, I'm doing fine, let's go on walking. What's the matter with you guys? I want to walk. And this is the scenario when the patient was refused for cardiac surgery, and he received the same structural correction, but nevertheless, I will not comment the gaze of this young nurse. Okay, so another clinical scenario where do we have cardiac surgery is the severe refractory post-cardiotomic cardiogenic shock. Our first ECMO run was performed in April 2015. Not for cardiac surgery, it was ECMO-supported VT ablation. It is a real-time issue, so when you go through the literature, it's 0.5 to 1.5%. You should say it's not a big number, but nevertheless consider that we are doing almost 2,500 open heart surgeries per year, so you can expect like 15 to 20 cases. If we go for the last year, we had 19 patients with refractory severe post-cardiotomic cardiogenic shock. We ECMO supported. We developed by the time early liberal institution strategy for this ECMO support, central cannulation, chest closure. We drain both atria just to allow the emptying of the left ventricle, and those results of the weaning maybe look like dramatically low, but nevertheless this is the real life, and I think it is a success rather than a failure. Another way of supporting patients in post-cardiotomic cardiogenic shock is another lady that was implanted Impella 5.5 like recently, a couple of weeks ago. This is the second Impella 5.5 in Serbia and the second one in our institution. You see after the CABG, the pre-op, it was low ejection fraction, recent non-STEMI, nevertheless elective patient, horrible vessels, right coronary occluded, left coronary occluded, circumflex, small calibers, nevertheless, the patient went out of the CPB on multiple inotropes and contrapulsation. Like 3 days after that, the patient crashed because of the VF. There were 2 shocks, converted him to sinus rhythm, but the hemodynamics deteriorated. So we decided to implant 5.5 Impella 4 days. It was needed 4 days after that, CVVHD renal replacement. Like a couple of days, 2 days ago, it was tracheostomy performed, and on 23rd, the no inotropes, no vasopressor, spontaneous diuresis, spontaneous ventilation with a little bit of pressure support, no signs of systemic infection. I had a video clip, but nevertheless, it's not working somehow. I just want to show you how the patient is exercising, moving her arms up and doing a hand grip test. So the patient is doing fine. What about our friends from interventional cardiology? We developed this algorithm, and this is something I just want to show you. This yellow markings is shock team. This is something that actually, as far as I know, occurred for the first time in our country. So we have heart team, it's everywhere, all cardiac surgeries, but somehow we decided to have shock team. And the shock team is composed of cardiac surgeon, anesthesiologist, intensivist, interventional cardiologist. So there is plenty of space for MCS in this arena, and we will see how it's going to be working. Hub and spoke referral network is in the pipeline. We are negotiating with some high-volume national CICUs. There are different scenarios, and you can see also we can offer patients total artificial heart. By the way, we have a huge number of TAHs in cardias implanted, like 15 cases in previous 12 months. So we have 15 Syncardia implanted in previous 12 months, and we have on the shelf, we are lucky hospital that have on the shelf Syncardia total artificial heart. Okay, let's play a little bit future telling. This is my idea. I didn't take this from any kind of presentation. This is my idea as a cardiac surgeon, being cardiac surgeon for almost 26 years, operating almost on every continent as a consultant cardiac surgeon. So year 2040, how do I see cardiac surgery, interventional cardiology year 2040? Myocardial revascularization, interventional cardiology. Aortic and mitral valve procedures. Aortic procedures, they already took it. It's TAVI there. It's almost universally available. Mitral valve, they are spinning up, and all R&Ds spending a lot of money in research, so it's going to be like in a couple of years, mitral valve procedures. Aortic disease, they are stenting everything, so they can do everything, so it's interventional cardiology. But if they have suboptimal vascular access, so we are going to step in and do cardiac surgery. And when they have complications post-percutaneous intervention, they will kindly, humbly ask us to correct the problem, to bail them out, so we are doing cardiac surgery there. And what about end-stage heart failure? I think this is the only area that is going to stay with cardiac surgery. How? It's going to be fully implantable heart pump systems and genetically modified heart xenotransplantation. So mark my words, mark this date, and we will see each other in how many, 18 years, okay? So what to do now? I think the idea is to go hybrid. Share, not dominate. I will say this in Serbian language, da citiram svog prijatelja Željka Bojovića, najvažnija matematička operacija je deljenje. So hybrid procedure, we are going to share part or the whole procedure and to give our best as a team. The only thing is I don't know who is going to be which part of the animal. Nevertheless, this is not 2020 years. Some of you already seen this, but this is the clip from our famous movie, our famous director. I will give the translations for our guests. So this guy is telling medicine, surgery, that is medicine, everything else is destiny. So.
Medicina to je hirurgija, ostalo je sudbina.
Thank you very much.
Thank you, Dr. Borović, for really interesting presentation, and hopefully we are going to see each other in 18 years to see whether you were right or no. Yeah. Okay, now I would like to ask Professor Redžek from Institute for Cardiovascular Diseases Sremska Kamenica to give us an overview of early and long-term outcomes after CABG, please.
Poštovani predsjedavajući, dragi koleginice i kolege, prvo da kažem da mi je veliko zadovoljstvo što sam prisutan na ovom vašem kongresu i čestitam na uspešnoj organizaciji ovog jednodnevnog skupa. Moram da se izvinim u startu, pošto se ovo predavanje odnosi na rezultate hirurške revaskularizacije miokarda i nema direktno veze sa srčanom slabošću, ali moram da kažem da smo analizirali neki moment u odnosu na istisnu frakciju miokarda, tako da leve komore, tako da na neki način malo se zadovoljava i temu ove sesije. Ono što moram da naglasim, da rezultate možemo posmatrati na različite načine. Rezultate možemo posmatrati kroz to kako se pacijent osjeća subjektivno, možemo objektivizovati njegovo stanje kod različite funkcionalne testove, ali ključni moment u evaluaciji pacijenta je kada interventni kardiolozi ponovo stave kateter i oslikaju naše graftove, šta smo mi to uradili i kakva je situacija sa koronarnom cirkulacijom. Pa u ovoj samoj prezentaciji mi smo analizirali naše pacijente koji su reangiografirani, znači ponovo su rađene koronarografije sa graftografijom. Moram da naglasim da to nisu randomizirani pacijenti, to su pacijenti koji su na osnovu pozitivnih funkcionalnih testova ili subjektivnih tegoba ponovo indikovani za rekoronarografiju, tako da u ovoj grupi pacijenata očekujemo najlošije rezultate što se tiče prohodnosti graftova. Sad samo da vidimo ovo je... Kao što vidite ovde, znači radi se o jednoj retrospektivnoj studiji u kojoj smo analizirali 163 pacijenta i posebno smo se ovde osvrnuli na venske graftove, da pokušam kroz ovu prezentaciju da prikažem da li su venski graftovi anatemisani, da li su oni prošlost ili za njih ima i dalje budućnosti. U prethodnim sesiji smo puno toga čuli o tome, a ja ću sad samo proći kratko kroz naše rezultate. Koronarografije su prosečno izvedene nakon 5 i više godina od primarne operacije. Kao što vidite 163 pacijenta, vidite polnu distribuciju pacijenata i vidite koliko pacijenata je dobilo jednostruki, dvostruki, trostruki, četvorostruki i petostruki bypass. Što se tiče graftova, ovde vidite znači, sumarno prikaz da je u ovoj grupi, ponavljam, pacijenata koji su simptomatični, koji su imali pozitivne funkcionalne testove, znači imali smo 37% okludiranih venskih graftova, 51% prohodnih i 18%, odnosno 11% graftova koji su bili prohodni, ali sa značajnom stenozom. Što se tiče broja okludiranih graftova po pacijentu, vidite da kod 62,6% nismo imali okludirane graftove, kod 29,4% smo imali jedan okludiran graft, kod 7,4% 2 okludirana grafta i kod 0,6% pacijenata smo imali 3 okludirana venska grafta. Svima su dobro poznati ranije publikovani rezultati koji ukazuju da što se tiče vene safene, nakon 10 godina 40 do 50% je malfunkcija venskog grafta, 17 do 37% radijalne arterije, 5 do 12% leve mamarije arterije, leve unutrašnje grudne arterije, koja ima privilegiju da je uvek korišćena za revaskurizaciju prednje silazne koronarne arterije, koja je najjača koronarna arterija sa najboljim run-offom. Što se tiče desne unutrašnje grudne arterije, malfunkcija 10 do 35%. Kada posmatramo cirkumfleksu, vidimo da je 30,8% graftova na cirkumfleksi bilo okludirano, 69,2% prohodnih graftova. Kad posmatramo riju, znači 33,7% je bilo, što se tiče rije, znači 33,7% imamo graftova na riji, 18,9% okludiranih i 81,1% prohodnih, iako posmatramo desnu koronarnu arteriju, 25,2% okludiranih i 74,8% prohodnih. Razmišljali smo i razmatrali smo različite parametre kod ovih pacijenata. Ovde vidite da vreme od operacije do graftografije nema statistički značajno razlike između prohodnih i okludiranih graftova. Što se tiče, merili smo i periferiju nakon mesta kreiranja anastomoze, što se tiče preoperativne koronografije, i tu nismo dobili statistički značajnu razliku. Dobili smo statistički značajnu razliku u odnosu na dijametar koronarne arterije od mesta anastomoze pa distalno. Dobili smo statistički značajnu grupu između prohodnih i okludiranih graftova u odnosu na vrednosti triglicerida. Nismo dobili statistički značajnu razliku u odnosu na ekcijnu frakciju, godine i body mass index pacijenta. Ovo su potvrdili i brojni publikovani radovi. Jedan od njih pokazuje da je dijametar koronarne arterije na mestu anastomoze ima značajan uticaj na prohodnost graftova. Što se tiče samog grafta na cirkumfleksiji, ako posmatramo ove iste parametre o kojima sam malo pre govorio, kod cirkumfleksa je samo nivo triglicerida pokazao statistički značajan uticaj na dugoročnu prohodnost grafta. Što se tiče rije, dijametar distalnog dela koronarne arterije, odnosno dijametar na mestu anastomoze. Ako posmatramo druge parametre koji se odnose na prohodnost cirkumflekse i prednje silazne arterije, odnosno venskog grafta na cirkumfleksi i prednje silaznoj arteriji, tu vidimo da nemamo statistički značajnu razliku između prohodnih i okludiranih graftova u odnosu na sve ove parametre koje vidite. Ono što je mene lično iznenadilo da nema statističke značajne razlike i u odnosu na TIMI flow, s obzirom na odgovarajući uticaj kompetitivnog flowa, to se odnosi i na graftove na cirkumfleksiji i na prednjoj silaznoj arteriji. Kada posmatramo graftove koji su korišćeni za revaskurizaciju desne koronarne arterije, u odnosu na ove parametre koje sam vam govorio, također nije nađena statistički značajna razlika. Kada posmatramo desnu koronarnu arteriju, također u odnosu na TIMI flow nije nađena razlika između prohodnih i okludiranih graftova. Ovde su sad prikazani intraoperativni parametri koji su izvučeni iz operativnog protokola, gde vidite kada posmatramo i poredimo okludirane i prohodne graftove, da je opisan kvalitet vene kao optimalan, odnosno nema statistički značajne razlike, znači između venskih graftova koji su opisani kao optimalni i oni koji su imali odgovarajuće promene zida ili varikozne promene. Što se tiče dijametra vene, takođe nije pokazao statistički značajnu razliku, a to se odnosi i na intraoperativno verifikovan dijametar periferijom. Ako posmatramo ove iste parametre u odnosu na prednju silaznu arteriju, u odnosu na desnu koronarnu arteriju, takođe nisu nađene statistički značajne razlike. I sada kao zaključak ove prezentacije, odnosno zaključak da nema zaključka, je prikaz ovog pacijenta koji je operisan od strane iskusnog hirurga sa velikim brojem ranijih koronarnih operacija, gde vidimo da nakon 10 godina od operativnog zahvata, znači mi imamo okludiranu mamariju i imamo prohodne venske graftove, znači u gornjem levom uglu vam je prikazan nalaz preoperativne koronarografije. S druge strane, imate ovog pacijenta koji je operisan, znači ove koronarografije, nakon 14 godina od samog operativnog zahvata, gde imate praktično prohodne venske graftove bez znakova neke arterijalizacije ili klasične bolesti venskog grafta sa izdašnom vaskularizacijom periferije nakon 14 godina od operacije. I ovo nas zaista stavlja u razmišljanje, znači šta je tu ključni moment oko dugoročke prohodnosti grafta. Na ranijoj sesiji smo dugo i puno pričali o tome i slušali različite ideje i publikovane radove koji ukazuju na prednost jedne, druge tehnike i tako dalje. Verovatno u svemu se nalazi malo istine, ali pravi zaključak još uvek nemamo. Hvala na pažnju.
Thank you so much for your presentation. And the last talk of the day and for the conference will be given by Professor Dragana Šarenac on advances to enhance recovery after cardiac surgery.
Poštovane koleginice i kolege, čast mi je zadovoljstvo da održim danas predavanje ovdje. Zahvaljujem se organizatoru na pozivu. Ja ću svoju prezentaciju početi sa prikazom slučaja jedne pacijentkinje stare 75 godina koja je primljena zbog trosudovne koronarne bolesti, koja navodi da se zamara posljednja 3 meseca, da ima anginozne bolove već pri minimalnom naporu, hipertenziju 14 godina, dijabetes mellitus na oralnim antiglikemicima, sa minimalnim neurološkim deficitom nakon preleženog cerebrovaskularnog insulta, kreće se uz pomoć hodalice, renalna insuficijencija blažeg stepena, anemija i ekciona frakcija 40%. Računajući Euroskor kod ove pacijentkinje, Euroskor 2 koji predviđa mortalitet, vidimo da se on kreće od 1,94 do 2,45%, zavisno od toga kako se definiše pure mobility, odnosno loša pokretljivost bolesnice, definisana kao nepokretljivost odnosno slaba pokretljivost usled muskuloskeletnog oboljenja ili usled neurološkog deficita. Međutim, kakav je bio tok u bolničkim uslovima? Urađen trostruki aortokoronarni bajpas, sve je proteklo u redu, međutim drugog postoperativnog dana razvija se delirium koji traje negde nekih 5 dana. Iz tog razloga rehabilitacioni napori su značajno usporeni. Pacijentkinja je u krevetu već 7 dana na farmakološkoj terapiji usled prisutnog delirijuma, a pored toga je prisutna i ograničena funkcionalna aktivnost preoperativno i smanjena pokretljivost, odnosno bolesnica se kreće uz pomoć hodalice. Razvilo se akutno bubrežno oštećenje i sve to rezultiralo u bolničkim uslovima od 40 dana. Postavlja se pitanje da li mi mislimo da li je ova pacijentkinja imala dobar ishod ili je taj ishod ipak nezadovoljavajući. Došao je moment za odlazak kući, shvatili smo da pacijentkinja živi sama, samim tim ne može da ide u kućne uslove usled lošeg funkcionalnog kapaciteta, slabije pokretljivosti, tako da je pacijentkinja primljena i prevedena u drugu bolnicu. Retrogradno posmatrano, da li bismo se odlučili za ovakav pristup ovoj bolesnici i hirurško lečenje i pre nego što je otišla na operativno lečenje, da li bi išla na otvorenu hiruršku proceduru ili možda neki drugi način i da li ukoliko bolesnik izađe živ iz bolnice, da li je to u stvari uspeh koji smo trebali da postignemo. I upravo preporuke za perioperativno lečenje kardiohiruškog bolesnika podrazumevaju i obuhvataju enhanced recovery after cardiac surgery, odnosno multimodalni put koji je zasnovan na redukciji pre svega stresa odgovora na hirušku intervenciju, obzirom da stres odgovor je povezan sa morbiditetom i mortalitetom i on može biti redukovan kako izborom anestezije, tako i minimalno invazivnom hiruškom intervencijom, odnosno farmakološkom modifikacijom inflamatornog odgovora. Zatim podrška fizioloških funkcija samog bolesnika i ubrzano vraćanje normalnim dnevnim aktivnostima. Koncept nije nov, fast track hirurgija, poznato još iz 90. godina prošlog veka, kada se govorilo pre svega o ranoj ekstubaciji bolesnika i multimodalnoj analgeziji, a onda je taj princip proširen, tako da je uključena i preoperativna edukacija bolesnika, rana rehabilitacija, rani otpust bolesnika iz bolničkih uslova uz prevenciju postoperativne mučnine i povraćanja. I upravo 16 hirurga, anestezijologa, intenzivista, kardiologa i drugih specijalista se sastalo i dali su 22 moguće elementa koje treba uključiti u različite faze lečenja, preoperativno, intraoperativno i postoperativno, i to od preoperativne edukacije bolesnika koja treba da započne i mesecima preoperacije, preoperativnu pripremu, intraoperativni deo do momenta odlaska kući, rane rehabilitacije i kontrolnog pregleda nakon mesec dana. I upravo to kao multimodalni, multidisciplinarni pristup bolesniku zasnovan na dokazima u cilju optimizacije perioperativnog lečenja i boljih rezultata. Nekoliko elemenata je uključeno u preoperativni deo koji se odnosi na poboljšanje ishoda u okviru RX protokola, pri čemu jedino zasnovano i predstavlja jaku preporuku jeste prekid pušenja i uzimanje alkohola bar mesec dana pre operacije, što je udruženo sa značajno nižom incidencom infekcije i perioperativnog morbiditeta. Ali nivo 2A preporuke je i perioperativna, odnosno preoperativna kontrola glikemije i analiza glikoliziranog hemoglobina koji ukoliko je preoperativno niži od 6,5% ukazuje na bolji ishod kod bolesnika uz korekciju nutritivnog deficita, pri čemu ukoliko je nivo hemoglobina niži od 30 udržane sa značajno većim morbiditetom bolesnika nakon kardiohiruške operacije, tako da 7 do 10 dana korekcije nutritivnog statusa poboljšava ishod. Svakako nema randomizovanih studija i studija koje govore da li je potrebno odlagati hirušku intervenciju radi korekcije navedenih parametara, ali su svakako parametri koje treba korigovati ukoliko postoji dovoljno vremena i ukoliko status bolesnika dozvoljava. Zatim, izbjegavanje prolongiranog gladovanja i unošenje ugljenohidratnih rastvora je nivo 2B preporuka, što bi podrazumevalo da bolesnik 2 sata pre ulaska u salu treba da uzima bistre tečnosti, 6 sati lagani obrok, da je ugljenohidratni unos 2 sata pre ulaska u salu povezan sa povećanom osetljivošću na insulin, na smanjenim efektom kataboličkih hormona i samim tim niži stres odgovor na hirušku intervenciju i bolji ishod bolesnika. I ovdje se navodi prehabilitacija kao preporuka umerenog stepena 2A, koja zapravo podrazumeva i obuhvata 3 komponente po principu nju, što bi značilo nutriciju, exercise and worry sniženje. Drugim rečima, poboljšanje nutritivnog statusa bolesnika, umerena fizička aktivnost preoperativno i smanjenje zabrinutosti i straha koji vlada kod bolesnika, svi zajedno doprinose višem funkcionalnom kapacitetu bolesnika i boljem prolasku kroz stres indukovan hiruškom intervencijom, a samim tim, kao što se vidi na grafikonu, i bržem oporavku ovih bolesnika. Intraoperativno postoji nekoliko parametara gde ću izdvojiti antifibrinolitike koji su jaka preporuka u okviru patient blood managementa koji zapravo prevazilazi okvire samo RX protokola jer podrazumeva i preoperativnu korekciju anemije, koagulacioni management i monitoring tokom perioperativnog perioda i to sve u cilju redukcije primene alogene transfuzije koja je povezana sa značajnim neželjenim efektima, kao i snop mera koji je uključen u redukciju infekcije hiruškog mesta i koji podrazumeva ne samo preoperativnu primjenu mupirocina u cilju eradikacije Staphylococcus aureusa koji je prisutan kod oko 30% bolesnika, regularnu primjenu profilaktičkih antibiotika do 30 do 60 minuta pre hiruškog reza i tokom 48 sati perioperativno, kao i hlorheksidin u smislu kupanja bolesnika. Izbjegavanje hipertermije, odnosno tokom vantelesnog krvotoka, temperatura preko 37,9 je udružena sa značajnim neurološkim neželjenim efektima, kognitivnim deficitom, delirijumom, povišenom incidencom koagulacionih poremećaja. Postoperativno nekoliko elemenata takođe uključeno, ovdje već vidimo da postoperativno više elemenata je jaka preporuka i obuhvata izbjegavanje hipotermije, održavanjem otvorenih drenažnih drenova zapravo za evakuaciju krvi i sniženje incidence nastanka pleuralnog, odnosno perikardnog izliva, zatim screening za nastanak delirijuma, kontrola glikemije i ciljano vođena terapija tečnošću, inotropima i vazopresorima u cilju postizanja određenih vrednosti hemodinamskih parametara, bilo da je to arterijski krvni pritisak, minutni volumen srca, saturacija mešane venske krvi i svakako multimodalna analgezija predstavlja značajnu komponentu preoperativnog, intraoperativnog kao i postoperativnog snopa svih ovih navedenih elemenata. Jedna od studija publikovana pre 3 godine je uključila zapravo većinu ovih elemenata RX protokola, publikovana i urađena u Severnoj Americi, je pokazala da je 15 sati skraćena dužina lečenja u jedinici intenzivnog lečenja nakon primenjenih ovih mera, da je skraćena dužina bolničkog lečenja za 1 dan, a da pritom je kod značajno većeg broja bolesnika 2 do 3 puta više u odnosu na standardne baze podataka bilo prisutno bolesnika sa moždanim udarom, odnosno primenjena intraortalna balon pumpa, govoreći o tome da ne samo rana ekstubacija bolesnika, već i proaktivni stav u isključenju inotropne presorne terapije i uklanjanju intraortalne balon pumpe doprinosi nižem morbiditetu i bržem otpustu bolesnika. I ovdje treba spomenuti upravo da zbir nekih malih promjena i sve to bazirano na istaknutim rezultatima britanskog trenera biciklizma koji je sa svojom ekipom postigao zapažene rezultate na olimpijskim igrama i sve to da zapravo minimalne promjene u različitim segmentima po 1% doprinose i promjenama u hiruškim intervencijama, uključujući kardiohirurgiju sa poboljšanjem ishoda i nižom incidencom komplikacija. Svakako postoje barijere za implementaciju jer zapravo je cela ideja poprilično stara, ali se sporo uvodi iz razloga što postoje problemi vezani za samog pacijenta, prevelike želje, značajne komorbiditeti, zatim osoblje koje je uključeno u lečenje, neophodnost čitanja, upoznavanja, učenja i napuštanje tradicionalnih starih pristupa uz naravno sam sistem i da je neophodno pratiti svoje rezultate i analizirati zavisno od dobijenih rezultata, korigovati svaki od navedenih elemenata. U zaključku, enhanced recovery, odnosno ubrzani oporavak nakon kardiohirurgije, nije novi koncept, podrazumeva zbir intervencija koje mogu da rezultiraju u promjenu ishoda. Neophodno je da se individualno posmatra svaki bolesnik, da su barijere za implementaciju moguće, ali da svakako treba primeniti protokol iz razloga što je terapija dizajnirana da napravi i da zapravo učini život mnogo boljim i da se produži životni vek. Hvala na pažnji.
So, do we have time for a few questions?
Yeah, maybe we can have 1 or 2.
Okay. So, Anders, I have a question for you, actually, because if if I remember correctly, in Stitch, myocardial viability was not a predictor of survival, right? But still, there are studies that show that if you revascularize those regions that are classified as non-viable, you, in 1/3 of patients, I think, do have increased contractility and improvement of left ventricular function. So my question is, do you require viability testing for Stitch Sweetheart? Do you know if the other national trial parts require viability testing, and do you think that this may impact the meta-analytic outcome of mortality?
First, can you hear me? No? Oh, you can hear me, but okay. You're right. In Stitch 3, the first study, viability testing was not associated with better outcome. I mean, patients who showed viability, it was not total better outcome, but that was a small sub-study. We are not requiring functional testing in Sweetheart, in Stitch 3 Sweetheart, and I'm not 100% sure, but I do not think that they require it in maybe Milan knows. No.
There is no requirement.
Mm.
Do our cardiologists have any questions?
So maybe I can just one short question for Professor Stojanović, and keep in mind this is a cardiologist who is asking. So, what would be the reasons for you for when having patients with severe MR, ischemic severe MR, and not to perform mitral repair, but to switch to the mitral valve replacement? So, what would be the main reasons for that?
The main reason is to repair the valve. So maybe the better question is how to arrive to the point not to choose the mitral replacement instead of mitral repair. Once you have a patient like this is a demanding procedure, of course. In the experience, it's sometimes very hidden. It's not that visible. Once we have a patient, you can, let's say, easily do it, the procedure. You can go on. You can go on. It's time consuming, but you will succeed. For example, if you have a patient that is not, the valve that is not visible, you cannot afford, additional time to replace the valve, because both procedure will be time consuming and your heart protection will not be enough. So in those patients, you have to, as I said, measure and take in mind all those variables before deciding what to do. And that's the main reason I decided to go on mitral valve repair on him. It is difficult to repair the valve when you have fibrotic papillary muscle. I never even tried to repair the valve. But when you have a young patient with a visible mitral valve repair, mitral valve that allows us even to make with the repair and do a quick mitral valve replacement, yes, I would prefer any time to go on with the repair.
Oh, perfect. You have a question?
Please allow me just to make a comment to what you just said. I know you're a great mitral valve repair surgeon, which is fantastic, but for the rest of the world, it's so you have a patient with ischemic cardiomyopathy. He is a very sick patient. You want to make a short operation upon this patient, and also the redo is very high if you have a repair, mitral valve repair. This was shown in Circulation by Joe Wu from Stanford, and he has analyzed all the Californian patients. So what I mean is, I think that he can do it, but your question was more, what do we do with a sick patient? Because the alternative therapy is, of course, MitraClip. And I thought you would ask about this. But I think, so in a very sick patient, you should do it really a fast operation, which is with 100% technically perfect results. Maybe some people can do it with repair, but as I said, the redo rate is very high, And I personally did always a mitral valve replacement in order to get him over the post-operative period. And therefore also the last talk, I think, was fantastic, because we as surgeons have the most problem with the early post-operative phase, in my view. The techniques are already perfect. I mean, our grafts are fine, repair in other patient population is fine. So our techniques itself are very good, but we are bad in the early post-operative phase, and that was shown in all these slides. On the long run, surgery is always better, but in the short run, we have a dip, and this is not okay, and we have to work on that.
The technique with this patch enlargement is something that just prevent what you are be worrying of. Because we got sometimes patients that get severely decompensated after surgery, but they never got residual MR because of this, the bad heart. I agree completely with you. It's not a reproducible technique. It is difficult, but as a Carpentier student, the first time I learned on him is when you start learning or doing mitral valve repair, the first thing you have to do is to quickly replace the valve. So it's a very important question, really. And for example, mitral clip costs how much? 30,000, 35,000 euros. It's not affordable, you know. On each and every meeting like this, so we are talking about, you know, very expensive procedure, high-tech medicine, and nobody asked from people, from the audience, from everybody in this room, how many countries in the world could afford something we are talking about? It is not possible. For example, we in Serbia cannot afford, we can afford, but we cannot buy PTFE course here. We cannot. So we developed very, very successful mitral, high volume mitral repair program without artificial cores. Artificial cores are tiny amount of money, but imagine how other things, you know, the modern medicine and modern industry is offering, and how much is, for example, Serbia is spending about $500 per capita on health insurance. In Western Europe, I think it's around 6,000 to 8,000. In US, it's 10,000. So we developed, and we are very proud, a successful medicine here in Serbia on low budget. And that's some congress and some, you know, future discussion should be not for the elite medicine, from technical point, from money point of view, but to medicine that could help people who don't have enough money to treat their inhabitants. Thank you.
Great. I think your point is well taken.
And in my most modest opinion, the best mitral clip is Alfieri stitch.
Of course, but it's still increasing in numbers like crazy all over the world, despite the high price.
Yeah, of course it is, but we are talking just about the situation when you are in the middle of the case, when you realize that, let's say, you did 3 or 4 grafts already and the time is running and you are a little bit sweating, you know, and your exposure is not ideal, and you know that you have to do something with your mitral valve and you don't have money for the mitral clip, then you do Alfieri.
Yeah, of course.
Yeah. It's better than more, how to say, it's more safe, because you can always add something, control something, you know, during the procedure, or eventually change the valve after all. But, you know, if you're concerned about the time, just forget about it.
And being concerned about the time, I think we'll close this session. Thank you, everyone, and for your great presentations. And we will hand over the stage to the organizers.
Well, now this is at the end. I want to ask Milan Milojević to say a few words.
Yeah, I will just start, and then I will give floor first to Professor Beyersdorf, and then Professor Mićović to close this, I think, very successful conference. I want all of you again to thank for being here today. I think all together we made our learning objectives finalized, and I think that all of us learned something today. And I wish you safe back home whenever you go, all around Europe, even in Belgrade. Sometimes can be quite dangerous in the traffic. So I'm joking. I just want to say that I really would like to see you the next year. I think this is only the good beginning. We need to continue working hard on the development of this conference, and it will be great pleasure and privilege to seeing you all again at this conference. Thank you very much. Now, Professor Beyersdorf can say something.
Well, I would also like to thank all of you for this really wonderful day about coronary artery surgery. I thank all the organizers for bringing this program together. I think all aspects have been touched, and I'm sure everybody has learned something. Everybody has also learned what we do not know, which is also very important. And I wish you much success with this series, and I'm looking forward already for the next year, for the next inaugural summit. So thank you very much.
Thank you. Ladies and gentlemen, dear colleagues, I will now be more official. First, I wish to congratulate all presenters, moderators, and panelists for extraordinary presentations and discussion. It was a privilege to be a part of this meeting. I want to thank all the guests from abroad for being today with us, all the experts, distinguished experts in the field of cardiovascular medicine, for taking part of this meeting and to share your knowledge with us. I hope you are having a good time in Belgrade. Society of Cardiovascular Surgeons will continue to work hardly and to try to collaborate with EACTS even more in the future. I want to thank all participants for staying with us and actively participate. And at the end, I want to thank the students and volunteers for being today with us and for helping us in organizing this nice meeting. I can say that this meeting was very scientific and really exceeded my expectations with quality of presentations and discussion. I will now officially close today's meeting. We hope this is going to be just the first one in a row. And now I can announce officially that we are going to organize 2 meetings next year, and you are all welcome. First one during spring will be regarding aortic valve disease from childhood till elderly age. And the next one will be second coronary summit during autumn time. Now I will officially close this meeting, and I'm kindly ask you all to attend the cocktail party in the room next to this one. Once more, congratulate you all and wish you all the best. Thank you.